this, I think after 2 days, we gave the post-test again, and opinions of the students was taken. The results, there was a significant difference between the pre-test and post-test average of the scores of the geriatric attitude scale. And so definitely there was a change in attitude of the students. Apart from that, the opinion of students also was taken. They agreed that there was it was innovative learning. They found it interesting. And most of them felt empathy and compassion for both the elderly as well as the caregivers. And all of them also appreciated the psychosocial aspects of elderly care. And about half of them felt that they had achieved concept clarity. Now, these were two important methods that we used to bring about change in the students' attitude, and definitely it did have a very good effect on the students' attitude to both the elderly and to the communication challenged. Now, one more thing I'd like to, this is something that I really like, reflection. And so reflection by Gibbs and then updated by Bullman in 2012. Now, one way I used this method was, there was a group of postgraduate students, and one of them had committed a near-miss medication error, and incident had happened. And how we went about using reflections to bring about change in their attitudes was, the student who committed, she almost gave a wrong medication in the casualty. But before that, before the medication could be given, somebody senior noted it, and it was aborted. So the student felt extremely bad. She was already a registered nurse, so this shouldn't have happened. So she was feeling pretty bad about it. So she kind of was hesitating, but then eventually she came around and she agreed to have a discussion in front of the whole class. So she went through the reflection, the reflective cycle, and we encouraged each of the participants in the group also to do the same, to go through the steps of the reflective cycle. And at the end of it, we shared our outcomes. We shared our conclusions we had come to, and it was all the same. Most of us felt the same things, and even the strategies that were decided were all similar. So that was one really very good outcome. So it is possible to bring about attitudinal change. We need to extend ourselves a bit and put on our thinking hats so that students will benefit more. So I think that's it. I'm open for discussion and questions.
Yes. Yes. Any questions to Professor Vilma Valsalan? Just if you have any questions, you can text in chat box. We'll be asking of you even after the completion of the conference. I think no more questions, madam. Thank you very much, madam, for participating in this event. Thanks for sharing your tips with us. Looking forward to meet again next time. Yes, just we have got a comments from Professor Catherine. Thank you for engaging presentation. From Dr. Edil also, thank you. Next we asked Dr. Avazian Rawaz from King Saudi bin Abdulaziz University from Health Sciences from Saudi Arabia to start the presentation. The topic will be the comparison of undergraduate nursing students' satisfaction in flipped classes, active lecture class, ALC, and traditional lecturers classes, that is TLC. You can start your presentation, madam.
Hi everyone, good afternoon. I'm Dr. Hawaz Rawaz. Are you hearing me?
It's fine, madam. You can continue.
Okay, from King Saud bin Abdulaziz University for Health Science, and today I'm presenting one of the important topic. I think I use it nowadays with the COVID, because this was before the COVID. It was to compare the nursing student satisfaction with the flipped class, active lecture class, and traditional class. I cannot move the slide. Yes, so the content for the day, it will be including the introduction, literature review, aim, method, result, then the discussion, and finally the conclusion, and if you have any questions. So for the introduction, in the recent years, as we all know, the different education approach have been broadly applied to the nursing courses. However, a comparison between these approach or the satisfaction for the student has not been conduct, especially in my area or my institution. So I use three kind of educational approach: the flipped class, which is simply can be described as opposite as to the traditional education. So essentially that have traditionally taken place inside the classroom, now it's taking out the classroom. So everything that we give it to the student in the classroom, in the flipped class, we give it outside the class. And I will explain it more later on. The student, they have the full responsibility to acquire all the knowledge in the flipped class, which is highly engaging and interactive learning model. So the instruction approach of the flipped class, it's a diverse and maybe include individual, or the activity it will be as a group for the student. And the learning resources may comprise of the video, tutorial, textbooks. All of these can be sent to the student before the class. And the previous studies show how the flipped class it's effectively when it's employed to the courses level, and how the student grade will be higher than the traditional class. The traditional lecture class involves the deductive lecture without any active involvement of the student in the learning process, and the traditional lecture may involve the audio-visual support to the lecture. The traditional lecture class model, it's most commonly utilized in the teaching model for the nursing course. And the active learning class, this is the third approach that I use, involve in-class discussion with the student, between them and with the instructor or the peers. It can be effectively infused in the class with the large number. If we have a large number of the student, we can use this approach. This approach or this strategy to teach the nursing student, it shows how it's effectively, and its result in the improvement in the grade of the student. So what is the aim of my study? It was like I aim to compare the flipped classroom with the active learning classroom and the traditional classroom, and also to assess how the students satisfy with these three models. So in the beginning of the semester, I have to teach the course medical surgical nursing. So during the orientation for this course for the first time, I already take the approval for the student to be part of this study. And then I explain the three modules for the student. For the flipped class learning process, explain it to the student and how they will be engaged in this one. So all the learning resources was sent to the student before the lecture through the Blackboard, the system for the university, for the teaching university. So I sent all the material for them, and they have to come prepared, and they explain it to me what they understand based on the video and the material and syllabus that attached for them. In the class activity, it's inactive class, so they have also the material in the blackboard, but when they are coming to the class, they have to discuss it with each other. I divide them into equal group, the student, so they have, when I ask question, they have to discuss it first based on what they read at home, what they watch at home from the video, and after that they can give me one answer from the group. But the traditional one, of course, as what usually do in the university, I come to the class, I prepare everything, I give them all the information. Then after that, when I conduct the 3 modules with them, with the 3 different lecture, I ask them to complete this, the survey in the beginning, and also in the end of the course, I ask them to fill all the survey. The first part of the survey, it was talking about their characteristic, about the marital status, about their previous GPA. The second part, it was related to their satisfaction and preference in terms of the teaching method. The survey was conducted within the premises of the college, and the convenience sample technique was used with a small number of students registered in the course. So the number of students were 206 students participate in this study, and the survey was analyzed by using the SPSS software. The result, the mean age for the study participant was 22 years, 0.1 plus or minus 2 years. Marital status of the participant, there is a differences between satisfied and unsatisfied students were significant with the traditional lecture classroom, and the large number of the married students prefer traditional lecture over the flip class or the active class. I think with their time, because they don't have time at home to watch the video and to prepare for the lecture. That's why a large number of the married, they prefer the traditional. I'm doing everything for them. I prepare the lecture and they are coming just to listen for the lecture. For the residual status for them, there are also differences between satisfied and unsatisfied students were significant. A large number from the students who living in the Royal prefer flip class over the traditional and the active class. Regarding their previous GPA score, the differences between the student are significant. The student prefer a flip class over the active class and the traditional class, whereas the large number of students prefer a flip class over the other teaching method. And this is for you if you want like to have more details about the result. So this study showed that the more students who were married prefer a traditional lecture format than the flipped class or the active class. It also shown that the previous study that the nursing student don't easily welcome a new teaching method, and this study also support the finding and reporting in similar study. The differences between satisfied and unsatisfied students were significant in the traditional lecture among those who are living in the rural and the urban regions. Our study has shown that a large number of the rural residents prefer flip class over the traditional or the active class, and the differences between the two residents was significant. The finding is different than the previous study, so we have a little bit of the differences regarding the result of the student. The student with the higher GPA, obviously they prefer the flip class in the large number. The finding also added to the already reported result from the different study in different area of the world. So it was revealed that with the group of students divided based on the differences in self-study hour, the differences between the student preferring the flipped class over the traditional or the active class was significant, where a large number of students prefer flipped class over other teaching methods. So I conclude my study that the student satisfaction with the flipped learning a classroom, traditional and active, different based on their social and where they are living, as well as their study habits, how many hours they spend to study, if they have the speed for the internet. So all of these, it was a factor that affect their satisfaction regarding the best teaching method they can use. So do you have any questions for me?
Yes, ma'am. Any questions? Any questions to Dr. Avazen Rivas? Just if you have any questions, you can text in chat box. Will be asking behalf of you.
Okay, thank you, everyone.
Yes, ma'am. Actually, according to our scientific program, Professor Hardeep Kaur need to join the event and start presentation around 4:20 to 4:40. Due to her delay, we are getting 20 minutes delay of the program. Please apologize, as she cannot manage the time. She'll be joining late by 7:30 evening according to EDT timings. Just we are around 15 minutes delay of the program. Hope you understand, everybody. Next we asked Dr. Kawthir Abdul Khalik from Almonoti from Adam General Hospital from Saudi Arabia. If you are in Zoom meeting, just you can join the meeting and start presentation. If not, we request Dr. Kia Mismingi from Right Health University from UAE, you can start your presentation if you are in Zoom meeting. Just we are in 15 minutes delay of the program, actual delay of the program.
We don't prepare my thing.
Yes, doctor. Sorry, is there anybody with your PowerPoint? You can start your presentation. As just we are around 20 minutes delay of the program. Yes, madam, you can call. We can continue. Dr. Hedel, you can start your presentation if you are ready. Yes, madam, you can. Dr. Edel, you can start your presentation if you are ready. You can start sharing your presentation. Due to Professor Hardeep Kaur, we are delay of the program. Actually, we will be running according to the program.
Good morning, can you hear me?
You can continue.
Can you hear me?
Yes, yes, it's fine. You can continue your talk.
Wonderful. Okay, brilliant. Thank you. Good morning, everybody. Sorry about that. I am ready, I promise. I just wasn't expecting to present at this time. So good morning, everybody. Thank you very much for having me here. I'm absolutely delighted to be at this conference and listening to such innovation and great ideas which link in with what I'm going to present today. So thank you very much. My name is Idel Mattox, and I am the program leader for a blended learning program at the University of Sunderland in the UK. And I'm absolutely delighted to come here today to present to you. So we started our program, our blended learning nurse education, in May of this year, May 2022, 2021 even, sorry. And so who would have thought that pre-registration nurse education would have gone online? Certainly, this is what I remember from my education. Most of us will have similar experiences. Who would have thought that we could go online? Well, the University of Sunderland in the UK did. How did this happen? Well, we think that the stars were aligned. We were ready. So our Nursing and Midwifery Council standards, so our NMC is our regulatory body in the UK, and in 2018 they had reviewed and released our new standards of education, which allowed us to progress into a blended learning format. The government had required an increase in nursing staff numbers, which is, an ongoing problem, but we needed to be creative and innovative. Our Health Education England had funding and money to support this. And the University of Sunderland was ready. And then COVID-19 hit. So I have to tell you that we had planned our blended learning program before COVID-19, but the timing was perfect. It was like a perfect storm. So when the UK government target for recruiting 50,000 additional nurses and 26,000 additional primary care workers by 2025, we had to think quickly. How are we going to do this? How are we going to be innovative? So the blended learning approach seemed a way forward for us. It helps to develop a 21st century nursing workforce that is digitally competent, agile, and enthusiastic about change. I'm likening it to the Patricia Benner model, where we're working with novices and we want to make them into experts. Blended learning students have access to new emerging technologies. And this will help students and their employers meet the requirement for strong digital capabilities. There's a concept of growing your own, attracting local people to work locally. And the University of Sunderland has been chosen specifically because it has the ability to provide high-tech learning environments on campus, and students get clinical experience close to home. For those who have skills and aptitude to nurse, but whose current situation doesn't allow them to study in the traditional way, perhaps due to caring commitments, physical access, or other barriers to study, a blended approach could be the answer. Everybody likes the flexibility of the blended approach. So what does it look like? So our full-time program at level 6, which is our degree level in the UK, is for this year, we're just running the adult nursing blended nursing program. It's full-time for 3 years. We have 6 modules in year 1 and 2, 5 modules in year 3, And that helps us to meet the requirements for the NMC, our regulatory body, of 2,300 theory hours and 2,300 practice hours. We actually have 32 hours per week using theory, practice, and simulation. It's combined. Placements are for 16 weeks. Practice clinical placements are for 16 weeks. I don't know what I can hear. So, and there's 24 hours per week. They are in their placement, but we combine that with a 7-hour theory online session every week, even whilst they're on placement. We also run a part-time course over 5 years, still at level 6, and it's almost pro rata hours. So they have students have 22 hours per week at theory, practice, and simulation. They have placements for 24 weeks, and they have 18 hours per week with 4 hours of theory per week. So it's just an easier way for some people to do finish their learning. So in all, students have 22 hours of synchronous learning, 52 hours of asynchronous learning. That's linked with simulation. They have 26 hours on placement and 9% of alternative placement. Now, all the mathematicians in the room will be calculating this as 109%. And the reason is that this last 9% alternative placement is actually combined with their placement hours. That is combined in with their 26 hours of placement. It's just, we wanted people to understand that this alternative placement happened. And the alternative placement is our non-traditional placements for nurses, such as police forces, prisons, areas where nurses do work, but we often don't send them on placement to learn those skills. But in this program, we will. So how did this all come about? We consulted with as many stakeholders as we could, and our patient care and patient involvement is a requirement for all our programs in the UK. So we have a patient group and their carers. We asked students, we asked the trusts, and we asked the academic staff. And what happened was we got the answers that it felt family friendly, the teaching times were useful, candidates or students could manage their study and home life and work part-time if they wanted to. And the placements liked it because there was a reduced number of placement hours from the traditional 37 to 25, and had that 7 hours of simulation with us in each week. So they liked that. And also that took that burden of teaching clinical simulation away to some extent. So because they didn't need to do that in the clinical placement, we were doing it in the university. It felt a natural thing for the clinical placement to agree to. And there are multiple entry points, and they're not at the traditional September and April times. We have May and January entry points, and throughout the year, in fact. And the timings for placement helps them to avoid bottlenecks and gaps in placement resources. So this is just a picture of our students in their uniforms meeting their patients in a simulated session. So I mentioned our patient carers, and our patient care and public involvement in healthcare related degree courses is an essential in terms of developing the knowledge, understanding and skills of students, as well as being a prerequisite for accreditation from our professional bodies and potential funding from external organisations. We consider our PCPI participants as members of the team within the Faculty of Health Science and Wellbeing. And by that, I mean they help us in developing the curriculum, they give us feedback, they help us develop sessions, they help us write scenarios. So they're a huge part of our team, and honestly, we couldn't do without them.
How friendly all staff work. There's always somebody willing to help you when you ask ask a question, even if the question is not directed to them. Having dyslexia, the support that was offered in my interview and told me about was absolutely amazing. The tutors are brilliant, they're very supportive. We are having staying at ease and confidence. The facilities are as well, which many universities. While the students are here, they build a massive rapport with their tutors. They have a personal tutor, they have a clinical link tutor, they have access to the programme leader, to myself as the team leader. They're invited to all of our pre-reg meetings. They are really part of the programme and they get involved with everything that we do. Towards the university extended fantastic facilities, there are some land and they have PC pads to take with cafe and things like that. So definitely not like health skills.
We are acting as patients trying to simulate the various rules that we're given at any one particular time.
When we get the code, we're able to come straight away. It's really good. So we've been great. The living lab, the water chapter, the ambulance provides a great learning opportunity.
It actually feels like it's a real situation, so you're able to practice and get more comfortable, so that when you're in a real life situation, you're not as nervous or as anxious.
I would summarize my time here at the university to learn this lecture. It felt like from day one, and everybody in the cohort was a family.
Fantastic.
Brilliant. Good. Everybody's warm, everybody's welcoming, and looking at things. Just makes absolutely fantastic. It's an amazing opportunity. Really like it.
So we got some really good feedback from our students, and I just wanted you to see that. I hope you could see that video, could you? Because I've got another video. So part of our simulation means that we're really lucky to be very well kitted out at the University of Sunderland with all the ambulance, the emergency services, and we have childcare simulation and things, and adult simulation. So our students are, even in the adult course, based on the new NMC recommendations, are exposed to all specialities, not just adult nursing. So as you can see, our students have a very good experience. And they enjoy what we do for them. So what we did was we had local marketing and outreach to support Grow Your Own. We have collaborative interviews and selection process. And what I mean by that is we have patients, our clinical staff and our academic staff in our interview process. And we have, we use an interactive team-based interview method to choose our candidates. And we try to recruit enough to fit our capacity in placement, and we have used joint branding. So we have a contract with higher education partners who help us to develop our materials. So they're a very useful team. Just another picture to see where our ward-based areas. So We have a great deal of partnership support. So that means the trusts, so the clinical areas where our students go and have their placements. There is student support throughout their placement from the academic staff. They have a place, so the PL PAD consistency is a placement practice assessment document. So all students are assessed by the same criteria based on the NMC requirements, our nursing midwifery requirements. We have learning lab tours for students and the NHS staff, and we help with alternative placements. So their placements are non-traditional placements. So what does this look like? So in year one, just as this is going to be a quick overview, not to memorize this, but basically we have 4 theory modules and 2 placements at the end. In year 2, we actually have 3 theory modules interdispersed with 3 placement modules, and one of those is an alternative placement. And by year 3, the students are having 2 theory modules where placements become more important. They have 4 placements, sorry. 2 placements are our traditional management placements, and 2 of them are case loading and clinical decision-making placements, considering the patient journey. So what's next for us? Well, we're going to expand. So at the moment, we're delivering these programs in the University of Sunderland, which is in the northeast of England, and we're going to expand, into London. So we have already got agreement from a London trust that we can move to there. And we have staff already based in London who teach the sort of face-to-face elements. And we've also got an agreement with Yorkshire, which will start in 2023. So in summary, it was the right time. The University of Sunderland was ready. It meets local and national requirements. It's future-proofing nurse education and nursing staff capabilities. It meets the digital agenda, and quite honestly, it makes sense. Thank you. Any questions?
Yes. Yes, any questions? Any questions to Dr. Adil Mathak? Just if you have any questions, you can text in chat box. We'll be asking even after the completion of the conference.
Brilliant. Okay, thank you very much for listening. And my job is done now. I'll listen nicely to the rest of the presentations. Thank you very much.
Yes.
Thank you.
Yes. You have got a compliment from Dr. Catherine. This was outstanding, great simulation, great student feedback.
Thank you.
Yes.
Thank you all very much.
Yes, thank you very much, madam, for participating in this event. As one of the keynote speakers for this event, on behalf of organizing committee members of Virtual Nursing Conference 2021, we want to thank you for instant presentation. Thanks for your sharing tips with us. Looking forward to meet again next time. Next, we asked Dr. Kai Misbango from Right Health Healthcare Organization from UAE to join the event and start presentation. The topic will be the impact of a change in senior management on employees' motivation as a result of merger and acquisition. A case of selected target company in the Dubai.
Hello, everyone. It's Kaya speaking. Just trying to load my presentation and share my screen, and I'll be starting shortly.
Yes. Yes, fine.
I hope everybody can see the screen.
Yes.
So, good afternoon. My name is Kaya, and I am based in Dubai. Thank you so much for the opportunity to present. I am working as a Chief Nursing and Compliance Officer for a primary healthcare group in the UAE, and that group name is Right Health. So today my topic is going to be based on research that I had conducted maybe a year ago, just as the COVID pandemic situation started. The research was based on the impact of a change in senior management on employees' motivation that came as a result of mergers and acquisitions. And as the title says rightfully, it was a selected target company in Dubai. I'll just move to the next slide if you can give me a second. Perfect. So this is just basically an introduction or of what I will be talking about. The research was conducted as part of studies that I was undergoing at that moment. So you might see that it's titled and outlined as a research project. But we'll be talking about our purpose, digital review, conceptual framework, methodology. But the most interesting part for, I think, everybody that's attending would be the findings and the conclusion. So in the world and all over in the UAE specifically, there's been a lot of mergers and acquisitions, particularly in the healthcare industry. And while I was conducting the research, I realized that most of the mergers and acquisitions were they were brought about as because of the growing healthcare industry in the UAE. There was exponential growth in the UAE healthcare sector, and that was from maybe 1970, where they had 19 facilities, and in 2019 there were 126 facilities. I'm sure that number has gone up considerably in the last 2 years. This positive growth trend has made it very, very challenging for healthcare providers, healthcare workers, and the entire healthcare system, in my opinion. The main strategy, which I found as a reason for these mergers and acquisitions, was the healthcare industry needed to expand, to be diverse, and the quickest way to do that was through mergers and acquisitions. The other interesting thing was that there was a huge population growth in the UAE, and that then increased lifestyle-related diseases. And there was also an introduction of mandatory healthcare insurance, which meant that people then had access to healthcare services, and this is all tracked and monitored. The reason why I conducted this study was the target company was very interesting. It was a merger and acquisition, obviously, but it was a group of pre-existing healthcare facilities that were now under one banner of healthcare management group. Those existing companies or healthcare facilities had been in the market for, on average, more than 10 years. So they had their own way of practicing. They had different ways of reaching their targets. They had set cultures, set processes. And suddenly, because of this merger and acquisition, they were brought under one umbrella. And the expectation was to grow as one and to perform as one entity. I think anybody can imagine the amount of chaos or disruption or some interesting scenarios that must have come from that. So that's why I conducted this study. But most importantly, I wanted to understand how the changes that were happening in these organizations impacted the employees' motivation and subsequently their job satisfaction. There were various theories that I could have applied to do this research, but I decided to narrow it down and focus on 3 theories. I looked at John Porter's change management theory. There was the Kubler-Ross change cycle, and as well as the motivation theory, Maslow's hierarchy of needs. John Carter's theory was very interesting for me because it looked at the the 8-step strategy to steer organizational change, and it seemed very straightforward that if organizations follow 1, 2, 3, 4, 5, 8 steps, then they will achieve their change. Kubler-Ross change cycle was also very interesting because it helped me understand that all changes have a psychological impact. And that psychological impact was not only on the existing facilities, but also that senior management that was taking over this organization and hoping to lead it to new growth and new challenges. The other theory that I applied was a motivation theory, and I looked at what motivates individuals, whether those individuals are employees, management, or just external stakeholders. So these were the 3 theories that I applied to do my literature review. The conceptual framework was also quite interesting. I took mergers and acquisitions as the main topic. I looked at organizational change and therefore focused on change management because I felt that was the crux of all of this. I then looked at the change process and applied the 3 theories that I had chosen to look at the change process. John Cotter's theory then led me to work environment. I looked at the change cycle and how it impacts job satisfaction. I then also studied mergers and acquisition syndrome, which was new to me. I didn't know that there was such a syndrome. And I then realized that it does have an impact on employees' morale and subsequently their motivation. The other interesting thing to note is that employee motivation is both intrinsic and extrinsic. So intrinsically, I as Kaya can have my own way of motivating myself to reach the organizational goals. But extrinsically, how the senior management and the organization functions also has a direct impact on the employee's motivation. The methodology that I used was a combined methodology. I decided to apply quantitative and qualitative methodology methods. I did look at a pragmatic approach. I wanted it to be realistic, to be sensible and practical, as well as practical, so that I could fully understand. It didn't seem like something that could have been studied theoretically, and practical just made more sense to me. I did use 3 data collection tools so to increase the reliability and validity of the study. And for data analysis, I used descriptive tables and charts and graphs as well, just so that the research could be more effective and applicable in a broader sense. So yeah, using a combined method seems to be quite rich, so I could get rich data. And it was a case study, so it was real life events that were happening at the time. What made it interesting as well was the study was started in 2019, and in the middle of the study, the COVID pandemic situation also started, and that added quite an interesting element to the research, which I'll go into a little bit later. For ethical considerations, there was informed consent, confidentiality was taken into consideration, and the respondents were anonymous, and I had to avoid researcher biasness by involving other researchers in my research and having a supervisor as well. As I've explained already, I use qualitative and quantitative methods. And to make the research more rich and to achieve triangulation, I did conduct interviews, observations, there were questionnaires, and there was data analysis. Now we'll get into a part that is quite interesting for me. I'll just go into it. The questionnaires were sent out to the respondents, and they were sent out through their emails, social media as well. We use WhatsApp because it was easily accessible. And I've just, for the purpose of this presentation, I just took a few of the questions and the response to those questions. I see somebody has raised their hand. I will just unmute so I can listen to the question before I move ahead. Hello. Hi, Luke.
Yes, madam.
Hi, I think somebody has raised their hand. I just wanted to attend to that question, if there was a question.
We can go after the completion of the talk, madam.
Okay, no worries.
It's better instead of disturbing.
Okay. So one of the interesting responses to the question that was raised, we asked questions that were related to the work environment, to job satisfaction, change management, as well as motivation, because I found that all of these factors would help enrich my research. The respondents were asked about their work environment, and the question was, is this a good organization to work in? And a huge population of the respondents agreed. When asked about job satisfaction, we asked, is their contribution to the organization valued and appreciated? And the respondents agreed, a huge majority of them. Another thing that was interesting for me was with regards to change management. I wanted to understand, was there a change management process that was followed? Were there any change management steps that the employees were a part of? And the question was, in your opinion, do you think the employees are motivated? And this response was very interesting for me, and it added value to the research, in my opinion. Only 13% of the employees said that they were motivated. And a lot of the other data was supportive of this, and 87% of the employees said they were not motivated. The findings that came from this research, were that effective and efficient communication is necessary. And this would help the senior management or any leader to gain success and advantage, especially in the event of change management, when there are mergers and acquisitions. Effective and efficient communication is important. One of the reasons I put this as a first point, while I was conducting the research, there were a lot of employees that stated that they were aware that the change was coming, but they did not fully understand what the impact of that change would be. So they were aware that there was going to be a merger and acquisition. Some made assumptions and assumed that as a result of the merger and acquisition, things would be great, there'd be growth, there'd be development, there'd be recognition, motivation, or whatever their expectations were. But there seemed to be confusion because one organization stated that X would happen. The other organization had a different expectation, which then made me conclude that effective and efficient communication had not occurred. Taylor did a research or published a study in 2018 and found similar findings and said effective communication is used to suppress power struggles and conflict. So I mentioned earlier that the organization in question was formed using or combining facilities that were already existing in the market. And there were existing cultures, there were existing ways of practicing, and there were existing processes that all these organizations were following. So every organization came with its own power struggles and conflict, because now we had senior management that were given the baton and the task to form one organization and one goal, one focus, and a unified culture. So the research indicated that if effective communication is carried out, that can help suppress whatever power struggles that may come from different organizations. And it can also help suppress conflicts that can come from all of these changes that are happening. The research also indicated that there's a strong relationship between work environment and job satisfaction. And both of these collectively add to employee motivation. So I then could understand that one should not only look at work environment as an isolated case or job satisfaction as an isolated factor. Basically, there is a direct link between work environment, job satisfaction, and employee motivation. Mergers and acquisitions do have a direct impact on the motivation levels of employees. I haven't included those slides, but there was a lot of anxiety amongst the employees when they were discussing the merger and how they were acquired, even though the research was conducted a year after the merger and acquisition was finalized. But the levels of anxiety, emotional distress that came from this were evident. The other finding was that employees are motivated intrinsically and extrinsically equally. So, which was also interesting, because when I started the research, my assumption was that employees would be more motivated by whatever's happening outside of them. But the research from the respondents and the questionnaires that were raised indicated that employees are motivated intrinsically and extrinsically. I did have some limitations to the study, time constraints, financial constraints, as well as respondents' biases, which was it had a huge impact on the study, because a lot of them were still part of the organization and they didn't want to pick a side. And I also had sampling limitations. So that's that for me. Thank you very much for listening to my study, and I hope it had added some value.
Yes.
I'll just
a hand raise from Dr. Louis Fan from. We have a hand raise from Dr. Shu Fan.
Yes. Hello, Dr. Shu Fan.
Yes, madam, you can continue asking the question. As we got, you have raised the hand for asking the question.
It's okay.
Yes.
Let me just see from the chat. No, she hasn't said anything. But thank you very much to everybody for listening, and thank you as well for the opportunity to present.
Yes. Thank you very much, Doctor, for participating in this event.
Thank
you. For organizational members of Nursing Education 2021, we want to thank you for excellent presentation. Thanks for taking time off for your busy schedule.
Thank you.
Yes. Next, we ask Dr. Maria Bustman from St. Paul University from Manila from Philippines to start the presentation. The topic will be how a Philippine Research Interest Group contribution to nursing education.
Good morning, good afternoon, and good evening. Let me just put my slide share.
Yes.
Can it be seen already?
No, not yet. Just
not yet. Wait a minute. Slide share. This one. All right, can it be seen already?
Yes, it's going to start.
All right, thank you very, very much. And I would like to greet everybody, either a good morning, good afternoon, or good evening. It's late afternoon here in the Philippines. It has been raining almost all day, and I'm used to being flooded. My street is now flooded. All right, so this afternoon, I'm going to present to you how a Philippine research interest group contributes to nursing education. How do I change the slide?
Yes, you can start your presentation. It's fine. We can visible your slide.
Yeah, I cannot change my slide.
Can you go to slide share? Slideshow at the top.
Oh, slideshow.
Yeah, press slideshow.
You are sharing. New share. Where is it? Mute, stop, security, participants, chat, pause, mobile control, more.
In top of this, just you can search in top. You'll be having the option slide change.
Slideshow.
Yes, slideshow.
New slide. New
Yes.
share
Yes.
or new slide?
Slideshow. You can click on the slideshow.
I can. There. All right. So what will be my areas of presentation? I hope you can see it now. I will be talking first about introducing, of course, my country, because we are worldwide, I suppose. I will also introduce the university where I'm teaching, and definitely I will be introducing the Philippine Nursing Research Society, which is the interest group that I'm heading right now. I will also share how the interest group contributes to nursing education, the process, the outcomes, and of course, my conclusions, recommendations, afterthoughts, and my references. So let me first introduce my country, where I'm coming from. The Philippines is a country in Southeast Asia in the Western Pacific Ocean. It has 7,641 islands, but on high tide, it is only 7,107. So it means that some of the islands cannot be seen during high tide. Now, you can see now on the slide is my country. There's an arrow pointing to a very small country. That's the Philippines, where I come from. This country has three major groups of islands. Although there are 7,000, there are groups of islands, and they're grouped together as Luzon, Visayas, and Mindanao. Its capital is Manila, which is located in the National Capital Region in the island of Luzon. Our country is known for its beautiful beaches and sceneries. I'm sure you can see it on your slide, the beautiful views that we have in my country. And I'm praying that this pandemic will end soon so that people can begin to travel and see beautiful places around the world. One of them, of course, is my country. Now, this time, I will be introducing the university where I am affiliated. It is St. Paul University, Manila, which is a private, Christ-centered education institution forming persons to be competent and compassionate to serve the church and society. It's actually a Catholic institution. The motto is Caritas, Veritas, and Scientia. It just means charity, truth, and science. This university was founded way back in 1912, and it is now part of the network of 7 Paulinian education institutions run by the Sisters of St. Paul of Chartres, which was accredited as a system. It means that all of the universities and schools which was founded by these sisters were put together as a system. Then, of course, I'm introducing now my interest group, the Philippine Nursing Research Society Incorporated, otherwise known as the PNRSI, which was established way back in 2008. It has actually 5 founding trustees, and I'm one of those 5 who started the organization. It is actually an interest group with membership that includes nurse professionals, allied health professionals, and student nurses, all of them both nationally and internationally. Currently, we have more than 1,000 members, and we give free webinars. Now, what are the goals of our institution? Number one is, of course, to provide a forum for dissemination and critique of nursing research. Second, to stimulate interest in the scientific study of the nursing phenomenon. The third, it wants to link nurses with similar research interests. It also promotes recognition of nursing as a scientific discipline. And I'm sure this conference actually shows too that nursing is a scientific discipline. It boosts evidence-based nursing practice. And of course, lastly, it fosters ethical standards in research. Now, what is the background? Why did I present this? Because, research is one of the core subjects of the Philippine nursing curriculum, way from the bachelor's to the master's and way up to the doctoral programs. This was promulgated by what we call as the Commission on Higher Education, known as the CHED or CHED, through their memorandum orders to all schools in the Philippines, higher education. Doing a research project is a prerequisite prior to be given a degree. So you can just imagine that all of the students who are taking up nursing will have to do research before they will be given their degrees, whether it's a bachelor's program, a master's, or a doctoral program. I will be showing you the office that we are holding. This is in the building of the Philippine Nurses Association. We hold office at the second floor, and the office of the Commission on Higher Education, or the CHED, on the other side with the flag. This is a government office regulating education in the higher levels from bachelor's. The Department of Education, we call DepEd, Department of Education, usually looks into the lower, from elementary to high school. Now, what is the process that we've been doing? The PNRSI abides by the Commission on Higher Education mandate about research as a course, because we were all given these mandates that I will show you later at the end. The PNRSI collaborates and coordinates with nursing, education, and services. So it's not only on nursing education, but also in nursing practice, known as, of course, the nursing services. PNRSI provides free mentorship, consultations, and assistance to both professional nurses and students in the bachelor's, master's, and doctoral programs, those who are doing research. Of course, we know that all those students who are doing research have advisors or supervisors. Our mentorship means that the PNRSI moves in the same direction with the student advisors or supervisors in research. Now, I have made a diagram of the process to make it simple. On one side, we have nursing education, and on the other side, we have nursing services. And twice a year, our organization provides conferences, usually for free, that will include both nursing education services from students to doctorals, and we provide mentorship and consultations for both. Now, what outcomes did we see? Based on what we have done, because we've been doing this from 2008, we saw motivation and inspiration to love research. Why did it become an outcome? Because, for many students, even at the doctoral level, they think that research is difficult to love and it's difficult to do. But because we have helped them and we give this free consultations and mentorship, they learn to love research. Now, to conclude, I can say that having a research interest group that operates nationally and internationally is a good way of showing how an organization may contribute to nursing education. I said nationally and internationally because we do not only mentor students from the Philippines, but also from other countries. I have had mentored students from China, from New York, USA, from Dubai, and from Riyadh. They write to me, and of course, I assign them based on their topics. I assign a mentor for them. Now, recommendation, nursing interest groups and specialty groups should collaborate with nursing education and services to enhance the profession. And for an afterthought, I have just placed here few words that will really be within our minds. We all teach, we encourage, we instruct, we mentor, we praise, we influence, we guide, and definitely we inspire. Now, my references are actually our Commission on Higher Education Memorandum Order, because these were all given to us, whether we are in the education or services, on how nursing should be practiced and taught. Now, before I end, I would like to share with you a quote from Nelson Mandela. He said that education is the most powerful weapon to change the world. Many thanks, and I will be answering questions. You can find me at my Gmail, which I wrote. And the picture that you see here is my picture when I graduated way back in the late 70s. Of course, I look so similar, I suppose. That's why I didn't put my new picture. I want you to see how I look like way back when I studied nursing. Thank you very, very much.
Yes. Yes, any questions? Any questions to Dr. Maria Bustamante? Just you are getting a compliments from chat box, madam. From Dr. Shaima, from Dr. The Spark is Love, as well as Dr. Shanti R, Dr. Gabriel, Dr. Catherine. You are getting compliments from the chat box.
I would like to thank everybody, and I would like to thank, of course, Inovine, because I received it in my email and I said I better share what we are doing here in nursing education. Thank you very, very much.
Yes, thank you very much, madam, for participating in this event. On behalf of OCM members of Virtual Nursing Conference 2021, we want to thank you for instant presentation. Thanks for sharing your tips with us. Looking forward to meet again next time. Thanks for taking your time to your busy schedule. Next, we ask Dr. Hardeep Kaur from University College of Nursing from Baba Farid University of Health Sciences from India to join the presentation as a poster presenter.
So very good morning, good afternoon, and here we are having afternoon in India. Myself, Dr. Hardeep Kaur. I am working as a professor and head at Community Health, head of Department of Community Health Nursing. Let me share my screen. Okay, thank you. So I am working as a professor and head at University College of Nursing, University of Health Sciences, which is the only health university in the Punjab region of India. And I'm going to present original research article on the study on the delivery practices and reasons associated with these practices among mothers. So I want to emphasize that this topic is a very vibrant topic because the maternal mortality in India is very high, and all the national health policies and government of India is striving hard to achieve the target of reducing the this maternal mortality rate in India. So this study was undertaken just to have the assessment of some of the areas which we have chosen for this study to understand what are the different delivery practices are running in these areas and what are the reasons for opting those practices by the mothers. So we all know that pregnancy is a physiological process. It's a very normal process, but also it has potential risks leading to complications, which lead to complications related to labor, related to delivery, during the delivery, or after delivery, postnatal period. And if we talk about the maternal mortality ratio in India, in the latest data 2020, it shows that there are around 254 deaths per 1 lakh live births, which are in India and in developed countries. But if we compare it with other in the developing countries, and if we compare it with the developed nations, it is only 16 per 1 lakh live births. So what has to be done? That means prevention of this maternal mortality. So there is need to have skilled care before, during, and after childbirth, which can save the lives of women and newborn babies. So the objectives of the studies were to assess the delivery practices among mothers who are residing in the selected areas. We have taken one rural area and one urban resettled colony, where the low socioeconomic people who resettled for, or we can say the migrated population who was residing in these urban areas. And the second objective was to identify reasons associated with these practices among mothers residing in these areas of district Faridkot, and to find association between delivery practices and selected demographic variables, means what are the different factors which are giving rise or which have effect on the maternal mortality, on the delivery practices. And the research material and methods, if I talk about, this was a simple descriptive study, non-experimental descriptive study. I have already told you we want to have the assessment data of our two areas to understand the delivery practices, so that as a nursing professionals, we can have some promotive actions, we can have some preventive strategies, so that these maternal, these women who are delivering at home and whose deliveries are conducted by unskilled birth attendants, those can be prevented. They can be motivated to go to the hospitals, to the institutions where they can be taken care. So the settings were, I have already discussed that we have taken one rural, that is one village has been taken, and one urban, which is Balwinder Nagar of our district Faridkot, which is in the Malwa region of Punjab of India. And this area which I have talked about, the urban, this is sort of resettled colony where the migrated people or of low or middle income strata were residing in these areas. And the sample was included 190 subjects, and these sample were total enumerative sampling was done. That means that the women who delivered the last in the last 1 year, that means that data was taken from the 1st January of the last year till the 31st December of the last year. So total whole 1 year was taken to understand about the different practices. And this was done. The data was collected through the first, of course, a socio-demographic sheet, data sheet was made, which include the socio-demographic variables. And then the semi-structured interview schedule were prepared, and which was to assess the delivery practices and to assess the reasons behind those delivery practices, which were we got with the information we got from the mothers. And ethical considerations was taken care of. That means the head of those villages, urban municipal corporation heads, the permissions were sought from those authorities, and even the mothers were given the explanation. Ethical consent was taken. And coming to the result shows that the demographic profile, and there were around 190 mothers who were enrolled for the studies. That means enrolled means they were delivered in the last year in these two areas. And out of these 190 mothers, 120 were from the rural areas and 71 from the urban areas. And majority of these women, they were in the age group of 20 to 30 years, and which comprised of 91.7% in the rural areas and 91.4% in the urban areas. And in both the strata, the education of the mothers were up to majority of the mothers were educated up to the primary level, and they also belonged to the nuclear families, which comprised of 66.7% in rural areas and 35.7% in urban area mothers. And they also, the income group in both the women and 1/3 of the women, or we can say the families who were having less income, they were comprised of almost 37.5% in rural areas and 44.3% in urban areas. And very astonished to know that that the only 2 mothers, but 1.7% of mothers in the rural areas, they had no antenatal checkups. That means they were not going to the hospital, and they were just residing with their pregnancy at home, and they are just doing the home remedies and so on. They don't have gone for any type of antenatal checkup. And 10.8% of the mothers in the rural areas and 8.6% mothers in the urban areas, they delivered their last child at home. That means this practice was there in their families. That means the untrained skilled birth attendant or some other practices or other persons were involved in delivering those babies. And coming to the percentage distribution of mothers according to the person who conducted home delivery in rural and urban areas. And when we have gone through the data, we have seen that around 95% mothers in the urban areas and 90% in the rural areas, they delivered in the institutions. That means hospital deliveries were there. But the remaining persons, 7 in the urban areas and 5 in the rural areas, they delivered at home. And when we have gone in detail who delivered these mothers, that the data shows that in the urban areas, majority of the persons, mothers who were delivered, these deliveries were done by the untrained skilled birth, untrained birth attendants, and less in the rural areas. And private nurse who has assisted in the delivery, that was again more in the rural areas as compared to the urban areas. And in the urban areas, one delivery was conducted at home by a registered medical practitioner, that is a doctor. He conducted delivery at home. And again, this data, which was around 5% in the rural areas and around 10% in the urban areas, that means these deliveries were done at home. So when the interviews were conducted of the mothers to find out the reasons why they have opted for the home deliveries, so a few of the constraints they have explained. That means they said that due to some financial limitations, they cannot go to the hospital. And again, the long distance to the hospital was there. That means they could not afford to visit there. And lack of escort at home, which is a very simple thing which can be overcome by the health profession. That means they don't have the transport limitation in their area, so they delivered at home. And there was a misconception to some women that if we'll go to the hospital, that means there is risk of cesarean section. That means that they will not opt the home delivery, they will not opt for the normal delivery at the hospital. That means the health facility where they will go, the medical professional will go for cesarean. So that means that is a misconception. And then traditional attitude, like in the results only, we have found that few of the 1.7% of the mothers, they already delivered their first child at home. And unexpected preterm labor, they were not knowing that. And short labor, that means we can say that the duration of the labor is very less. So that is the reason in 20% of the women. And ignorance, that means they are not very much aware. Like in urban areas, I have told you, like most of the migratory population is there. So they were not knowing that these type of health facilities were available, and they just delivered at home. And for few mothers, around 25% of mothers, they said it is very convenient and comfortable to deliver at home. And I think to some extent that is okay, because if we have skilled birth attendants which can deliver these ladies at home, that will be much better. And the same thing, few of the mothers have told that they wish to have their family members to be nearby. They cannot leave their children. Maybe this delivery is very like if spacing between the children is less, he is having toddler or infant with her, like 1 year or 1.5 years baby is there, toddler age is there, so she cannot leave that child at home, and maybe due to nuclear families, so that means that they wish to be at home and they want to deliver at home. So these were the reasons for not opting the home deliveries. And about the third objective, that is what was a significant association of the delivery practices with the demographic variables, and it has been seen that in both the areas, in rural and urban areas, the significant association was found between delivery practices with the income of the family. In both the areas it was there, but in the urban areas, education of women, they also had significant impact on the delivery practices. That means the education of mother, has effect, that has impact on the delivery practices. That means the mother is educated, that means she will be opting for institutional deliveries, she will go for antenatal visits, and she will know the benefits to be delivered at home or by the skilled birth attendants. So coming to the conclusion of the study, this shows that the awareness regarding the institutional delivery increases the number of of institutional deliveries in both and urban areas. Means when there is awareness, that means of course the hospital deliveries will be more and the complications will be reduced. And the financial limitations, risk associated with cesarean section remains the most common reasons for home delivery. So our government has planned Janani Suraksha Yojana. That means this type of the opportunity is given to the mothers to deliver free of cost in the hospital, in the institution, and they are given the remuneration if they deliver in the hospital, and also transportation facility is given to the mother if she want to deliver at the institution. So this was the very, I think, important study from my point of view, which has given us the baseline data about our areas. And after that, we have planned a few of the promotive and preventive strategies to make the mothers aware about the different institutions who are nearby, and also to motivate them, that is, what is the importance of giving birth to the child, to the baby, in the institution or by the skilled birth attendant. So these small, I think, measures, we can improve the maternal mortality rates in our area. Thank you very much. If you have any questions, most welcome. So your mic is off.
Sorry, please apologize. Yes, any questions? Any questions to Dr. Hardeep Kaur?
I want to thank Inovine and this Virtual Nursing Congress 2021 for giving me this platform to discuss my views, and of course listening a number of nursing experts from the different countries. Thank you very much, sir.
Yes, thank you very much, madam. So thank you for taking out your busy schedule. Yes. On behalf of Organizing Committee of Virtual Nursing 2021, we want to thank you for instant presentation. Thanks for your sharing tips with us. Looking forward to meet again next time. Next speaker, we ask Dr. Deborah Maliniger from NMC Provita International Medical Center from UAE. The topic will be NMC Provita and LTCU Royal Cluster Nursing Paving Way of Rehabilitation Transcendency. Yes, madam, you can start sharing your PPT.
Can you see now? Hello?
Yes, madam.
Okay. Hello, everyone from any parts of the world. My name is Deborah Molnegro, and I'm the clinical educator for NMC Provita International Medical Center. We are the pioneer of long-term care nursing here in the UAE and the largest post-acute rehabilitation service in GCC. We're the first to be accredited for the JCIA for long-term care in the UAE. So the topic for this day is entitled NMC Provita and LTCU Royal Cluster Nurses Paving a Way to Rehabilitation Transcendence. So this presentation aims to, define rehab nursing, determine the importance of rehab nursing in the UAE as well, and provide statistical data on status of rehab in UAE. We also want to differentiate the rehab nursing and long-term care nursing, determine the relevance or status of rehab nursing in UAE, and at the same time, we would like to determine how rehab nursing will affect healthcare system in the future, provide Provita's journey to rehab nursing, determine the nursing perception of rehab in Provita, and we would like to present the current and introduce future programs of rehab nursing in Provita. So what is rehab nursing? From the word itself, rehab. R stands for recovery and promotion of rehabilitation for the patient. And E is for enhancing outcomes or capabilities and self-esteem. And let me go back to R. It's more of restoration of maximizing function. And H is for holistic approach, meaning we want to put the patient back to their normalcy or the community re-entry. And A is for adaptation to the new self, and B is for boosting independence. So why is rehab nursing important in general? According to the national newspaper here in UAE, last 2019, between 10,000 and 12,000 people suffer strokes in the UAE each year. And every hour on same hour, they say that a person, in the UAE suffers a stroke. So in the UAE, rehab is actually a growing specialty with unique competencies, and we have 14 unique competencies according to the ARN. And according to Middle East Physical Medicine and Rehabilitation, there is a high demand for rehabilitation services in the country. And in order for rehabilitation to be provided efficiently, we need people who are trained in different spectrums. And one of it are to specialized nurses in rehabilitation. So here we have a data according to a study conducted that a total number of trips from the UAE seeking medical treatment overseas sponsored by DHA, actually the government pays an average total expenditure of $77 million to cover on an average of 1,500 UAE national patients. Well, it doesn't mean that the people that are going or the locals that are going overseas for treatment just tells rehabilitation or just seeks for rehabilitation, but at the same time, those people that wanted to be treated for long-term may also need a long-term care here in the UAE. And this study actually included 6,557 UAE nationals. This graph or this chart illustrates the total number of trips from the UAE based on age group of patients treated overseas during the 2009 to 2016 year. And the bigger chunk on this chart is showing that 19 to 39 years old, which comprises 29%, are those people that are going for overseas treatment, which means they are more of a working class or a working age group. And according to Outward Medical Tourism, a case of UAE study, last January 2018, the most common types of treatment that were sought by Emiratis for medical tourism one of it is rehabilitation. And part of the main reasons to travel overseas for healthcare included post-treatment rehabilitation, which is mainly because it is not available in the UAE before. So what is the difference between rehab nursing versus long-term care nursing? Actually, rehab nursing and long-term care nursing will be differentiated based on their goals, the time frame of nursing care coverage, the healthcare personnel required, and its concept. Well, for rehab nursing, the goal is mainly to put back the patient to recovery, or it's a transition back to the normal activities, which promotes more of independency, while long-term care nursing is more of round-the-clock presence of a healthcare professional. With regards to time frame of nursing care coverage, the goal of rehab nursing is goal-oriented, meaning temporary, while long-term care nursing is permanent and routine-oriented. For healthcare personnel required, most of for the rehab nursing is actually interdisciplinary in approach, while long-term care nursing is more of multidisciplinary team. And the concept, finally, of rehab nursing is working with the patient, meaning the nurses will assist the patient towards their independence. While long-term care nursing, the patients are fully dependent on the care of the nurses, meaning the nurses will work on with the patient. So the status of rehab nursing in UAE doesn't have really a clear definition of what a rehab nurse is. And according to Emirates Nursing Association, it is in the process of developing a rehabilitation society in the UAE. And NMC Provita nursing workforce will be an active part of it. So healthcare in UAE is actually predicted to take a turn towards more long-term and home healthcare in the future. And according to DOH statistics, approximately 48% of the population is on the age bracket of 40 years old and above. As it is one of the Department of Health's advocacy to promote quality of health, rehab nursing will really play a big role in encouraging the patients to live independently. In addition, a recent study conducted by the same Department of Health local government authority here in Abu Dhabi reported that there are over 700,000 patients requiring outpatient rehabilitation services. And after 5 years, by 2024, because this one is conducted in 2019, it will increase to roughly around 40%, meaning 5,865 patients and requiring 466 beds. However, the perspective of local population here in the UAE towards rehabilitation seems like they don't have really an idea on what rehabilitation is, because they felt like encouraging the patient to do activities is more of doing or lessening the workload of the nurse. So we're still on the verge of changing that perspective. So now we're going to discuss rehab nursing in NMC Provita. Well, firstly, NMC Provita started as a long-term care facility. However, the scope of care has expanded, especially with the admission of more PAR patients from the recent years. And with that, there is an identified need for nurses to be trained in assisting the patients with ADLs. Furthermore, in order for the acute care nurses to be a rehab nurse, there are a lot of challenges in this situation. So firstly, we have to assess the perspective of the acute care nurse versus the rehabilitation nurse according to their readiness, their competency, and their experience. With that, with the educator's perspective, one of the challenges that we face, according to our education manager, is that developing a program for nurses who do not have a rehab background can be challenging, as we currently do not have an active rehab society in the country. And Anami, a clinical nurse coordinator for rehab, states that lack of formal training and being self-taught as a clinical nurse coordinator for rehab somehow is a difficult hurdle, because they don't have a point person from the rehabilitation nursing perspective. And in addition to that, from the multidisciplinary team perspective, PTs actually states that the nurses or the physical therapists notice that there's decreased level of cooperation from the nurses, and some of the OTs or the representative from the occupational therapy thinks that nurses should be encouraged to practice self-care and initiation from the staff. I mean, they need to embrace the concept of rehabilitation. And from the nursing side as well, the approach of LTC or long-term care and PAR patients are entirely different, meaning they are very in contrast. The charge nurses, they say that lack of follow-through for the rehab workshops tends to be difficult because of staffing issues. So to overcome these challenges, NMC Provita Nursing Department, in collaboration with Therapy and Education Department, developed a program which is the Rehabilitation Nursing Program or Workshop. And these this workshop aims to, or started to have goal plannings. They identified rehab coordinators and link nurses, and we've developed a rehab workshop tailor-made for healthcare assistants. Inclusive of this is development of fundamentals of rehabilitation curriculum, the CARF accreditation, the utilization of Northwick Park staffing tool, and formulation and carrying out of rehabilitation nursing. So this is what Northwick Park dependency score tool looks like. Well, here the patient dependency actually is formed in under 3 categories, meaning basic care needs, special nursing needs, and inpatient nursing needs. So the tool actually helps us to indicate if the patient needs low level of dependency or high or very high level of dependency. And from the comment of our nurse manager, Miss Ruby, she mentioned that the Northwick Park dependency score tool has been a helpful tool in establishing a general guideline on how we can better disseminate our staffing here in NMC Provita, considering that we are catering to a number of PAR patients. So here we have the NMC Provita journey to rehabilitation. We started actually in 2010 as a long-term care hospital. We cater to mechanical ventilated patients. And after 7 years, there's a range of patient care expansion so that we welcomed our first rehabilitation consultant, Dr. Ahmad Al-Khair, in the facility. Following that is our accreditation for the Center of Accreditation for Rehab Facilities with 3 years validity. And in the same year, we applied for admission of PAR patients or post-acute rehab patients to the local government. And around 2018 of January, we already received the approval for admission of PAR patients. Hence, our mission and vision was changed to cover the scope of care in the facility. And on the same year, the rehab coordinator helped establish the protocols on bowel and bladder management. And the same year also, the multidisciplinary team was held a meeting was held to discuss possible rehab workshop to be held to the facility. And after a year, or on February 2019, we received our reaccreditation. And from that reaccreditation, we were given inputs so that we added it to the workshop as well. On the same year, we applied for CME accreditation of the workshop and was sent to HAAD, or the DOH, HAAD before and now DOH. And we were approved for that workshop so that the first rehab workshop was successfully held on April 2019. Furthermore, on 2020, we noticed that there's a further need to develop nursing for rehabilitation, so that from the fundamentals of rehabilitation, we evolved to the formulation of essentials of rehabilitation. And because of COVID, we weren't able to carry out the workshop on 2020. Thus, we were moved to 2021, first half, and we were able to successfully carry out the essentials of rehabilitation workshop, which comprises phase 1, phase 2, and phase 3. So here is an example of the first rehab workshop that we held last 2019. 2018, the fundamentals of rehabilitation, which is more of a multidisciplinary approach, since we have here OTs or therapy team, we have the SLPs together with the RNs and the educators. And it evolved to rehabilitation nursing workshop, which is actually a ladderized program consisting of 4 phases, which is more of focused on nursing. And it involves phase 1, phase 2, phase 3, phase 4. Phase 1 meaning the essentials of rehab nursing, and phase 2 the application phase of the first phase. The third phase is rehabilitative nursing care management, and phase 4 is more of the application phase, wherein a supernumerary day or a shadowing period with therapists or rehab CNC or clinical nurse coordinator. Here are just the snippets or the snapshots of the training program. As you can see, we are helped out with our therapy team. And the benefits of this program actually for one of the participants, active participants of the program, is that Literally everything about rehab to her was new, and because of the workshop, she really gained confidence. During phase 1 of the workshop, she was still adjusting on that period, and after the second phase, it helped her to retain a lot of knowledge and skills and was able to apply them at the bedside. And she was really competent in handling patients, and at the same time, she was more confident in imparting her knowledge or her skills or what she has learned in the real scenarios. From the therapy side, they would say that from a scale of 0 to 10, the nurses at the beginning were from 0. However, after the program, they noticed that there's a great improvement from 0 to 5 after 2 to 3 phases, meaning the program is still not complete. But the progression of the staff or improvement of the staff was from 0 to 5. So the nurses now have a better understanding of what rehab is, and they are more competent and responsive. And also they noticed that there was late turnover of patients for therapy, but now they come on time for the therapy session. And these are just additional comments. They were able to widen their knowledge and skills, promote patient independency. And one of the doctors actually thanked the rehab team for really helping us out in this program. So recommendations in the future of nursing rehab in NMC Provita, we just need a follow through or refresher courses at least once a year for those who were previously trained, and rotation of staff assigned in long-term care patients to the rehab patients or units. And from the therapy side, they wanted to prioritize training of staff who are assigned in the rehab units, and also to involve the therapy team in conducting staff nominations so that it will ensure participants' willingness for the program. So we're nearing the end of the presentation, the future rehab nursing inputs in NMC Provita. So right now we are planning to have a caregiver or healthcare assistance rehab workshop here. And at the same time, you're nearing the phase 4 of essentials of rehabilitation with supernumerary day, as mentioned earlier. And we're also looking forward to recruitment of a rehab nurse specialist, and as well as a collaborative nomination of rehab workshop participants. Lastly, as I end this presentation, I just like to impart this, that in NMC Provita, we are committed to bridge the gap between long-term care and rehab. And as a multidisciplinary team, the doctors, nurses, therapy team, education team, and links will move forward with the demands of healthcare system in UAE. Ever innovative, giving quality care with heart. So here are my references. And we are on the question and answer portion. Are there any questions?
Yes. Any questions? Any questions to Dr. Deborah?
If you have any further questions, you can freely contact me with this email.
Yes.
And these contact numbers. Thank you very much, Inovine, for inviting us.
Yes, thank you very much, madam, for participating in this event.
Thank you very much.
Yes. Thank you for taking your busy schedule and joining this event.
Thank you.
If everything goes well, we are planning to organize physical event in Dubai, madam, in the month of April in 2022. If everything goes well.
Okay, sure. We'll join.
Yes, thank you.
Thank you very much.
Yes. Have a nice day. Bye.
Have a nice day. Bye.
Yes. Next, we asked Dr. Shanti Har from American Art International Training and Center from King Faisal Hospital Research Center from Saudi Arabia to start the presentation.
Hello.
Yes, madam, you can go ahead.
Hi, is my voice is clear?
Yes, it's fine.
Okay, hi everyone. Yeah, voice is clear, yeah?
Yes.
Okay, hello everyone. This is Shanti connecting from Riyadh. I hope all of you are doing very, very well. And thank you for the invitation as a speaker as well. Let me start with my topic, psychological trauma on resuscitation provider. why am I here today? Prior to that, let's watch this short story about Mr. John, which was captured. This story was captured from Salem Health camera about April 17, 2012. So based on real superheroes, who may be one of us who are talking today, who've been saved these patients' lives.
If it wasn't for this team here at Salem Hospital, I'd be dead.
61-year-old John Juris of West Salem started sweating and felt chest pains the morning of April 4th.
I just had a weird, strange feeling that something was definitely wrong. I remember telling her I need to get to the hospital.
He never goes to the doctor. And when he says he needs to go, don't question it.
John's girlfriend, Janet Carter, decided to drive him to Salem Hospital. She felt his heart stop beating when she pulled up outside the emergency department.
I was laying on the horn and realized nobody could hear me, so I had to get out and go in.
Janet ran by Ola Yost, a trauma nurse who was just starting her shift. Yost noticed another nurse, Hattie Lowry, plus an emergency department technician heading outside.
I didn't know what was going on, but she looked like she was in a hurry. So I ran after her, and immediately she yelled for a stretcher for me to go grab a stretcher. You could hear in the tone of her voice that this was a serious situation. CPR is just one of those first things you got to keep that heart pumping to get the oxygen flowing to his brain. She was performing using the seat as a backboard and performing against the seat. And you could see the whole car moving while she was doing that. Once we had enough help, we got him out of the car and right onto the stretcher. As soon as I jumped on top of him and started performing CPR, that's when it really slowed down. It was very slow motion, seeing him and looking at how bad he looked at that time, and just knowing that we need to get him into a room fast.
There was so many people responding to his situation. It was incredible.
Emergency physician Jeff Hemstreet was part of the team that spent 45 minutes trying to resuscitate Juris as his heartbeat returned and then faded several times.
He was breathing on his own, clenching his teeth, and that's a sign of brain function. And this was a ways into the resuscitation still. His heart wasn't beating, and he required some medication and energy to restart his heart. He was able to be taken right to the catheterization lab immediately following his resuscitation. Things definitely aligned in his favor. To be at a hospital with an excellent emergency department staff that was very skilled in his resuscitation, immediately followed by a cath lab available around the clock. Can't believe to see us sitting upright talking. To see him with his new lease on life, that's really a gratifying moment.
It's amazing, absolutely amazing to me, what they have done for him. Thank you doesn't even seem enough. But yeah, thank you.
Absolutely a miracle what they did for me. I owe them all my life.
So why am I here today? I'm a mental health advocate for all the healthcare providers. So that is why I am here today. Every resuscitation provider needs to feel confident to say that it's okay to not to feel okay. Almost every time, while our focus is always on patients, then what about us as a healthcare provider?
All right, move run 3, 1, 2, 3.
So as you can see, while our focus is always on patient, what about us? What about the healthcare professional? We all experience both personal and professional trauma. Every person has different threshold and range that conceptualize as traumatic. Ask ourselves, or ask any healthcare professional about their experiences on resuscitation. They will tell you about a case that personally affected them deeper than expected. They may say poignant, they may say traumatic, disturbing, and stressful. The study shows presence of psychological trauma symptoms in resuscitation providers, and an exploration of debriefing practices. It actually concludes that nearly 10% of acute care staff screen positive for PTSD following in-hospital cardiac arrest event. And there are a lot of possible examples of negative effects from this trauma: depression and anxiety, avoidance of resuscitation, hypervigilance in resuscitation, drug and alcohol abuse, lack of compassion, changes in worldview. Can we do anything about it? Or we just take it as this is just part and parcel of being a resuscitation provider? Definitely we can do something about it. One of them is psychological debriefing, post-resuscitation, which allow the victim to talk about their experience and receive information on normal type of reaction to such an event. So debriefing divided into two, formal and informal debriefing. Formal debriefing, few hours of post-actual event, whereas informal debriefing, 48 to 72 hours post-event. And the study says that most helpful is to include all the staff members involved, pre-hospital, ED, and ICU. So usually when we let the staff member talk, debrief, and they will come up with the negative outcome from the trauma, is really long lasting. Watch this video of debriefing and find out whether if we can identify individual most likely to be affected. Can we spot the circumstances likely to affect us? Or can we do anything about it?
First, it was a pretty typical day in the ER, but we got a trauma call and we found out that it was a drunk driving accident and there had been a mom and a child who had been pretty severely injured. And I was responsible for taking care of the two of them, and it was just horrible. It was just terrible, and I couldn't do anything. I couldn't save them. I tried everything I could think of, and I couldn't save them. It was terrible. And then I had to go talk to the husband and tell him that they didn't survive, and it was just heartbreaking.
And for you, what would be the thought, if you, oftentimes there's a thought that is the loudest in our heads at the time, or we repeat over and over again. What would be that first thought that you recall having that kind of salient occur?
I think it's just that this is so unfair. It's just, I mean, this mom and child were just driving along. They didn't think anything was going to happen, and now they're dead, and I couldn't save them. And it's a horrible feeling, and they didn't deserve this. And because of one person's choice, now their lives are gone, and her husband is just distraught. It's horrible. It's just unfair. It's all I can think in my head is it's just unfair.
So Iris, for you, could you maybe give us a little general overview of the facts of the experience that you had there on that day?
It's really hard for me because I'm new in this job, and for me it was very traumatizing, and it's the first time that I've experienced death and seen death with my eyes, and it was not one but two people and a little girl. So I prefer not to go into details as I'm still in shock right now. I can't.
So you can share with us your experiences on that day.
Well, again, I'm probably one of the senior nurses in the ER. I'm also precepting Iris. And as you know, we go through this. It's not a common occurrence, but each one can really take a lot out of you. And so basically my role was to help her. We took care as a family. And then I also went over to take care of the man that caused the accident. And that's where emotions can get really strong too. I didn't take Iris with me because I felt there was enough going on.
And for you, what was the first thought or the strongest thought that you remember having that repeated over and over in your head?
For me, being in the room with the drunk driver and hearing Melinda, I knew Melinda had just broken the news to the father because there's this horrible scream that families do when they realize they've lost someone. And I think that's what truly has shaken me to the core of the auditory versus the visual. So,
a deep sensory.
Yeah, I'm more sensory.
The
Yeah.
deep sensory piece. So we go around. Would you like to share the first thought that you had that you remember having that sticks out in your mind? Perhaps the loudest thought.
Oh, I can't talk about this. It's been. I don't think I'm ready for this.
I'll go make sure she's all right. Great, thank you. So Allie's going to go with Iris and offer her some support while she's doing that. I'd like to continue on if that's okay with you.
I think for me, it's auditory. When Melinda had to go and tell the father that they both were gone, and there's something about that howl that families do that carries with me. So I noticed, like at home, if the TV's on and I hear laughing, I get real agitated, like how can you be laughing, right? You know, everybody has to, why aren't they feeling like I am? You know, that kind of, and also for Iris, because when that occurred, although I was near her, I almost felt mothering, like I wanted to spare her and I couldn't. So I think some of that's with me too, being her preceptor. How do I handle, besides myself, a young nurse?
You're worried for her.
Yeah, yeah.
Strong.
Because she's at a spot she's gonna be because it's so new, you know.
Of course, you know, wish she could do more and could reverse the course of time and somehow made it not happen the way that it did. That's a normal feeling. That's grief. You know, that's a part of the grief process. And, you know, and it's important through this to come together, to talk, to share, to seek support if you need it, and also to do self-care. To know that that is okay, to do the self-care piece. So we've talked a little bit about some of the effects that can happen. What do you feel like for you has been the way in which this might be interfering with your normal life course? Maybe your sleep, maybe your appetite has changed. Maybe it's more challenging to engage in some of the things that you normally enjoy.
Yeah, I mean, I definitely am having trouble sleeping, but I feel like I can't do anything fun. Like I shouldn't be doing anything fun. You know, just like Sue said, she hears someone laughing and it makes me mad, or I feel like I don't deserve to go to the movies or do something, with my family that is fun, because I have a beautiful family still, and this family is now torn apart. And I feel like I can't be kind to myself in that way because somebody else has been suffering. It's just hard to get over that.
Hard to put that piece of self-care, make that okay again.
Right. Like it's hard to go have a good time when we're thinking about that and know that someone else is not.
Yeah, I notice for me, I've learned in some ways to not go to the mall or something too noisy. Again, I think for me it's auditory, that I tend to take walk. I try not to climb into a shell, try to get out, but go for walks, take the car, go somewhere that I like to go that's not as overwhelming, so that, and just take that time. And I think allowing it to happen, I'm more prone to eating when I'm stressed. So making sure, although I might want to eat, I've learned too to eat properly. So if I'm going to go on, to try to comfort in that way. And to also know, to help Melinda, it does get better, but it's there for a while. And I think the good part for me, I find coming to work, which I hope I'll be able to help with Iris. It almost feels like you're with the people who have been through it, so they understand. And my plan for Iris is to reassign us for a while, so we're not on that trauma hall, and let her see a lot of basically normal events. Again, normal can change, but to regroup her.
Yeah, and what I like about what you're saying there, sometimes we do have to give ourselves permission to take a step back for a little time and do something a little bit different and focus to allow some of the healing to occur before we step back into the fire, as it were. So why don't we take a moment and just kind of go around, because although it can feel very difficult to engage in self-care and to feel like that's a priority, it is important. It's a part of how you will move beyond this, and that's okay to move beyond this, because you do have family and other people to care for, and this is a tragic part of life, but it will get better. I want to keep you strong through that process. So what is something that you might do for self-care?
Well, I'm actually really glad that you mentioned, Sue, going somewhere that's not noisy or not a lot of people. I think that is one of the things for me, is I don't want to see other people be happy, and I don't want to, I mean, it's fine, but it just brings up that feeling that I should have done something to save this family. But going to a place that's quiet that I like maybe going on a walk in one of the parks near my house that I really like to do, that would be nice to be able to get out and bring my daughter and my husband with me, and then, you know, we can have a nice time together, but it doesn't have to be around all of these other people. And I think that's probably a good way to get started, at least.
And I think what I think is a gift is that we have people like you now who come and let us have these feelings. And
so conclusively, we can say here, we can identify individual most likely to be affected. Iris, who was in this video, she's just newly joined the trauma team. So she can't even sit and talk about it again and again, even though that incident took place like a few weeks ago. So, and number two, can we spot the circumstances likely to affect us? Yeah, for the senior staff nurse, she feels like if any loud noise, she feels like a bit not comfortable, because she still recall back the incident. And can we do anything about it? Obviously, we can do something. Self-care. Look after ourselves. As we know, we are truly the wounded healers. How can we take care of ourselves? We must develop a strong positive support system at work and at home as well. Take time to decompress. Find a way to engage in physical activity. Exercise is extremely helpful in relieving stress and providing an outlet. Finally, be aware of your stress responses and don't be afraid of reach out for help when you need to. These are some references where you can refer to. Let's see what are the key takeaways from this session today. Number one, creating an awareness of PTSD among resuscitation providers. Number two, creating a strong support system within healthcare facility for resuscitation providers. And also create an environment that every resuscitation provider need to feel confident to say that it's okay not to feel okay. And we need to create an environment that psychological safe in order for them to voice out. And thank you very much for listening. You guys can reach out to me for any questions in info@shanticoaching.com. That's it. Thank you. And also thank you very much.
Yes. Yes. It was a real. We really appreciate everything what you do, madam. It was a great video.
Thank you.
The video everything explains what the during the period of corona, what the coronavirus had done to everything to the society. Yes.
Yeah.
Yes. Thank you. Thank you. Any questions? Any questions to Dr. Shanti or?
And you guys can reach out to me in info@shanticoaching.com. And I do free online coaching for all the frontliners. So if anyone needed to talk, anyone need to reach out for any help, you guys are free to reach out to me at info@shanticoaching.com.
Yes, yes, ma'am. You got so many compliments from chat box, madam. It was a great presentation, Dr. Kai. It was excellent.
Thank you.
It was an excellent presentation from Dr. Hedel Matak. This was a powerful from Dr. Catherine.
Thank you.
Yeah, so many compliments. Thank you very much, madam.
Thank you very much for giving me the opportunity to the virtual nursing conference. Yep.
Yes. Thanks for sharing your tips with us. Looking forward to meet again next time in physical event if everything goes well in 2022.
Sure.
Yes. Next we ask Dr. Lizette Herrera Bazaba from Pontifical Catholic University of Chile from Chile. The topic will be psychometric analysis and validity of readiness for interprofessional learning scale in undergraduate Chilean nurses.
Thank you very much. I'm going to share then. So for me, it's a good morning. So good morning to everyone. I'm Dr. Zetira Razabal, a nurse who works at the nursing school at the Pontificia Universidad Católica de Chile in Santiago de Chile. So I'm here to share with you some of my results from a research where we effectively did a psychometric analysis and a validity of a readiness for interprofessional learning scale in undergraduate Chilean nurses. With that said, I'm sorry, did I take it out? There we go. Next slide. It doesn't work. What's going on? I'm sorry about that.
Yes.
Let me see if I do this. Oh, I know why. Sorry. Excuse me about that. Let me just.
Yeah, we have a lot of time now. You can take your own time.
I'm so sorry. Wait.
Yes.
I think I was at the end of my presentation, not at the beginning. So that's why it just ended. Now, so it should be. Okay, so I did the first page slide and now it's the second. Yeah, there we go. So this is the introduction to give you a little bit of context of the scale. So in interprofessional learning, according to WHO, provides students with the opportunity to learn and practice improving communication and collaboration skills through the learning experience with and from other professions. Interprofessional education leads to a more comprehensive healthcare, which makes its incorporation into healthcare very important. So this interprofessional education is defined as an activity that involves two or more professions interactively learning together to improve collaboration and quality of care. In other words, it optimizes skills and knowledge for a more effective collaboration practice centered on the patient, family, and communities. This increases confidence in their own professional identity and helps participants to better understand the roles of other professionals. Therefore, interprofessional education reduces prejudice and ignorance of the roles and duties that may exist between professionals from different areas, which increases understanding and improvement of their performance. So just to give a quick example of our just previous great presentation about, the cases, shown that, there you go, it's shown that it helps people to take difficult decisions, to support each other, and to feel like they are, you provided a better and a more comprehensive environment. I think there is this microphone that is open. So please, if you could silence it. Thank you. Well, taking into account that attitudes or readiness of learners is very relevant in the development of interprofessional strategies. Why so? Because to be able to learn interprofessional, it means that you need, as a student, for example, you need to get out from your comfort zone. Comfort zone that could be, you know, try to reach out to other students that you don't know, other profession, maybe that you have some prejudice or say preconception idea of their role. So you are stretching out by doing an interprofessional education and learning. So with that said, a relevant aspect in this direction has been the creation of this readiness for interprofessional learning scale. That measures or assess the willingness of students to interactively engage with other students in the learning process. It is said that you higher readiness or willingness, you higher probability of a successful implementation of a new procedure or new way of learning, a new way of perform different activities. The original Ripple scale have 19 items divided into 3 subscales focused on teamwork and collaboration, professional identity, roles and responsibilities. While this scale was later used by other researchers, establishing its usefulness to be able to assess the willingness to get involved in interprofessional learning among university students. And when we did this study, it was not had not been translated into Spanish. And as you know, we have many countries that speak Spanish that could be using this scale. In 2004 and 2005, the scale was modified to strengthen the third factor, roles and responsibilities, and explore possible new factors, such as focusing on the patient. So the final scale ended with 23 items and 3 dimensions. So with that background and that context given, we created this study with the objective or study aim that said to analyze the psychometric properties and validate the Ripple scale with 23 items in Spanish in nursing students at our university, a metropolitan region of Chile, for later use with nursing students from other universities, as well as with other students of healthcare careers or professions. As you see, just to highlight that the team, the majority were nurses working at the nursing school, but our co-PI was actually from the School of Education. Our universe were 593 enrolled students in 2006 attending the School of Nursing. The sample was 327 regular nursing students that were all from 1st to 5th level. We have 5 levels in Chile because our nursing degree is obtained after 5 years. And well, the instrument, I already gave you a hint of it, correspond to the Reed and Bruce Alpha recommendation, the 23 item scale. And it's a Likert scale of self-reported assessment, where the response category are 5, strongly disagree, disagree, neutral, agree, or strongly agree. And the 3 dimensions are actually collaboration and teamwork, sense of professional identity, and centrality in the patient. The validation procedure, let me see, yes. The validation procedure were performed in 3 phases. So we can see the first one is a validation by judges. This stage included translation and back translation, in which 2 bilingual people separately translated the scale from English to Spanish and then from Spanish to English, and both versions were compared. B, a cultural and linguistic validation was carried out with 5 methodological and thematic experts. And C, the face-to-face validation technique was used, in which the instrument was applied to 25 students, 5 from each level of the profession, health of nursing, who answered the scale and then participated in this focus group we created, where they were asked about their understanding of the items, the complexity, and the general appreciation of the instrument. These students were not included in the second stage with the massive application. So from the first stage, we were able to adjust the scale and make the final version for the second phase. And the third one is the data analysis, where we perform exploratory and confirmatory factor analysis. So our analysis plan was to ensure validity and determine if the theoretical factorial structure of Ripple scale was replicated in the Spanish version through these 2 procedures. The exploratory factor analysis used a random subsample of 171 participants that was taken and using all the test items. In the FA was implemented with Varimax orthogonal rotation using the method of iterated main factor. The estimation of FA was adjusted to a 3-factor model, theoretical model. The confirmatory factor analysis used another random subsample of 156 participants, and only with the items that were kept after the previous stages. Varimax orthogonal rotation, EPF method was implemented, and the test was adjusted to the 3-factor model. For the internal consistency of the instrument, Cronbach alpha coefficient was estimated in 2 stages. In the first, all the items of the scale and each theoretical subscale with all items were included. At the second stage, the alpha was estimated for the entire scale and each subscales, after eliminating the items that did not have good results in the factor analysis. Let's take a look at that. Of all the students, now starting with the results, starting with the descriptive one. Of all the students who were invited to participate in the study, 55.1% agreed to participate and responded in full to the survey. Regarding the proportion of students who participated per level of training, we can see this table that shows the level of the study from 1 to 5th year and the number of participants. So there was a fair and representative sample from each year of the profession, nursing career. About the internal consistency of the instrument, we can see that the reliability of the full scale 23 item is good, 0.8. And in this other table, we can see the Cronbach alpha of each of the subscales. So team and work collaboration had 0.82, patient-centered work 0.8, and sense of professional identity showed a much lower alpha, which is below the recommendation 0.7. Here we can see the, there we go. Here we can see the rotated matrix that shows the most of the items are grouped in the theoretical dimension in this table too. However, item T3 has a factor loading less than 0.3 in all factors and should be eliminated. In addition, item 5 and 11 have factor loads shared between factor 1 and 2, which are higher in factor 1, which is not its original factor. The item T6, T7, T13, and S15, although they are loaded in 2 factors, the graded weight is in the theoretical factor. There we go. There we go. There we have all of them. So through the confirmatory factor analysis, after eliminating items like T3, T11, S16, and moving the T5 to EP, it means, you know, the patient-centeredness, The three-factor model with 20 items has an acceptable goodness of fit with a normalized chi-square of 2.182. And why do we suggest to move the item T5 to patient-centeredness? Just to show you that this item asked the following: health professional work together to solve the problems. It is the patient who ultimately benefits. So it makes sense to be loaded on the factor of patient-centeredness. So these are the final conclusions. In this study, the 25 items version of the Ripple scale proposed by Reed was translated into Spanish, cultural adapted, and applied to nursing students from a Chilean university. 2 of the 3 subscales are reliable, and their items are grouped in a valid factor structure. However, it is necessary to make adjustments and improvement to the 3rd subscale. The full scale presented then good internal consistency, as well as for the other 2 subscales like teamwork, collaboration, and patient-centeredness. Not so for the sense of professional identity. So these values are slightly lower than those reported by Reed and other researchers that you can see there. They agree on having good alpha in the 2 first subscales and not so for the sense of identity. So Ripple may not adequately measure this construct sense of identity, given its complex nature and in which the experience of the respondent influenced the results. So the Ripple scale validated in this study has adequate reliability and validity for the dimension of teamwork and collaboration and work centered on the patient. It is required to develop new items for sense and professional identity. I'm sorry, went ahead. So the main contribution of this study is to make available to the academic community the psychometric analysis of an instrument to measure the disposition to interprofessional learning translated into Spanish and applied to Chilean students. It recognized inside of the limitations, it recognizes that the sample needs to be extended to a student from other professions in healthcare and ideally to other universities in order to have a greater diversity of experiences in the training of students and to carry out a validation on a larger scale. And that's it. Thank you so much for this opportunity to share this result. Below my name and degree, you can see my email if anyone is interested in taking contact and talk further about interprofessional learning and of course the Ripple scale. Thank you very much.
Yes. Any questions? Any questions to Dr. Lisette?
I don't know if anyone had used a Ripple scale before. Sorry, I'm just curious.
Just if you have any questions, you can. I'm in chat box. We will be playing behalf of you. Yes. Yes. Thank you very much, madam, for participating in this event. On behalf of Organizing Committee of Nursing Conference 2021, we want thank you for excellent presentation. Thanks for sharing your tips with us. Looking forward to meet again next time. Yes, we have got a compliments from Dr. Shanti as well as Dr. Edil Matok. Thank you for great work. Thanks for sharing. So we will have, meanwhile, just after this completion of your talk, we will have 10 minutes break. According to ED timings, it's around 7:05. We'll be joining around 7:15 according to EDT times and rejoin. After this completion of this break, we will have Dr. Gabriel as well as Dr. Ann will be joining the meeting and start presenting the talk. Just for 10 minutes of the talk break.
Hello?
Yes, sir. We will have after 10 minutes.
Can you see?
Yes, sir. Just you can enlarge it.
Good morning. My name is Garfield.
No, sir. We will have 10 minutes break and we will join you. We will have 10 minutes break. We are in break. Hello, sir. Just we have 10 minutes break. We can join after 10 minutes. You can start your presentation.
Can you see?
Excuse me, sir. Just we will have 5 to 6 minutes break and we will join the meeting. We are in break. We are in break. We will join for after 5 minutes. I think you understand.
Yes, 1 moment.
Just a 5 minutes break.
Can you see the presentation?
Yes, sir.
Yes.
Yes, sir. We will have only 5 minutes break and we will join the presentation. We are delay around 30 minutes delay of the program actually. So we want to cover it the program. Just for 5 minutes break. Yes, your presentation is visible on the screen.
The establishment of equivalent as during prison her can be traced back nearly 4 decades. According to this prison, prisoners shall have access to the same level of care a member of society alike. Equivalent is a right basic forward. It recognizes prison as a microcosm of society which link to the general community and the logical consequence of the high truth of the prisoner from a black to the community. The United Nations introduced the principle in the 1982 Resolution 37-194 and in the International Law and Principle 9 of the United Basic Principle for the Treatment of Prisoners. Prisoners shall have access to the health service available in the country without discrimination on the ground.
Okay. Can you hear me?
of the legal situation.
Excuse me, can you hear me?
Yes, ma'am.
We're on a break at the moment.
Actually, we are just. Yes, sir. Yes, sir. You can continue.
Oh, sorry about that. Sorry.
Okay. Okay, you can continue, sir. You can continue your talk.
Similarly, Article the third and fight in the European Convention on Human Rights strengthen nation obligation output indirect to preventing human and degrading treatment, ensuring adequate medical treatment and avoiding inappropriate detention for those with mental disorder. This obligation is recognized in the state duty of the care to the protected prisoner right to the heart, while ensuring rehabilitation is at the core of the prison agenda. Kidney disease. Chronic kidney disease is a substantial worldwide clinical and public health problem. CKD is a link to the high health costs, poor quality of life, and serious urban health outcome, including cardiovascular disease, infection, hospitalization, and mortality. Moreover, renal replacement therapy with either dialysis, both hemodialysis and peritoneal dialysis on kidney transplantation represent the economic burden of end-stage renal disease, with continue to grow substantially. Future projects and for an increasing prevalence of ESID globally, worldwide 2.5 million people we treated for ESID in 2015, and this number is projected to more than double to close to 5 million people by 2030. Case on this study from the 2018, we are developing a prisoner dialysis program inside. The critical point, there are very few articles about similar experience, and there are very few studies on the background. During the last decade is the recur to the renal patient as well. During the last decade, the frequency of hemodialysis is right weekly. The dialysis unit of the hospital San Paulo received the prisoner patient and they treated them under the security control and the several penitentiary policemen. Among them, we have 2 high-violent prisoners who need 6 policemen is for security. The hour is experience. This study is essentially a nurse-led service, and a prison is geographically isolated, but close relation and maintained with hospital renal service. We are observing different benefits on this program. Benefits the faster and responsive service and the great continuity of care, proximity and responsiveness in the treatment of the end-stage kidney disease, the reduction of hospital visits, the prevention and dignity and comfort of the prisoner, in knowledge, the reduction of cost. In clinical practice, we have no problem with the type of dialysis session poorly applied in the space of the long-term detention. The future goal, we want to continue the observation to understand the benefit of this process in the other registry, the outcome, and the goal is guarantee the best continuity of care according with the reduction of cost, transport, for example, or a system of policemen during dialysis session, in order to reinvent this serving in the interesting of the clinical logic. Thank you very much. Sorry about my English, but thank you very much.
Yes, sir, we do understand. Any questions to Dr. Gabriel? Any questions? If you have any questions, you can send to us. Even after the completion of this, after the completion of the conference, we'll be asking you behalf of you.
Okay.
Yeah, just to be online, sir. Just you got a. Yes, thank you very much, sir, for presenting. On behalf of organizing committee members of Virtual Nursing Conference 2021, we want thank you for inside presentation. Thanks to you for sharing your tips with us. Looking forward to meet again next time. We would like to inform you that Dr. Gabriel has joined this physical event in 2019, which was held in Italy. Thank you once again, sir, for participating in this seminar. Yes. Next, we ask Miss Annie Makondwana from Faculty of Health Sciences from University of Witwatersrand from South Africa to join the presentation and start presenting. I'm sharing opera. Yes, Dr. Annie, you can start your presenting, madam. You can start sharing your slide.
Good day. My name is Anne Mkondwane, an MPH graduate from West University. It is my pleasure today to present a research report submitted to the Faculty of Health Sciences, University of the Witwatersrand, in partial fulfillment of the requirement for the degree Master of Public Health in Rural Health. A study that was done in the Northern Cape Province titled Community Health Workers' Perceptions of Their Role in Primary Healthcare in Khasigonyana Rural District. Good day. My name is Anne Mkondwane, an MPH graduate from West. I will give a brief outline to the background, aim, methods, results, and conclusion. Primary health care is globally recognized as one of the effective strategies for the implementation of sustainable developmental goals. The global shortage of health workers in developing countries and rural areas of developing countries weakens the healthcare system. Community health workers are found to be and are recognized as an integral resource in addressing the shortage of health workers in healthcare. Who are community health workers? They are known by different names in different countries, such as lay workers. Their names have been influenced or related to the work that they do in their communities. The World Health Organization defines community health workers as members of the communities where they work, who are selected by their respective communities, answerable to the communities for their activities, supported by the healthcare system, but not necessarily a part of the organization, as they have been trained to some extent but do not possess a formal professional certificate. In the light of the shortage of health professionals in South Africa, to achieve universal health coverage, the South African government has restructured, calling it re-engineering its primary healthcare program, which seeks to address health inequity. The major strategy is ward-based primary healthcare outreach teams, which aim to offer preventative care and health promotion using multidisciplinary teams, comprising a professional nurse, a health promoter, and an environmental health officer, and 6 community health workers. Community health workers are an integral resource in the rural villages of Kgasigonyana, where access to healthcare services remains limited. The aim of this study was to explore the perceptions of community health workers, of their role regarding the services they render to the community, and their contribution towards strengthening primary healthcare services in Kgasigonyana local municipality. This was done. The importance of this is that community health workers' perception of their respective roles and impacts matter because this may influence the quality of patient care as well as have implications for healthcare cost. Variations in community health workers' perceptions of role and impact can have negative unintended consequences as well as positive impacts. This study utilized an exploratory research design to conduct semi-structured interviews with purposefully selected community health workers in Kgasigonyana. Atlas TI computer software version 7.0 was used for data analysis. Despite the lack of a written scope of work, the community workers were able to outline their roles and responsibilities as expected by their employers. In terms of their work as community health workers, the results indicated that they've had both good and bad experiences. Community workers perceive their training to be related to the nature of their work. However, there were no support system to assist them with issues like psychological trauma and other pertinent situations in which they find themselves. They perceived barriers and challenges pertain to ill treatment to which they've been subjected to by patients, lack of support system, lack of recognition for their contribution, lack of cooperation and collaboration from relevant departments and organizations and other stakeholders, lack of resources, and late payment of stipends. The recommendations are relatively easy, is that we provide ongoing training, not just at the beginning of their work, but we facilitate regular communication and coordination with ongoing meetings, not just when they are employed at the beginning. We provide community health workers access to counselors to deal with stress. And relatively difficult is that we improve interagency coordination within the government and we promote community awareness. Thank you.
Yes. Any questions to Miss Anne? Any questions? If you have questions, you can have in short. So, next talk we will invite. Just be online. Yeah, John. Thank you very much, Doctor, and thank you for participating in this conference, for sharing your tips with us. Looking forward to meet again next time. So, according to the scientific program, Dr. Jennifer, Dr. Autumn, Dr. Pamela, Dr. Gloria, as well as Dr. Evelyn, Dr. Catherine, Dr. Stacy asked to present their presentation. So, if anybody are ready with their PowerPoint, you can start presenting. So, we are just about 20 to 30 minutes delay of the actual program. So, we request if anybody, those who not given their talk, if you are ready, you can start presenting their talk, your talk. So we will go with Dr. Evelyn Austin Bell from Atlanta Black Nursing Association, the faculty of Embry College of Healthcare Science. So it is a video presentation we are going to play.
Hello, everyone. My name is Dr. Evelyn Bell, and my presentation is going to be on my dissertation research findings while at the University of Phoenix, which is exploring perspectives of legal nurse consultants as entrepreneurs. My research was born out of my work as a legal nurse consultant, or an LLC, and realizing that there was a lack of research related to the processes to become a successful nurse entrepreneur. Now, the objectives of my presentation is to define the legal nurse consultant role, to define entrepreneurship, and to identify the path toward entrepreneurship. A legal nurse consultant is a licensed registered nurse who uses the training and nursing expertise to consult on medical legal issues. When working as an LNC, there is an opportunity to function outside of the traditional nursing role and hospital setting. LNCs can be employed in law firms, in government offices, insurance companies, and hospitals. I have even gone to the state capitol building in my home state and worked alongside with legislatures and discussed some of the issues related to the healthcare system, specifically how they impact our nursing profession. Even though LNCs may perform outside of the familiar hospital setting, there remains the opportunity to advocate for the patient. Whether the focus is medical malpractice, personal injury, the determination for injury causation, correlation to a pre-existing condition, and adherence to practice standards will always lead back to the patient. The patient will always be our function, whether you're inside the hospital or working in some other capacity. An entrepreneur can be considered as someone who generates or establishes something new, someone who's innovative, a motivator, and does something different. Entrepreneurship for the legal nurse consultant is an opportunity to work independently and have the flexibility with time commitments. However, finding effective ways to make the transition to entrepreneurship is often a barrier to having a successful career due to the lack of resources and business acumen that's needed to be successful. An awareness of what to expect on the nurse's journey toward entrepreneurship would be valuable in determining how to proceed in the process. With the increasing complexities of healthcare, along with some of the associated increases in medical litigation claims, there is an increasing demand for entrepreneurship. Castellana emphasized that there's a demand for qualified and seasoned legal nurse consultants to meet the needs of those entities and organizations that employ legal nurse consultants. However, and very unfortunately, there is a lack of useful resources for the emergent legal nurse consultant, as research tends to focus more on the successes of entrepreneurs. The general problem for this study was to seek to address what was some of the high entrepreneurial failure rates. The specific problem is the absence of sufficient and applicable research that identifies the process for LNC entrepreneurs developing a successful independent practice. The purpose of this case study was to explore the perceptions of legal nurse consultant regarding the journey to become entrepreneurs. This research study provided a platform for successful legal nurse consultants to describe their personal journey while providing a description of those experiences with an exploration and an explanation of the spirit and essence of being a nurse entrepreneur. The study provided legal nurse consultants with a stage or the platform to discuss some of their personal experiences, present a conclusive depiction of those experiences, and provide an interpretation of what an entrepreneurial encounter looks like. There was one guiding research question for this qualitative case study. How do legal nurse consultants describe their journey toward entrepreneurship? This qualitative case study was based on the theoretical framework of Albert Bandura's theory of self-efficacy. Self-efficacy is at the core of Bandura's social learning theory, which includes the discernment that individuals make about the ability to be successful about a particular task and the ability to control situations and ambitions. According to Bandura, unless individuals have confidence in following through with their intended actions, there will be little motivation to persevere when facing challenges. The social cognitive theory proposes that the most important predictors of self-efficacy are expert skill, experience, verbal influence, and physiological and emotional conditions. Bandura's self-efficacy theory provides a framework for the entrepreneurial's commitment, intentions, and the ability to be a successful entrepreneur. Entrepreneurship is a significant component in the outlook for economic success. Working toward creating an environment that is more alluring and attractive for the entrepreneurs is essential. The current autonomy is not new to the profession of nurses. As nurses worked independently during the 1920s to meet the health care demands in rural areas. Wall found that less than 1% of registered nurses are included in the sector of entrepreneurial efforts that consist of the self-employed nurse shift from existing organizational positions. Opting to seek entrepreneurship was fueled by the restraints placed on nursing related to the ability to use innovative and creative ideas. Now, as we look at the literature gap, we have to look at some of the studies that examine business challenges for the legal nurse consultant, which are devoid. There are very few literature research studies that address some of the challenges that legal nurse consultants or even entrepreneurs experience. Studies examining the experiences of legal nurse consultants as entrepreneurs and the transitioning stages of development are lacking. Even though a lack of recognition was identified as a barrier to entrepreneurship, Wall confirmed that limited research exists related to entrepreneurial nursing. Further exploration is needed as to the depth of knowledge and experience related and required for professional development as a nurse entrepreneur. The qualitative approach allows participants to have a voice, which was found to be appropriate in the quest to explore the different perspectives which reveal the experience of legal nurse consultants. With exploration of the perception of legal nurse consultants regarding their journey to become entrepreneurs, the qualitative paradigm was used, as it was an opportunity for subjectivity while discovering what had not been seen or revealed before. The case study approach provided the how and why of events and occurrences while obtaining great insight into a case while permitting data collection from different sources. This approach allowed for productive and contextual information to emerge from in-depth interpretations of the entrepreneurial experiences. This exploratory case study focused on legal nurse consultants, which is a specific group of individuals. In the context of the legal community, legal nurse consultants act as trailblazers, which defy the status quo while modifying the nursing culture. This study's population was entrepreneurial registered nurses working in the United States as legal nurse consultants. The use of the legal nurse consultant population holding membership in the American Association of Legal Nurse Consultants allowed access to data. A purposeful sampling method was used for recruiting the study participants. The initial potential participants were identified from a specific Southeastern chapter of the American Association of Legal Nurse Consultant membership directory because of the accessibility of the participants. Additional participants were recruited from some of the northeastern and midwestern states to reflect diversity within the sample. The sample size of this study consisted of 8 legal nurse consultants who had participated or had practiced as an entrepreneur for at least 5 years. The study participants included a sample of 8 legal nurse consultants who were interviewed using open-ended questions that took place via Skype. Different data sources were collected and analyzed, which included participant interviews, a theme matrix, the researcher field notes, and the archival documents from the American Association of Legal Nurse Consultants. There was an alignment of the participants' responses with the theoretical proposition and related to the theoretical framework through pattern matching. The theoretical framework consisted of Albert Bandura's theory of self-efficacy. The participant responses were formulated by computer-assisted qualitative data analysis software, MaxQDA, 12th edition, from the interviews, the archival document from the AALNC, and the researcher's field notes. The responses from the interviews that were recurring topics included determination, confidence, the ability to work independently, responsibility, challenging, work flexibility, the need for financial solvency, the need for peer support or mentorship, the need for education, marketing, the need to network, provide attorney support, the need for diverse background, risk, and lack of support. Following the discovery of themes and the representation of experiences of entrepreneurial legal nurse consultants, an alignment with the central research question was determined. Exploring the participants' journey to entrepreneurship led to emergent themes of confidence related to performance capabilities and determination to be successful, which emerged during data analysis. The desired entrepreneurial path does not always develop or progress as planned. Having the resolve and the willpower to continue pushing forward despite obstacles is essential for establishing a thriving business. The determination of confidence and the belief in one's abilities resonated as an element and strong indicator for success as an LLC entrepreneur. All the participants believed that confidence was necessary to be successful with work performance, especially with the interactions that are required with developing and maintaining attorney relationships. Confidence was felt to be an expectation of the necessary skill set as an entrepreneurial legal nurse consultant. The research question was answered by the study findings. The research question queries, how do legal nurse consultants describe their journey toward entrepreneurship? It was apparent that an interrelatedness of themes is seen during the entrepreneurial journey. Bandura's self-efficacy theory brought meaning to the participants' insistence that having confidence and being persistent is required for success as an entrepreneurial legal nurse consultant. Confidence feeds the ongoing determination. The basic attainment or success of entrepreneurs is the desire to develop a new business venture, along with accepting risk, along with the journey to entrepreneurship. The entrepreneurial progression for the LLC participants started with their wish to be an entrepreneur. Self-efficacy can be found along the continuum to entrepreneurship development. The theory of self-efficacy played a role in the qualitative research, process in discerning the level and depth of entrepreneurial success. The theory of self-efficacy draws on the belief that individuals are contributors to personal situations and events rather than being a product of them. A positive result is likely for those entrepreneurs who possess a high level of self-efficacy with the ability to be successful. With the current and impending changes to the healthcare system, nurses are charged with diversifying their practice to integrate business astuteness. Continued awareness of known nurse practice standards is paramount to the LNC entrepreneurial practice. It is necessary to assess resources through the American Association of Legal Nurse Consultants as the organization that sets the LNC entrepreneurial standard. Entrepreneurship for the LNC is in a unique position to have a positive impact on the profession of nursing and the legal community. Developing a strong sense of confidence, especially when providing medical opinions, is very important to the leadership component and developing client relationships. Maintaining a strong sense of confidence of the entrepreneurial expectations, along with innovation and initiation, will help to develop leadership skills. Careful thought is needed related to the education of nurses that focus on innovative and entrepreneurial opportunities. Preparation for the entrepreneurial role is not evident in the nurse education programs. This study was significant to nursing in that research provided knowledge for nurses relative to the benefits of entrepreneurship while clarifying and providing specific information about entrepreneurship in nursing. Jahani and Wilson and their colleagues noted that the concept of the nurse as an entrepreneur is not usually related to the practice of healthcare and at first glance might not be apparent to the work of nurses. This study focused on the perceptions of the legal nurse consultants' experience as entrepreneurs and how those elements might expand into the profession and guide practice. With the availability and dissemination of the research findings from this study, nurse faculty in nursing education programs will be provided with resources to address entrepreneurship in legal nurse consulting as a specialty in nursing. The evolution of nursing roles and the diversity within the nursing profession, which includes entrepreneurship, will be apparent through this research and will be available to those who are in a position to distribute the findings. Even though nurses can enter this specialty without formal training, the American Association of Legal Nurse Consultants retain the position that nursing education programs should include legal nurse consulting as a specialty within the curricula. Registered nurses transition into many roles during their professional season, which undoubtedly includes the enhancement of leadership capabilities. The LNC entrepreneurial role emerges as a change agent, which is seen as a visionary, a decision maker, and the key to conflict resolution. Developing the leadership skill set that is enhanced with the entrepreneurial role prepares registered nurses with also having a voice at the table to impact change within the healthcare system. Entrepreneurship is an optimal role suitable for supporting the readiness of nurses for leadership in the changing healthcare climate. Having a determination and the initiative to lead for change is the goal, and the motivation for entrepreneurship. Research related to failed LLC entrepreneurial attempts might provide additional perspectives as to some of the challenges that are experienced during the journey toward entrepreneurship. A study that generates knowledge as to the worth of the LLC entrepreneurial is needed to give additional credence to the specialized practice. Such a study might obtain data from those that benefit from the services of the LLC. A duplication of the study with the use of a larger sample, as well as soliciting participants from additional regions in the United States and other countries, would be an opportunity to validate the study findings. The ability to compare and contrast the male and female perspectives as to the success and challenges would disclose additional insight into entrepreneurship. Some of the potential study limitations were the researcher bias. However, it was minimal through the process of preserving honesty and candidness of the data. During data collection, the selected American Association of Legal Nurse Consultant chapter ceased operations, necessitating a snowball technique. In addition to widening the sample to include the northeastern and midwestern states, the small sample size lessened the capability to generalize findings and was not anticipated to characterize the whole population of LLC entrepreneurs. The absence of the male perspective limited the ability to compare and contrast gender differences related to the entrepreneurial experience. According to Powell, passion is critical to work successes. There is so much independence as an entrepreneur. Feeling a strong desire to be successful is often related to the thirst and the desire for professional growth, to continue while pushing forward. Passion and excitement stimulate success and growth within business venture. I was amazed at the lack of the discussion and excitement by the participants related to the successes and growth of their practices. Yet I was inspired by the commitment to the LLC entrepreneurial role. This study provided a means for transparency while validating the entrepreneurial's path with a stronger understanding of the value of entrepreneurship. And here are some of my reference sources. I wish to thank you for joining me in this presentation and participating with me, sharing some of my study results. If there are any questions related to my presentation, they can be forwarded to lhoustonbell@gmail.com. Again, that's LHOUSTONBELL@gmail.com. Thank you very much.
This was the video presentation from Dr. Evelyn Bell from Emetech College of Healthcare from USA. So regarding the presentation from your side, if you have any questions, you can text in chat box. We'll be asking behalf of you. This was the video presentation. At present, she is not there in the Zoom meeting. Next, we asked Dr. Catherine M. Griffield from President of Healthcare as one of the keynote speaker for day one of the conference. Yes, madam, you can start sharing your slide.
Okay, I'm working on it.
Okay. Okay.
Let's see here. View. Start design. I'm just trying to get to full screen. There we go. Can you hear me?
Yes, ma'am.
Okay. So I'd like to thank everyone for having me here to speak on my topic, which is the long-term effects of workplace bullying on healthcare, as well as within our education systems. And so oftentimes people ask me why this topic. And I believe, and in my experience as a nurse, going back to when I was a nursing student, I have taught, I've been a dean of nursing, and I have my own independent practice. I have seen multiple incidents of abuse within our healthcare system, either laterally or horizontally, either by experienced nurses, or I'll talk about younger nurses today. And so I think it's an important topic to highlight what the problems are and what some recommendations are to create a better workplace and school environment for all practicing nurses and future nurses. I'd like to share an example I have that really sort of highlights this. When I was teaching several years ago, I had multiple students come running to my office just bursting through the door crying. It was like there was 30 of them, and I'm like, explain to me what has happened. And they were in class, and the teacher gave them a pop quiz, and they were really ill prepared for it. And I can understand the faculty's members being upset about that they, as fourth year students, that they diagrammed a heart, they had it upside down. And so her response to them was she started throwing packs of Smartie candies at them and told them to get out of the room and to go and learn to be smart. And when they were smart, they could come back to her classroom. It was really distressing what the students went through, and it highlights what people experience both in education and in the workplace, and where oftentimes administrators fail to act on these issues. So today we're going to talk about what is workplace bullying and how do we define it, the problem and the effects of bullying, and then, like I said, the next steps, because I think it's always important to understand what's next. So where do we start? We start with the end in mind. Failing to address the issues of bullying limit the contributions of nurses, both now and in the future, in our healthcare community. They will continue to drain our healthcare systems as we see good healthcare workers leaving practice, young nurses leaving, and the latest research shows that within the first 5 years of practice, we can lose anywhere between 40 and 50% of our new grads. So there's also an increase in the mental health issues of those who enter practice that has had sustained bullying while they were students, and also the mental health issues that correlate with those that undergo sustained bullying in the workplace. In order to create a positive and bullying-free work plans, firm places must be in place, both in our schools and our healthcare organizations. And it starts with understanding what are the types of bullying, what are the sources of bullying, and how frequently these are occurring. And as an administrator, I think one of the important things is that we survey. When I was doing my doctoral work, I did survey my nursing students about what their perceptions of a hostile environment was, what bullying they were experiencing. And I think that those are profound findings that really help us frame how we put together plans of success to prevent it and support those that have been victimized. Nurse bullying, as defined, is a systematic, pervasive problem that begins before nursing school and continues throughout a nurse's career. We've all heard, or should have heard if we've been around a while, that nurses eat their young. And this term, though Mies Bartholomew actually started talking about this about 15 years ago, research shows that this really goes back to the Crimean War, and why it started was this hierarchy of, as we develop professional nursing standards and we look at our nursing history, where some nurses that came into nursing really were not pillars of our community. And so there started to be this divide within nurses. And that's really, there is literature that goes back that shows that throughout history, this has been a pervasive issue. Microaggressions now include both older nurses bullying and belittling new graduates, where younger nurses are now bullying more experienced nurses. It's estimated that approximately 35% of employees surveyed in workplaces state that they have sustained some sort of lateral or horizontal bullying within their workplace. The American Nurses Association has estimated through research that they have done that anywhere between 18 and 31% of nurses have experienced workplace bullying, and 20% of first-year nurses quit the profession. So how do we define these things? So what is bullying behavior? Bullying behavior is a repetitive, it happens again, 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 again. And its intent is to harm the victim. Workplace bullying is repeated, health harming mistreatment of one or more persons by the perpetrator. Its abuse conducted can be threatening, humiliating, intimidating. It interferes in the workplace. I've seen when I was at the Board of Nursing working with the Director of Discipline, where some nurses have sabotaged other nurses to the detriment of their patients. Watson condemned bullying behaviors in nursing and says that anything that dominates and oppresses others is considered bullying. Bullying is unwanted. It reoccurs, and that's the important thing. It's not a one-off comment. It occurs again and again and again. I think what's really important to hear and understand, and research and data shows it repeatedly, is that where the problem lies is that we allow victims to stay in our workplace, and we're not supporting victims. Research shows bullies get promoted, victims leave. And that is an unfair situation to our nurses, our healthcare workers, and our patients. So what happens when people are recurrently victimized? It causes psychological and physical harm. It creates a psychological power imbalance between the bully and their targets. Bullying occurs at least once a week for a period of 6 months or more, and on average lasts for a period of 2 to 5 years. So mobbing, what is mobbing? Mobbing seems to me to be a more recent term. And what really mobbing is saying is that in the workplace, it's not just one person is targeting a victim, but it becomes a group of people targeting a coworker. They isolate, they humiliate, they're aggressive. So why do people join in these groups? And there's a lot of research about why people act in ways that they may normally not act. And they don't want to become the victim themselves, or there's professional jealousy. And bullying often involves others through coercion. And so if you have a boss that's bullying, then what happens is that you want to not be the victim what you see that boss doing to someone, so you'll often join in. I saw in one place that I worked that the boss who was the bully created a situation where people felt they had no choice but to be on her side, because their statement was, I don't want to be her victim. Nurses eating their young. And please note my disclaimer that not all younger nurses behave in the way that I'm going to talk about when I talk about younger nurses, and not all older nurses have eaten their young. So I think that that's really important. It's not in everybody's situation, but we do have a problem. So nurses eating their young is in reference to bullying, harassment, and victimizing nursing students, younger nurses, and generally perpetuated by older and more experienced nurses. Its direction towards students has been found in literature for decades, and there's a direct correlation between students who are being victimized and those students performing poorly in school and or withdrawing from school. I had students one time on a clinical unit, and this one student came to me very tearful, and I asked what had happened. And one of the nurses on the unit had been, and this had been going on, it was the first day she had reported it to me, would get her in the corner of a hall and just start picking at her. Who did she think she was because she was a BSN student? Did she think she was better than the LPNs on the unit? That she was never going to be a good nurse? And so in trying to talk to the nurse about what was going on, it was an ineffective conversation. And we had to take it to the nurse manager, who again failed to act. And then it became an administrator to an administrator discussion when that nurse was finally talked to and did have to apologize to my student. And when we go back to the mental health presentation from earlier this morning, is are we providing enough support to victims, whether they're students or employees? Microaggressions we see more and more microaggressions occurring across our workplace and within our school systems. So microaggressions are actions and comments that communicate a bias against a specific group. So if younger people are making comments about older people, or older people making comments about younger people, or if the BSN nurse is making comments about an associate degree nurse, or I've worked with some still diploma nurses who are outstanding nurses, and they are meant to feel less than by comments that are being made. So really a microaggression is a prejudice and an attitude and belief against a specific type of person, a type of group, etc. Nurse bullying is linked to older nurses bullying younger nurses. However, where's this change in paradox that I'm talking about with younger nurses now having microaggressions against older nurses? Is there's a change in the landscape in our workplace. So the baby boomers are retiring, older, more experienced nurses are retiring. And if anyone has followed the news over the past year, our oldest nurse, I believe she was 90, just retired this year, and only because of COVID. Bless her for practicing I think she practiced for 70 years, so bless her. But so we have a changing landscape, and we have younger nurses, and by a greater number of younger, less experienced nurses on units. And so oftentimes they call older nurses slow. And yes, younger nurses are much more efficient at technology and some of the new technology that enters our workplace. And they make assumptions that older nurses, their knowledge is dated. They ask older nurses when they're going to retire. So what do we need to teach? We need to teach respect and kindness. Newer nurses need to be taught that as educators, we can't teach them everything that they need to know. Those of us that have been nurses 20, 30, 40 years, there's a breadth of knowledge that we never learned in school, but we learned it at the bedside. And that bedside really, for those researchers who have presented today, really came out of bedside knowledge, that we have those aha moments. And so there's value in experience. Older nurses, on the other hand, should value the positive attributes of younger nurses bring to the workplace. And I think where that's important is when we teach evidence-based practice. But research shows it can be 15 to 20 years before evidence-based practice is the norm at the bedside. So what are our newer nurses bringing to the bedside, and are we listening to them? And are the younger nurses, are they collaborating with older nurses? And if we could just collaborate these two and have this yin-yang experience, think about the positive attributes within our healthcare system. Workplace violence accounts for 11% of deaths nationally, and were warning signs overlooked. And when we peel back the onion in investigations into our last speaker, our legal nurse consultant, thank you, because I am a legal nurse consultant as well. When we peel that back and we investigate, there were oftentimes, more so than not, warning signs that things were escalating. So 35% of American adults report that they've experienced bullying behaviors in the workplace, and 15% that they have witnessed others being bullied but are too afraid to come forward. Our students and our new nurses, 78% of students experience bullying in nursing school. That is a profound number. Over half of nursing students reported seeing or experiencing nurse-on-nurse bullying during their clinical rotations. And what students often say is they don't know what to do with that information. And that is our responsibility as educators, as administrators. What do we do? What is our reporting structure, and how do we support them? The Joint Commission on Accreditation of Healthcare Organizations found that as negativity and hostility increases in the workplace, errors increase as well. Medical errors are the third leading cause of death in the United States. So why is this going on? Well, stressful demands. And when we're looking at what's in the literature right now, what's coming out, this pandemic is not helping with the stress level in our workplaces. And I think we need to really pay attention to what stress, what burden that we're putting on our healthcare workers today. Globally, it is estimated that 142,000 people die annually from adverse medical treatments. The Institute for Safe Medical Practices say that 39% of nurses feel pressure to accept orders, dispense a product, or administer a drug despite concerns about safety. And about 50% of our nurses reported that patient safety had been compromised due to fears of dealing with difficult providers. What I don't have in there was just an article, and I believe it was in the Chronicles of Higher Education, where healthcare providers, nurse practitioners, PAs, and physicians are feeling very bullied by patients who are demanding treatments that are not, do not meet the medical standards of care for COVID, and they're demanding some of these treatments. And so they're feeling pressured to either dismiss the patient or just go ahead and prescribe it. More than 25% of nurses have linked negative behavior to patient morbidity and mortality. 1/3 to 1/2 of healthcare workers feel that there is a lack of effective management of hostile behavior. And in surveys of nursing students, that number is significantly higher. The Joint Commission has determined that only about 48% of hospitals are addressing disrespectful behaviors in a meaningful way. So when the complexity of dealing with bullying, lateral bullying, and hostile work environments, I think we have to start with what does the law say, and then where do we, what can be taken, where legal action can be taken, and where facilities just need to step in and do a better job with this. So harassment is protected. It's a legal characteristic so the conduct is intended to intimidate. It's hostile and it can be abusive. It interferes with the employee's ability to perform their work. However, bullying is not a legal actionable item. Bullying is about psychological power. Bullies are equal opportunity offenders. They often have more than one victim, and they often are able to take power and control of an environment and often discredit the victim. So if you think about, if you're in your hierarchy, if a boss, a manager, a vice president, a president is the bully, a nursing instructor, it is a power imbalance. And what happens is that they often have the line of communication up. So oftentimes by the time a victim comes forward, they've already been discredited as a whiner, a complainer, an incompetent, and so oftentimes then what they're told is that, well, you're just complaining because you're not able to do your job. You're failing your classes. This is a personality conflict. And so they are oftentimes not heard because the damage has already been done to their reputation. Bullying is a global issue leading to profound healthcare and employer issues. So 1 in 3 women often feel that they've been harassed or bullied, and 1 in 5 men. And I think in healthcare, and I do think the dynamics are starting to change, is that, we have more women than men oftentimes in our nursing profession. And so oftentimes men can feel more devalued because there's still some of the stereotypes out there about men in nursing. 20% of workers say that they've experienced sexual humor in the workplace. 22% feel that they have been threatened either physically, they've been assaulted, they've been touched, they've been demeaned. Mental health claims, and this is what's really concerning, is that our mental health issues, PTSD issues, physical issues are all on the rise with victims that have sustained bullying over time. Nurses are quitting. The mean girls are winning and nurses are quitting. There's a strong correlation between bullying and turnover rate of healthcare staff. And it's important for an administrator to realize that the cost of replacing a nurse is anywhere between $27,000 and $103,000 when you figure recruitment, training, retention. Workplace bullying is costly to an organization in terms of a turnover rate and recruitment and training. Workplace bullies are placing organizations at risk for legal actions from victims and victims' family. And when we talked about the more victimization that's going on, the more hostile work environment is, when that rises, so it rises medical errors. It puts a facility at risk for legal action. And I think the Me Too movement has really highlighted victims stepping up, stepping out, and taking legal action against not only the person that was the victim, but the organization responsible. Employees have to understand that bullying is not just somebody being picked on. It's workplace violence, it's psychological violence, it's psychological harassment, it's personal harassment, it's emotional abuse. Euphemisms intended to trivialize bullying is incivility, because incivility just makes it sound a little softer than what it is. It's violence. It's, you know, when you disrespect somebody, doesn't have the same hold as when somebody said that they've been a victim of violence. When people come forward that they're being victimized in the workplace, we've all heard it again and again. Well, X person is just a difficult person to work with. Or when employees come forward about their boss, oftentimes what they hear again and again is this is just a personality conflict. Workplace bullying equates to domestic violence. Violence is not tolerated by law. Domestic violence is a part of our healthcare assessment. Why is this tolerated in the workplace? Where is the protected assessment for victims, for our employees, for our students? The bully, who is the abuser, inflicts pain and violence. 50% of surveyed nurses said that they have endured yelling, cursing, outbursts, and or verbal threats from physicians. And when I was at the board of nursing with the director of discipline, there had been a nurse brought in for slapping a physician, and what came out during the investigation, it was in an OR, what came out during the investigation is that these nurses had repeatedly sustained not only being cursed at by this physician, but instruments being thrown at them, contaminated, physicians intentionally contaminating sterile fields to make the nurses reset things up. And I think that because they had complained repeatedly and the hospital had failed to take action, nobody's going to justify somebody slapping somebody, but this nurse was at the brink and lashed out. And that was not appropriate to leave her in that position. Workplace bullying, bullies choose their targets. So who's their target? And again, we talked about somebody that, you know, I have control over, somebody that I don't want to move ahead from me, somebody that's just brighter than I am. Bullying is acts of commission, doing things to others. Omission is, you know, withholding resources. So it really is domestic violence in the workplace where the abuser is on the payroll. So what are the healthcare issues associated with workplace bullying? There's lots. So there's psychological injury that can be lifelong, post-traumatic stress. So when we have short-term depression and anxiety, and what happens when people are victimized for a long time, or the victimization is so intense that people do develop post-traumatic stress disorder. And that's when they oftentimes leave the workplace. But oftentimes when they go to their healthcare practitioner, they don't report that their high blood pressure, their depression, their anxiety, their PTSD symptoms are related to work. They just go in and they just said, I'm having anxiety, work's a little difficult. And there's not the strong correlation that what is happening in the workplace. And there's no reporting structure. If a patient, if a student or a nurse or a healthcare practitioner goes to their healthcare practitioner, there's no assessment being done in that doctor's office, and there's no reporting of that event to anybody. There's an increased risk of self-harm. So we know that oftentimes people with suffering from mental health issues often to start self-medicating, and that can lead to harmful behaviors. Increased risk of suicide, stress disorder, risk-taking behaviors, etc., psychosomatic conditions. Bullying causes both psychological and physical harm. So again, anxiety, depression, stress, sleeplessness, neurologic issues, blood pressure, GI, heart. And so when somebody, all of a sudden at 50 years old has a stroke, do we necessarily say, well, he or she has been under a phenomenal amount of stress at work? We're not linking the two situations, and therefore I don't think we truly have a strong hold on what the outcome of long-term sustained bullying is. Victims of bullying are 3 times more likely to experience depression than those who have not. 50% of people surveyed that have been victims of bullying have considered suicide. 20% of those later died by suicide. There's a correlation between sustained bullying and post-traumatic stress disorder. 75% of employees are affected by workplace bullying on some level. Those numbers are phenomenal. This isn't just an issue here in the United States. I was asked when I've done presentations about this before, is this just an issue in the United States? So I've just highlighted a few countries, not all, but I think it would be really profound if, to do that type of research on what the global issues are and how they're similar and different by region. So in Japan, it's found that workplace bullying and harassment are driving women to seek mental health care treatment. In Australia, 1 out of 2 Australians reported that they have experienced bullying in the workplace. In England, bullying and sexual harassment epidemic is an epidemic in some hospitals. In England, they found that cyberbullying in the workplace has blurred the line between professional and personal life. And I think that's huge, and it's just really starting to take hold in literature, is that, technology comes and then the ethics and laws follow. And so we're always far behind the times of what do we do with technology on the legal ethical side of things. And so when people are targeting victims, it's oftentimes not just in the workplace, but social media has created this ability to victimize people in a global way outside of work. And oftentimes during investigations, hospitals, employers, and schools want to say, well, it wasn't on a work computer, that happened during off times, it's not employment related, and I think it needs to be. And those laws are not there yet, but I think that's something that we need to promote, greater laws to protect victims. In Ireland, the physical toll workplace bullying is a silent killer. Cardiovascular impact of bullying is similar to that of diabetes and alcohol. Workplace bullying is a silent killer because of the stress and leaving the victims with no place to go and report this and get resolutions, and provide them with services. So EAP, for those that have employee assistance programs or mental health services at their employment, oftentimes they're time limited, but these long-term consequences are not a 4 visit to a mental health professional solution. So what do? We have to take action. If someone's a victim of bullying, they need to talk to someone and get professional advice. They need to speak with the bully, but in surveying students and new graduates, oftentimes people don't know how to have those conversations, and it's very intimidating to do that. And oftentimes nurse managers and nursing instructors want to say, when a victim comes forward, well, did you go and speak to the person? Well, think if they've been sustaining over time victimization, how difficult it is to ask them to go back and talk to somebody. People should be keeping detailed documentation, times, dates, summary of events, what was said, what was done, because that does strengthen the case if action is to be taken. make formal complaints to human resources and tell people to keep copies of everything. And if needed, get legal advice. Management issues, lack of actions by employers, lack of action by reporting process. And there's inadequate laws. We need to change the laws. We need to look at our school policies. We need to look at our employment policies. Do we have effective plans in place to handle complaints, investigate complaints, remediate complaints, and provide support to victims? So what is the anti-bullying prevention program in your facility? And when I say anti-prevention, it's not just having a workshop about what bullying is and what we need to do about it. It's all those things that I talked about, the next step, now what? Intervention should be based on research. And I think it's always important to start with understanding what your problem is in your organization. It may not be the same in every organization, and tailor your interventions to the problem within that organization. And things take time, but I think that our schools, our workplaces need to show that we are taking these issues seriously, and we do have good action plans in place. Intervention should include specific training. So it's training, ongoing training, and those that are the victim, those that are the bullies, they need to go to very specific training. Workplace training needs to be how to communicate effectively, how to manage behaviors, how to reduce stress in the workplace, team building, not team destroying, what are reporting structures, and what are the victim's rights. We should be always, 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 always going back and reevaluating. Is our program working? Are we seeing a decrease in numbers of people that feel that they are being targeted or bullied? Is there less violence or the perception of violence in our workplace? When they persist, we need to say, what is wrong with our organization, and that needs to be fixed. And oftentimes it's best to bring in outside consultants at that point. Effective leaders. How are you supporting the recovery of your victims? How are you empowering reporting? Is it to a neutral place? Sort of like when we report Medicare or Medicaid fraud, there's an 800 number, or any insurance in different countries, there's always a process to report fraud. Child abuse, there's confidential ways to report that. Well, there needs to be a confidential way to report these issues. What's the value to an organization to have really good, strong plans in place, increase morale, work satisfaction, positive affect of students? We're going to keep students, we're going to keep employees, decrease risk of liability, and decreased errors. Human resources. This is one of my favorite topics. One of the big issues that I have is oftentimes when people go to human resources, if you work for a small organization, I had an HR director one time said, I'm stuck in the middle between, I know what's being said, I know what should be done. However, the president, who is the bully, he is the problem, but he's my boss. So I really am limited as to what I can do. So I think there needs to be independent investigations. I think human resources is great for hiring people, making sure policies in place, trainings are done. But when we have issues of this magnitude, there needs to be an independent organization outside of that facility sometimes to facilitate those things when there's no place to go and a human resource director feels stuck. Board of trustees, they have an accountability to their organizations, and are they doing their job? Sometimes with some organizations, I feel that the presidents fill their boards with their friends. And so oftentimes things don't get relayed to the board of trustees. And if they did, they're not going to unseat certain people because, you know, it is it's their friend. They don't want to lose their position. So I want to thank you very much. I hope that you had some positive takeaways from this presentation. If you need to contact me, feel free to contact me at any time. Thank you so much. Are there any questions?
Yes, ma'am. Any questions? Any questions to Dr. Catherine? Yes, madam, you are getting compliments from chat box. Excellent. Thanking you. Excellent job. Buying, selling too closely relation to narcissism. You can read from chat box, madam, after the completion of this your talk. I really appreciate that everything you done. It was a great presentation, madam. Thank you. I would like to inform you that Dr. Catherine is attending and managing our conference since last 2 years, which was held both Italy as well as Paris conferences as a keynote speaker for these conferences. Thank you for taking your busy schedule and joining this conference as a keynote speaker for this conference and managing the whole day of the conference. Thank you very much, madam.
Thank you.
So, next we asked Dr. Harma Zobazal from Salgado from Talca University from Chile to start the presentation. Yes, sir, you can start. Yes.
Well, thank you very much for the presentation. Good morning. Well, I'm from Chile, and I would like to talk about a research we did about one experience with the methodology called problem-based learning. Well, first of all, the problem-based learning is a problem-oriented educational approach that is commonly used in higher education. This basically consists of providing a group of students with a problem situation that they need to solve. And this methodology would eventually help them to acquire the necessary abilities and professional skills that they need for their future performance in the medical field in general. This is closely related to the way nurses work. So this means that the problem-based learning can help students to analyze situations, to work in groups, teamwork in general, with little information given. This means the problem situation is just a small piece of information given by the tutor that the students need to solve. They have to learn how to proceed and look for research, for evidence, and doing their research in order to provide some alternatives of solution. So this methodology allows the evaluation of generic competencies in the students. Thus, it's very necessary to incorporate this in nursing education, since this is an approach that is completely adjusted to what we do as nurses. In the PBL process, students are guided by a tutor. On these sessions, these meetings are called mentoring sessions. This consists of intentionally organized learning activities where the students are guided by the tutor. So the tutor at first provide a little piece of information about usually a patient or a family, and the students need to understand the general context, and from then they need to start looking for the necessary scientific evidence that they would need to solve. They would need to know in order to understand or to reach a better understanding of what's happening with that family and with that patient. So the problem has to be right in the middle between too easy and too hard. It shouldn't be too easy that the students could do it by themselves, or too hard that they don't have the knowledge yet. It has to be in a place where the tutor can help them to to infer what they need to do in order to proceed with the situation. Evaluating the PBL is multifaceted and comprehensive, so that involves many areas. And for doing that, standardized tools are required and encouraged. That's what it was done in the nursing school of the University of Talca by a team of lecturer nurses over a 7-year period between 2014 and 2021. So the implementation of this methodology in the activities that were done already in nursing education required a series of consecutive stages. Among them, rubrics to guide the process were created, and these instruments assessed autonomy, teamwork, self-assessment, and co-assessment skills. Each one of them were widely knowledge and spread among the students and, of course, the tutors. These instruments are reviewed by tutors and students on a regular basis, especially in the beginning of the process, where that means that's it 2014 and 2017. Then the rubrics were mostly adjusted and validated, sort of speak, and ready to be used with the students. So the students must use them as a tool to complete the PBL. They will know what is required for them to do in this activity due to the availability of these instruments. So the facilitating function of the tutor was performed during the tutoring sessions. So like I said before, the tutorials are meetings between the tutor and a group of students in charge of solving a given situation. These were third-year students, and it's important to note that nursing education lasts 5 years in Chile, the undergraduate nursing education. So the tutor is not only responsible to provide the initial situation, but also monitoring the process. So the tutor has an active role in that regard. After completing the PBL, students were graded and are commonly graded according to the rubrics that they already know. That has led to high quality work, which has been quantified in a scale. It's important to say that the institution, the University of Talca, follows a scale between 1 to 7, where 4 is being the minimum requirement, and above 6, that 0, it qualifies as very good. In this table, it's possible to see the main features of every period where the PBL was used. The average grade of PBL in all of these years has not been below 6.4. That means the overall experience, according to the rubrics or the process, more than the experience, was very good. So the number of PBL groups varied considerably, but it was in average 8. But in 2015, some changes were implemented. Every tutor had 2 groups in charge in order to have fewer students. per group. However, the experience demonstrated that due to the tutors' overload, having 2 groups to supervising the process was really difficult, and the quality could be compromised. That's why the entire team of tutors decided to stay with 1 group per tutor in order to improve and keep the high quality of this experience in general. Well, the implementation was a consensus. It was not one-sided. The process involved the students as well as the tutors. As I said before, the rubrics were elaborated and improved in common agreement with the students. So this was reciprocal and synergic. Tutors have multiple areas of clinical and professional expertise, and they use their expertise or their knowledge in order to boost and guide the situation. The experience of each one of them ranges between 13 and 30 years, and the areas of work, the background of every professional was from primary health care, mental health care, and hospital care in general, pediatric nursing care, acute nursing care, and so forth. The number of years that they have been performing the role of tutors has been no less than 6 years, between 6 and 8 years. So that means they already know the process, and since they have completed this cycle several times before this year, 2021. Well, the main objective of this case study was to learn about the experience of the facilitators or tutors between 2014 and 2021. In doing this, semi-structured interviews were conducted. So valuable information was extracted from these interviews and analyzed. These processes, the conversations lasted no more than 30 minutes. And the guided question was, what has been your experience as a PBL facilitator during all the periods in which you have participated? So basically, those were open questions, and the information was extracted by following, by guiding the process through an instrument called QDA Minor Lead Program. So the target population was the entire universe of tutors, which is 9 nurses. Thus, many different experiences were possible to note. From the content of the answers, some dimensions and categories emerged, providing clear and precise concepts of their experience. From the analysis, 4 dimensions emerged, and these are experiences, learning, instrument, and commitment. Each one of them with several subdivisions, and that we will discuss right now. Well, with the dimension experience, we have the category of facilitators experiences. They are between good and not so good. And well, we have some examples highlighted in each phrase portrayed in the presentation. For instance, the first one alludes directly to the current pandemics and the performance of the PBL under online education. So for one of the guides, the PBL was a very good experience during the COVID pandemics. It offered the opportunity to see the students more often than we used to do when we went to the university before this crisis. So the tutorials are always in common accordance with the students according to their availability. They also have other duties as part of their nursing training. So their time is limited to develop this activity. So the tutor has to be there for the students in order to remind them to go ahead with what they need to comply with regarding this activity. Well, the next one as a tutor must study in order to guide the students. I have been pleasantly surprised with their proactivity. This is important because the tutors need to learn about the process as well as the problem situation in order to provide scenarios according to what is needed for the students. They need to develop a wider perspective about nursing care in all the settings that they would eventually work as professionals. So the tutors have noted that the students are proactive. They propose solutions, they research, and due to that research, the tutors also learn from it. Since some things can eventually change, some processes in the clinical settings are boosted. And following that, we also have a sort of feedback and enrichment. But this is for another category. Similarities between the PBL groups. They are in general quite similar. All the students in the beginning are usually confused. They don't understand what they need to do. So further analysis of the rubrics is needed. Thus, the role of the tutor in that is active, an active one. Tutors need to explain the students what they need to do, the reason why is that, or why things are done in a certain way instead of another one. So due to the vast experience of the tutors by performing and guiding groups throughout this methodology, further feedback for the students and explanations is given in every tutorial session, especially in the first ones. All groups are formed with random students. The students obviously have they could have some fellow classmates or even friends, but in a workplace, that's not even possible. So the PBL is looking for encouraging the students to get to know others better throughout teamwork. So all groups are formed in that way, which allows them to learn from it. And they end up working quite well and knowing each other eventually. Tudor also noticed generational differences among the students. This was given basically due to the differences between groups from different years. And according to that interviewee, that was attributable to their generation. Some of them are more proactive, yet the most recent ones, not so much. So that's why that phrase was said. Differences were observed in the performance of students in 2021. This is a common idea which popped up during the interviews from many different tutors. So the differences were that the students in this year had fewer opportunities to acquire clinical experience. That's a hindrance due to the current coronavirus outbreak in Chile. Our students didn't have the chance to go to a clinical setting in their second year training. They had online clinical experiences, but not in place or in a clinical setting by assisting actual people, real patients. So that was in detriment to their overall performance during the PBL. So they ended up working very well and eventually learning from this activity, but it was not the same compared to the previous years prior to 2020. So more creativity was seen in students in 2020 who had the experience of going to a clinical setting in their second year of training. Well, I would like to remind you that these are third-year students. So, well, in 2021, it was very difficult for students to understand the methodology. It's always difficult. There is no difference, but this year, it was specifically more challenging for them to grasp what they needed to do throughout this process. So they needed more tutorials, they needed more involvement from the tutor that we usually did in the past. So that was something that we needed to take into account, especially this year, the second year of online nursing education. The students of the first group in 2014 focused a lot on looking for information. This is something that happened the very first year, where with little experience from the tutor as well as the students. So it's important in the beginning of the process of PBL education and training that the tutor is always there with the students and guiding them to set up their priorities in this process. Other difficulties were the productivity. And well, the interviews are part of what is needed for the students to be done during the PBL activity. They need to interview an expert nurse or an expert professional to provide evidence about what is done in a clinical setting regarding to their clinical situation, the situation given. These interviews in the past used to take place in the clinical setting with a small group of students that went there, physically there in those places and interacted with those professionals. This was not possible in the current pandemics, the last 2 years, but from one perspective, that was productive because the entire group had the chance to interview the person online in a video call or a phone call, whereas others claimed that the opportunity of not going to this setting was detrimental. So, well, the PBL stands out for comparing evidence with practice. That was more achieved in the past than it was now. It took more time for the students. That's another experience, another difficulty. PBL is good for disciplinary practice of nursing. It allows students to contrast theory with practice, which is one has to do in nursing in general. So this year, a lack of internalization of the nursing processes and this critical thinking was absent of the PBL. The self-learning of students is a key element of the PBL experience because this is the first experience of self-learning for the students. A significant one because they have initiative and propose solutions. But also this is a two-way process. The facilitator also learns. This is an enrichment upgrade because the tutors are working full-time in the academy, giving lectures and supervising students in clinical settings, but they are not directly involved in clinical settings anymore. So this is an enrichment upgrade of their knowledge, which allows them to be even better tutors and lecturers for the students. So this is a feedback. This process boosts self-learning even more from the tutors. And the current COVID-19 pandemics offered in the context of online education allowed the tutors to find out new strategies to keep up with nursing education successfully, including the use of the new technologies. The previous knowledge from tutors while before starting this experience was little. They didn't have previous knowledge, so they needed to take responsibility and actively looking for extra information about this in order to become and perform what they were supposed to do as tutors. Well, the comprehensive view is part of this process that we have already discussed. A clinical scenario is approached by the students from different perspectives. So this is a key element. The students will see and try to solve a problem situation. They don't have to reach a diagnosis though, but they need to proceed with a plan of nursing care. By doing this, they will develop their skills of giving a situation a second view and critical thinking. Teamwork is also an element that we already talked about. Teams are randomly formed. That means they have to learn. They have no choice but learning from each other and working together as a team, not as a group. It's not the same. The online PBL was a very good teamwork, especially when they were not allowed to work autonomously. Was a difficulty in this in 2021. They work autonomously, and this was divided. This opinion was divided. Some tutors thought that they actually worked autonomously, and that was a good thing. Yet others thought otherwise, that working autonomously was like working alone with a fragmented work as a result. So further guidance from the tutors is required in online education. So the overall product and the result of this, especially these last 2 years with online education, 2020 and 2021, was actually very good. Guidance is required. This is from the instruments as well, from the tools, assessing tools, are necessary in order to adjust the process according to the current contingent issues in healthcare system and nursing, the role of nurses in this context. Continuous improvement is by definition a key element of the PBL. So suggestions arise from meetings and from discussions among the tutors as well as the students that enable this process of continuous improvement. The assessment is according to the tools, and different ranges of assessment are proposed. Because this is a group activity or a team activity, they are assessed by teams with one exception, the co-assessment tool, because the students will assign each other a grade according to their contribution to the overall activity. But differences among these in their participation and their compromise in this have been seen by the tutors. That's why individual assessment is proposed, as well as more time to perform this activity, since the students have the chance to learn more out of this, way more than just giving them a class about a certain topic. Mentoring is also an opportunity for everyone to learn. The tutor who can guide the students on the way they should work by following the assessment tools, and the students learning not just as recipients, but also as an active character in this methodology. So in conclusion, this was a very good experience with some challenges during the current online education and COVID-19 outbreak in Chile specifically. So the tutors experienced personal satisfaction when students managed to motivate and commit themselves. This is satisfactory for tutors since they can see that the students really want to become good nursing professionals. They are empowered in their role as nurses, and they are encouraged throughout these activities specifically. Over the 7-year span of working with this methodology, several improvements have been made and implemented successfully. So we are pleased to share these findings with you in this presentation, because this is an achievement. Some critical aspects are described and they remain unmet. So the tutors expressed interest in making improvements, as well as evaluation, more time, rubrics, individualization of the process, among others. So the mentoring sessions are optimal. At least one early mentoring session is optimal for helping the students to understand the methodology. In other words, to improve in order for them to reach a better understanding of what they have to do as part of the PBL. Instructors proposed an individualized evaluation for every student, but further research about PBL and PBL assessment in nursing education is required, and we encourage that. In online PBL, well, students require further guidance from tutors. They cannot be alone. It has to be a middle point, a middle area where we need to be there for them. And they have to visit, ideally, clinical placements to interview an expert. So autonomy can be both good and bad, and that has to be encouraged, but supervised. And practical experiences of the students, previous practical experiences from them, is highly recommended to optimize the learning opportunities from this activity. So overall, all the improvements in the implementation of the PBL methodology would ultimately lead to the consolidation of PBL as a high quality and reliable teaching practice. So this would eventually help us to improve our profession and thus the nursing care provided. Well, I'm pleased to have had the chance to share this with you. Do you have any questions?
Yes. Any questions to Dr. Harmazabal? Any questions? Just if you have any questions, you can ask through chat box. We'll be asking behalf of you, even after the completion of the conference.
Okay, thank you very much for giving me the opportunity to be here.
Yes, thank you very much, sir. Thank you very much for participating in this event. On behalf of organizing committee members of Nursing Education 2021, we want to thank you for your excellent presentation. Thanks for sharing tips with us. Looking forward to meet again next time. in physical event if everything goes well in 2022.
Thank you.
Yes, yes. Next, we ask Dr. Stacy L. Losenberg from Southern New Hampshire from USA to start the presentation.
Welcome to the presentation, Lifelong Learning in Higher Education for Nursing and Health Professionals. I am Dr. Stacy Rosenberg. I'm an Associate Dean in Nursing. I've been in higher education for 22 years. Commitment to lifelong learning is an expectation for nursing and other health professions. Today, we will be discussing nursing and health professions continuing education initiatives at Southern New Hampshire University. This collaboration on lifelong learning opportunities is for online learners seeking degree and non-degree offerings with stackable credentials. The occasion to acquire additional just-in-time qualifications, which is required as healthcare evolves, can lead to increased quality of care provided and career advancement. Consider that current students will need to work until their mid-70s. Through 60 years of employment, they may go through many jobs requiring different skills. Dede and Richards, 2020, say that society must prepare them for career growth and change as part of a multi-stage life. Provision of opportunities and stackable credentials not limited to formal degrees and certifications are increasingly being sought, as indicated by Fawn 2020. As a university, we wanted to serve our lifelong learners by offering opportunities to upskill through various ways, such as micro-credentials, CEs, or continuing education offerings, to address shifts in workforce skills and the need for employee-based education, including soft skills, as learners need to develop and apply general-purpose knowledge and skills. As noted by Bleck and Joan Stank 2018, continuing educations provide rigorous content and development oversight, but with open accessibility. To address this changing environment in the nursing and health professions field, we identified the first initiative within our strategic plan. This learning model is called HEART, which stands for Higher Education and Real-World Training. Here's a bit of background on why it's beneficial to provide project-centered experiences for our learners. According to JobVite survey, 89% of hiring managers and recruiters say that competition is increasing. In order to be more marketable, our students need to have the skills employers are seeking. An internships.com survey found that 71% of students would be willing to complete a virtual project to gain knowledge, skills, and networking experience. The outcome when students participate in these experiential learning activities in conjunction with their courses are reflected in a recent Gallup study, which shows that 22% of graduates take 7 or more months to find a job. But when they gain experience while in school, It makes it 2 times as likely that they will land a job post-graduation. Conclusion? Career and academic collaboration lead to a strong, positive correlation for our students. HEART is delivered asynchronously as an experiential learning opportunity. It is non-credit bearing, optional, and provided at no cost to the student. The challenge takes place over 8 weeks. Since its inception, a variety of learning management systems have been utilized, demonstrating the flexibility of the model. In addition, an integral part of the model is that learners collaborate with employer partners to solve current workplace problems in need of a solution. The opportunity offers just-in-time learning experiences as a result. A recent challenge related to healthcare reimbursement exposes students to the need of chronic ventilator patients who are not often able to live in a long-term care facility due to the low reimbursement. This issue, while not new, became extremely timely with the need to transition these patients out of acute care hospitals during the pandemic. As learners collaborate with employer partners to solve current workforce problems, the employer is benefiting with just-in-time solutions. Our learners work in teams and are assigned to those teams based on their healthcare discipline and whether they are undergraduate and graduate learners. Each challenge includes 2 core competencies, and badges are awarded to demonstrate mastery of skills. Workforce readiness is a basic construct of the HEART model. The model provides structure and context for learning by providing a detailed challenge statement that defines the employer's issue. One example from a previous reimbursement challenge was an employee partner who was experiencing significant numbers of patients who didn't call or arrive for their appointments, leaving highly skilled and highly paid workers without the ability to generate revenue. As a result, patients who were on a waiting list were not seen, leaving a huge gap in the healthcare continuum. Students are supplied with scholarly and targeted resources within the course shell and use this knowledge to ascertain solutions to the employer's issue. During their teamwork, learners are also developing soft skills. Learners are networking with a potential employer in a private social media type platform that is embedded in the course, giving them experience in interacting with an employer. These structures literally close the gap between traditional coursework and workforce readiness. As Miller et al. 2020 noted, universities need to equip graduates with more than just skills and knowledge specific to their chosen field. They must also develop broader transferable capabilities. In the HEART model, workforce readiness is impacted in these key areas of technical skills, networking, and resume building. In the technical skills arena, learners develop project management, data analysis, writing, and presentation skills. Learners also analyze data and learn new tools such as SWOT analysis. Learners hone concise writing skills with a team executive summary and learn from each other when crafting PowerPoints to display their solutions to employers. Learners start to envision what their relationship with a business employer should reflect in the challenges. The badges they earn upon successful completion of each challenge can be stacked with the ability to receive prior learning assessment or PLA credit for a small fee. Finally, each learner now has additional skills that they can display and share on social media. Our careers team also assists them in crafting information about their challenge experience around teamwork, consultation, project management, and presentation for their resume. The topics of the non-credit bearing experiences were intentionally chosen to align with 3 graduate course credits. for nursing and health profession students. Learners demonstrate their workforce readiness within the challenge, and badges are awarded based on mastery of 2 or 3 competencies per challenge. These competencies are aligned with a minimum of 75% of the identified course outcomes. If students are interested in obtaining credit, as previously mentioned, they can use these for prior learning assessment using the stackable badging. One of our badges, Healthcare Reimbursement Strategies, demonstrates the skills listed on the slide. These skills, when clicked on, are linked to MC skills, EMSI, which create a common language between people, education, and employers, groups that have historically struggled to communicate according to the MC CEO. Employers want to know what skills to require in the job postings. Educators want to know what skills to teach in their programs, and job seekers want to know what skills to learn so they can succeed in the workforce. Targeted small chunks of education can help learners get a job. Now within MC, if you were to click on the financial analysis, you'd be taken to the skill definition. This is what the learner and potential employers have access to. Also included are job posting and job trends related to this skill. As part of this stackable learning pathway, progress is visible to the student throughout their learning, demonstrating organization of the requirements. Upon completion of each challenge, the pathway is uploaded, and the pathway progress is shareable. Our Nursing and Health Professions Department has been trailblazing within the university, establishing the badging design framework for the entire global campus. Note that on the left, within each box, notes a challenge. Those boxes with a purple line are linked to prior learning assessment and optional credit that can be available to them. And then finally, in the light purple box on the right, it demonstrates completion of the pathway, or basically a micro-credential, with the culmination being Graduate Healthcare Administration Professional 1 being issued. Here's an example of our badging, and we had indicated earlier that 2 challenges would equal 1 meta badge that can be used for prior learning assessment. So the white background is non-credit bearing, and the blue background badges can be credit bearing. Here you will see the 6 challenges listed above in the gold color, and you'll see that they're paired. So if you complete each of those challenges, the blue star indicates something that can be PLA'd, and that is a digital badge. Below that, students have 2 choices. They can pay a small fee and seek PLA, or prior learning assessment credit, and then they'll receive credit for a 3-credit graduate course. And they can do this for a total of 3 courses. The outer ring would demonstrate completion of the entire process and pathway leading up to a summit badge or the Graduate Healthcare Administration Professional 1. And here's an example of that summit badge that they're issued and can share. This slide depicts the expansion of the HEART model since its inception. On the left, we have partnered with social sciences and business verticals for additional challenges. which resulted in a planning and communication badge. The focus of this badge is on DEI. The middle section of the slide depicts the various alternated experiences that have utilized the HEART model during COVID. The model was adapted to serve as an alternate practicum experience following accreditation guidelines for the Health Information Technology Program, the Master's in Nursing Program, and for 2 psychology course internships. These alternatives have allowed hundreds of students to graduate on time during the pandemic. On the right side of the slide, this spring we launched a new product, the HEART Solutions Lab. In the Solutions Lab, students select from 6 experiential learning opportunities in which to participate in a small team. Each opportunity lasts 4 weeks, and students are presented with an employer problem, which can be completed in that shorter time period. Students are given a high degree of flexibility with the deliverable, and faculty serve in the role of facilitation only. For each solutions lab that's mastered, the learner receives a badge, and with the completion of 3 badges, they have the option to PLA for a course called SNHU 290, which is experiential learning. This can be used as an elective within their program. This provides examples of the need for the 3 badges, badge 1, 2, and 3. With the completion of those 3, you're issued a blue background badge, which is a meta badge, which is credit bearing, and then they can use that to PLA. This leads to a significant cost savings for the learner. HEART participants include global campus learners in the United States and global education movement learners, GEM learners, who live in refugee camps in South Africa, Kenya, Lebanon, Rwanda, and Malawi. HEART has a completion rate of close to 50%, a significant percentage considering HEART is optional, free to learners, non-credit bearing, and they're often taking HEART in addition to their regular coursework. HEART learners rate the experience as an 8.3 out of 10, and over 89% of the participants would recommend the model to a classmate. This model has won 2 national awards as well as a regional award. We are very proud of this model. Now, full disclosure, this initiative came with some challenges, one of which is our organizational structure and agility. We are an extremely large university, and initially we struggled to find the right people to help us move toward our goals. Finding these individuals was essential in helping us to build out more lifelong learning opportunities. Another example of a struggle that we encountered was keeping HEART organized with all of its moving parts. A standard operating procedure, or SOP, was needed to keep us on the right path and timeline. These lessons learned all helped us as we continued to expand opportunities. These opportunities will be described next. Continuing upon the success of the HEART model, a second initiative to provide continuing education hours to individuals, internal and external to Southern New Hampshire University, while addressing trends in the field. There's potential for PLA credit also within this opportunity with a stacking option. Again, CEs, or continuing education, provides rigorous content while maintaining accessibility to all learners. One of the successes of this initiative is that we became accredited in 2017 by the American Nurses Credentialing Center so that we may issue contact hours. Since that time, we've issued over 1,400 contact hours and 600 participation credits. One example of what you can do with continuing education is this 4-part series which provides career preparation through the development of 21st century skills needed in the healthcare arena. The response for this has been overwhelming. This shows how students value these types of opportunities. The final opportunity I'd like to share demonstrates how we continue to use the digital credential to prove workforce skills. Global health competencies were integrated across the RN to BSN curriculum, and upon mastery of the competencies, a badge is issued for students to share with potential employers, showing how they're in the process of upskilling. It has been a fantastic journey as we explore the area of continuing education to support the needs of our learners. Thank you for allowing me to share our journey with you as we move to meet the needs of lifelong learners in our field. Now we will open up for questions. Also at this time, please feel free to share what you are doing at your university. If you'd like to discuss these opportunities in greater details, please email me at s.rosenberg@snhu.edu. Thank you.
Yes, this was a presentation from Dr. Stacy Rosenberg. If you have any questions related to this talk, just mail us. We'll be asking behalf of you to the Professor Dr. Stacy. So, another keynote speaker of the day one, we asked Dr. Pamela Trister from New York Institute of Technology from USA to start the presentation. The title of the talk will be Critical Thinking in Nurse Students, the Impact of High Fidelity Stimulation and Debriefing.
Good morning. Can I share my screen?
Yes, madam. You can start your
Thank you. Thank you. I'm just trying to get everything from the full screen. Here we go. Okay, good morning. My name is Dr. Pamela Triester, and I am a clinical associate professor at the New York Institute of Technology in the USA. My topic today, which I will be speaking about, is critical thinking in student nurses, the impact of high fidelity stimulation and debriefing. I've been a nurse a long time, and whether you are new to nursing or have been a nurse for quite a while, you may notice this wonderful mannequin from years and years and years ago. Stimulation has changed through the years, and this is Mrs. Chase, and she was one of the very first mannequins that were used to demonstrate skills, and we were able to learn we were able to learn from her, really, what should we do to best help our patients? Now, this is back in 1911 when this was first discovered, but we still are using stimulation today. And these are some simulations that we are using. We know that we can use the vein the arm and the vein in order to start IVs, draw blood. We do use Annie and Annie is used for CPR. And these are some students in a simulation lab. So we are bringing this more into the School of Nursing. So now, why do we do simulation? Okay, we do simulation in order to reinforce nursing knowledge. We usually do have lectures or didactic presentations for our students. Thankfully, we are back to live didactic information because COVID seems to be edging away from us, so now we can all be in person. We were doing this virtually. However, when we had the lab, we needed to have students come to campus and do actual lab skills. You can't listen to breath sounds on a computer screen. You really need to have a simulation with either yourself, your patients, or to be able to listen to the mannequins. We want to determine best nursing practices, basic things such as providing privacy, washing your hands, identifying yourself. These are the basics to any nursing care. We want to help the patient to think on their feet. If they see something, can they go through their Rolodex in their brain to try to figure out what would be the next probable and possible step? We want to help the students with critical thinking, reinforce SBAR communication, which I will go into again in case you're not familiar with, and determine if students can meet competencies. We often have students demonstrate a head-to-toe assessment, a focused assessment, or give medications and show us that they can be competent in the simulation lab. We don't want their only experiences to be with patients. I wouldn't want to be their first patients that they actually start an IV on or have never given an injection. We want them to have that practice before getting to the clinical field. Okay, so low fidelity versus high fidelity simulation. Low fidelity means you have a static mannequin. It's just a patient in the bed. They do not respond to the student. What very often happens is the instructor is in the room with the student and they're constantly prodding the student, okay, what would you do next? What would you do next? What if this happened? What if that happened? And the student does not have direct experiences as if it was a patient. However, such a thing as low fidelity is great for practicing skills. We can tell our beginning nursing students, your patient has considered to have some bronchi. What would you do? What is a basic skill that you could do? And they may be asked to perform some chest physical therapy. And more advanced student may be asked, okay, can you demonstrate suctioning? And these are just on static mannequins. High fidelity simulation takes it one step further because the patient can then interact with the student. What happens, at least in our simulation lab, is I have a control room and I speak through the microphone and then I am responding as the patient directly to the student. I can ask the student questions, I can complain, I can say anything I want that will help provide patient interaction, and the student is more aware that they're speaking to someone, quote, live. The instructor is in the room, but that instructor acts as a nurse practitioner. They may be asked to clarify some orders. Sometimes we have medication orders that may not have a route. So we want them to know, hey, I can't just give a medication. I need to have a complete order. So we're checking that they know the rights of medication administration. We have vital signs and a cardiac monitor as well. So high fidelity brings the simulation to a whole new level. One of the things I mentioned is that, yes, we can actually demonstrate competency and the students can show that they know what they're doing and can meet the expected health complication that the patient may have. We want them to do this in the simulation lab so they are not only more confident when they go to clinical, but we are confident when they go to clinical as well. We want to also see that they have critical thinking, which is the objective analysis and evaluation of an issue in order to form a judgment. Now, as nurses, and I'm assuming that we are all RNs and have been out in the fields at least a year, if not longer, we know that we have been using critical thinking forever. And in using critical thinking, we could go right away. It's like, okay, we have a flow chart in our brain, and our flow chart is saying, okay, this would be the next probable step. But we also need to know, what can we do and how can we get there? So students are asked, okay, what is critical thinking to you? And they look at you like you have 3 heads. But we just keep telling them it is assess, assess, assess. Organize your information. We're going to do a head-to-toe evaluation or a focused assessment. We're not going to start at the feet and work our way up. We're going to see what the patient has a problem with, look at the evidence, look at the chart, look at the lab values, determine what's going on with the patient, and then communicate this so we can then go to the next step of treatment. It really is breaking down thinking in a step-by-step process. When you have a beginning nursing student, they may have critical thinking, but they're not as aware of their critical thinking abilities. SBAR communication, this is essential. In using SBAR communication, we tell them that you always need to use this when you are giving reports, especially if there's a complication with your patient. So this is something that they relay to the nurse practitioner. Let's say they have a patient who is having difficulty breathing. So they may call the provider, whether it's an MD, a PA, an NP, or whoever is providing, a hospitalist, whoever is providing the primary care for the patient. They need to identify what the problem is. They may call the provider and say, okay, I'm taking care of 89-year-old Mrs. Jones. She's having some difficulty breathing. These are the vital signs. She has a history of congestive heart failure for the past 3 years. And this is what I found. And now what do you want? You can't just call someone and say, okay, what do you want me to do with that information? You should have some idea of, okay, I'd like you to please come to the unit to see your patient. The patient is not doing the same as they were this morning when I got report on the patient. Or if the patient is vomiting, let's do some blood work so that way we could check what the electrolyte levels are. So this is all part of SBAR communication. We get this ingrained in our students from the very beginning. We do this as a matter of fact, but they have to learn this. You always assume your student does not have any experience and then let them prove us wrong, that they have critical thinking, that they're looking ahead to see what can I anticipate a problem will be. So the goals of simulation is to enhance limited clinical experiences, especially for those students who are brand new, because we have to assume they don't even know how to identify your patient properly. But also in light of COVID, in the United States, many of the hospitals shut down to all nursing schools when the pandemic was unfortunately killing so many people. In New York, we had many times deaths over 800 per day. And those were situations where hospitals did not want any students in the hospital setting. So we had to do a lot of simulation, give them simulation programs, and they were all approved by New York State because we need these things to count towards their clinical hours so they can sit for their RN boards. Okay, low fidelity simulation can mimic hospital simulations. It may be that you're just saying, okay, the patient's having difficulty breathing. Maybe they are very edematous. Patient is having abdominal pain. It's just very minor things that we can do, but we can build on those thoughts and those clues. In high fidelity, we are actually directly responding to the patient. We use simulation in a lot of different ways. At my current position as associate professor, I am also the simulation coordinator and lab coordinator. So those two hats fit very, very well with simulation. Each semester, we do have our students doing simulation, even if it's for basic breath sounds, heart sounds, head-to-toe assessment, and we do medication administration. This is to make sure that they are following all the proper protocols for giving medication. Okay, in maternity, we try to have a maternity simulation at the very beginning before they even go into the maternity units. And what we do concentrate on is, remember, we have to have SBAR communication. We do a med-surg maternity where the mom has postpartum bleeding, has a history of diabetes and asthma. But if the student does not communicate that the patient has a history of asthma, the patient would be given Hemabate. Hemabate will help stop postpartum bleeding. However, in patients with a history of asthma, it can cause status asthmaticus. So if the patient does not have this communicated, the patient winds up dead. And now when we further debrief, we will then show the student, because you left out this in your SBAR communication, now this family has a newborn without a mom, maybe other children in the family, maybe a significant other, and now they're not here anymore because they're dead. Someone did not communicate properly. We do pediatric assessments of the newborns. We know that diabetic moms typically have larger babies. We also know we need to know about this diabetic mom because the baby tends to be hypoglycemic once they are delivered. So we have to watch that as well. We do use a psychiatric simulation where we can use our patient, and I'm in the control room, with visual and auditory hallucinations, and the patient gets a medication which they suddenly have an allergic reaction to. So they have to know how to treat emergencies. And usually we have a standardized patient that comes in who is bipolar, pretends that they actually know the person, trying to distract the students. So usually a student will say, okay, let's go out in the hall and let's sit and talk to the incoming bipolar patient so they can control the situation. For med-surg, we have fresh post-ops with NG tubes, with dressings, need pain medication. We do have med-surg with the geriatric population. We don't want students to call their patients honey or dear. We must have signs of respect for our patients wherever they are, whether in simulation or in the hospital setting. And then sometimes we have our patients that have some dementia issues. So they may say, oh, this is a wonderful hotel. I like the hotel uniforms. It's such a nice place here. And we have to have the patient reoriented as to what's going on. I typically have a patient who's 99 years old who I am speaking for from the control room. And they asked me for my date of birth. I said, oh, I'm 99. I'm so old. Does it really matter? And they have to demonstrate that they know how to identify that patient when the patient cannot help them. And unfortunately, we do need to have end-of-life scenarios. Usually we put this with pediatrics and community nursing, where there is maybe a bicycle accident or a car accident, and now we have a child that was previously healthy that now has brain injury and eventually brain death. And we need to be able to work with the parents in order to help them go through this terrible tragedy and grieving process. So again, competencies that we're looking for are SBAR communication, health assessment, mental health, maternity, newborns, and then we have specific medication administration rubrics. And what we wound up doing, we had a change in our program from when I was doing my doctoral work. And we had medication administration with knowledge retention. The students would learn medication administration, and then the following semester, they would say, oh, you know, I never learned this, but they really did. And they demonstrated it. So we would do competencies the semester after they learned medication administration to see if they retained that knowledge. We didn't have the time to reteach them. So they have to remember things as they learn them. Okay, why is debriefing necessary? Debriefing is one of the most important things. Simulation is great, but if you don't talk about it, then you're going no place fast. They can't just come in and say, okay, thank you very much for your time. Now, next group of students. So the students will be encouraged to self-assess when you go through debriefing. We use high and low fidelity with our debriefing. So if we're fortunate that we can use the high simulation, that's wonderful. And we want the students to realize that this is a safe environment. We also, or at least I always run the simulations there, I make them promise not to say what's going on to the next group of students. And I always tell them, listen, you weren't prepared in advance of what to expect. And we want everyone to get that same experience. On our simulation day, we have now been using a clinical day. So instead of going to the hospital setting, the students come to the simulation lab. And we are very fortunate to have a simulation lab as well as a nursing arts lab. So the group of 6 or 8 students will come in. They will get reports in the regular nursing lab where we have our static mannequins. They do not communicate with the patient. We may have one that's in for a hip repair. We may have one that has a chest tube. We may have one that has an upper GI bleeds. And I will dress up the mannequins to these situations. So they are in the nursing arts lab, and then we call them in 2 to 3 students at a time. They give report for their static patients, and then they come into the simulation lab to do the high fidelity simulation. So when they come in, they are expected to do medications. They're expected to do a head to toe assessment and act appropriately with whatever our patient is stating. Okay, our expectations is that they are competent and they can actually see what's going on with the patient and start to interact with our patients. Now, part of their skills is to not only know the medications, but to explain to the patient why they need the medication, what we're looking for, and when they're supposed to be getting the medications as well. So as the patient, I'll be asking them these things. These are some students that are getting reported on a simulation day. Here they are preparing some medications. And here's one of our professors helping them with breath sound assessment. Maybe the student hears something, but they're not quite sure. We have always told the students, listen to the patient. If you hear something, excuse me, if you hear something and you don't know what it is, that's okay. You don't have the experience, but you recognize when something is not normal. When they practice listening to each other's breath sounds and heart sounds, they hear clear breath sounds, they hear normal heart sounds. If in a patient they hear something that's not normal, they should please get their instructor and say, what is going on with this patient? I never heard this before. And that's really how a lot of the learning does happen. We teach them the normal for them to realize something is not normal. Okay, some barriers. Now, unfortunately, we have to make sure that the students do not have barriers to simulation. They may be very nervous. They come into the room and like, oh my God, oh my God, oh my God, what's going on here? They think right away, this is not good. Some students can't get over the fact that we are in the school building in our sim lab. So they have to really buy in that there's a real patient. This is definitely easier with high fidelity simulation, because that way the patient is responding directly to the student. They don't know what the patient's going to say. They cannot predict it. They may be very uncomfortable, especially if the patient's status changes from when they come in. Suddenly they're realizing they have a lot more responsibility, and they don't always look at the patient. They look, but they may not see what's actually going on. So having this simulation and then debriefing is important. Okay, prior to coming into simulation, I have the students come in. I orient them to the room. I show them the patient. I show them where the chart is, the medication chart, where the keys are for narcotics. They are able to take a quick look at the patient, but they are given their chart so that way they can be familiar with blood work, what doctor's orders or patient orders we have in the chart, and that way they can ask questions. And if the student is going to give medication in the simulation room, they must choose the right medication. Of course, if they're giving an injection, the right syringe and needle, confirm the dosage with the professor, that's the NP, and administer the medication. Now, our professors are wonderful. If the student is making a medication error, they will allow it in the simulation. In real life, in the hospital setting, we will never allow that because students cannot give any medications without their professor. But in simulation, they are allowed to make mistakes to see what the next steps would be. Okay, so we want to see that the students are coming in, they knock on the door, they answer, hand hygiene, introduce themselves, why are they there, identify the patient with 2 unique identifiers, and assess the patient, focused assessment, and continue to care for the patient, especially if they complain of pain. Okay, the most important thing for the day is that I emphasize there is no failure in simulation. So even if they accidentally make a med error, or they do not follow instructions, or the patient has a very bad outcome and they die, it is a learning experience. And if the patient dies, which many times they do, I bring them back to life before the students leave the room. So they realize, okay, this was simulation. Hopefully they got why they were doing what they were doing. We want to make sure that the basics are done. Sometimes students forget to do hand washing, provide privacy, put on gloves. Did they identify themselves? So these are the things that I start off with in debriefing. Let's discuss what was good. Did we do this, this, and this? Did they check the patient's ID? Did they check the IV that it was the correct fluid and for this patient? And was it connected? Many times I'll just put up an IV bag with tubing and never connect it to the patient to see if they're going to notice that. I will not play around with incorrect information regarding patient IDs and their chart. Those I always make sure will match. And then we discuss what happens if something doesn't match. Okay, what was the scenario about? What were the patient complaints? What happened? We go through step by step by step, asking the students all the different things. So debriefing can take at least 20 minutes. This whole scenario may take 10 or 15 minutes, but the debriefing could take at least 20 minutes. So this is a typical scenario that I give to our junior students. We have a 28-year-old patient who was post-op day 1 from an emergency appendectomy. Not a typical difficult patient. The patient's in bed, has an IV for fluids, has a Salem sump, ordered to low intermittent suction. Abdominal dressing is dry and intact. Patient is NPO because of the Salem sump. However, the tube is kinked and it's not hooked up to low intermittent suction. Patient constantly asks for PO meds and water. Patient has no significant mental health history, med surg history, not an IV drug abuser, not looking to be a drug seeker. And medications ordered are Percocet PO or morphine 3 milligrams IM Q6H PRN. So this is your typical non-emergent patient. The students come in, they read the chart, hand hygiene, and the patient, me, in the control room, is complaining of terrible, terrible, terrible pain. I'm a fresh post-op. My dressing is dry and intact because they do check that. They identify the patient, and the patient is screaming and writhing in pain and wants pain pills. They want PO meds. Now, of course, we keep a cup of water and a pitcher at the bedside because most patients have that. But this patient's NPO. Will the student notice that the patient cannot have anything by mouth? Very often, they will still try to give them PO meds. Now, PO meds with a patient that has an NG tube or a Salem sump that's kinked will not do well because the patient's going to start vomiting. So, of course, with the vomiting, the patient has the pills come up, and then they said, oh, no, I can't give you meds. I can't give you ice water. And the patient's really very, very, very consistent. excuse me, that they want ice water. They're very, very thirsty. They haven't been allowed to eat or drink. With this, the patient starts to vomit. And if the patient is vomiting, and believe me, they vomit a lot, sometimes the students forget to put on gloves, or they forget to get a basin so the patient doesn't vomit all over themselves in the bed. So sometimes I'll get carried away. Ew, that's disgusting. Don't you think you should put on gloves? Or, oh no, I think I vomited all over your shoes. Just to get, and as the patient gets more and more agitated with pain, the students start to get very much into the scenario. So they are asked to be doing a focused assessment, especially abdominal. They need to look at the patient. Patient has the Salem stump directly in front of them. They can see it. Excuse me. But they do not see it. They don't see it actual. There's an IV. It may not even be hooked up to the patient. We will go through step by step what needs to be done as we debrief. Excuse me, just a moment, please. Okay, did they do the non-nursing things? Identify themselves, identify the patient. How did they react when they spoke to the patient? Were they respectful? Did the patient's concerns become an issue? Did they decide, okay, let's go hang out at the medication clinic and ignore the patient? Because they get nervous and they don't want to deal with things that they don't understand or know. What actions did they take? Why does the patient have a Salem stump? We go through that. Why do they have this? Why is it necessary to have it on low intermittent suction? We go through basic anatomy. We ask them what happens when they haven't eaten all night and they get up and don't they feel that their stomach is growling? What's in the stomach that's causing them to not be feeling well if they're not eating? Isn't there hydrochloric acid? Hasn't the patient just had surgery? Shouldn't they be getting all of that out of the patient through their intermittent suction? If they gave medications, did they give the right one? Now, this is where the problem sometimes is. We have students that will pick up the wrong concentration of morphine, or they may be picking up a sub-Q needle when they're supposed to be giving morphine IM. So a sub-Q injection needle is not going to be the same as someone getting morphine IM. What happens if they overdose the patient? Maybe they picked up a concentration and they didn't read the bottle properly. And maybe they gave 3 times the amount of the morphine. Of course, if that happens, the patient goes into respiratory arrest. Do they know what to do with this patient? Do they realize what's going on? Do they know that they need to give Narcan? Do they know that they need to call a code? And if they call a code, did they do CPR properly? And now I am implementing that in one of the scenarios when they're in for simulation, the patient winds up expiring. And with that, I check that they know how to do CPR and can they do a good face seal with the ambu bag? Do they know that they need to put the bed into CPR mode? Did they call for help? All of these things are gone over during debriefing. In case this patient is fine, I have a very old patient that may just say, I think I'm going to close my eyes. And the patient actually passes away. And they still have to do CPR because we do not have a DNR order on the chart. So either way, they're going to wind up doing CPR and being able to use an ambu bag. And I make sure that each person in the scenario will practice and demonstrate this. Our ultimate goal is to have knowledgeable, competent, and safe nursing students who are on their way to become competent, knowledgeable, and safe registered nurses. I was very surprised at one of my simulations to receive this email from a student. The student wrote to me, and I, of course, shared this with my chairperson, and she shared it with the dean. as well as the director of the medical school, even up to the president of the university, to show how our students were truly impacted by simulation. The student wrote, "Hi, Dr. Treaster. I just wanted to reach out to you and thank you for the past Monday for the in-person simulation we had. It was honestly an eye-opener for me, and I felt like in the span of 4 hours, I was able to learn so much about myself and really explore a part of me I haven't seen before. I haven't felt that feeling of hopelessness in a while, and to feel that and then troubleshoot it and try to control was honestly one of the best experiences I've had in the whole program. Don't get me wrong, it was extremely stressful in the heart of the simulation, but afterwards, when we were debriefing, I really felt like you helped us paint a clear picture with goals and checkpoints for us to succeed, not only in the lab, but as a future nurse in general. Just wanted to thank you. Thank you for the opportunity, and thank you for constantly pushing us to become a better version of ourselves. This was an experience I will not forget. I'm happy you were there to guide us through it. This is why we do this. Not to get a thank you note from the students, that they take this experience away with them and can reflect on it in the future. Now, we will bring the patient back to life. And something that I do discuss with the students is second victim. And explain, especially if there's been a medication error or if there's a problem, what do you do if your patient dies or has an untoward effect? And if this happens, what can we do to make you comfortable in your own skin to ever practice nursing again? So we speak to them that they need to know, the first thing is admit what happened. They should never hide or run away from whatever error they may have done. If they do not admit there's a problem, that's when they're going to get fired. We want to be able to provide them with counseling, because sometimes when a nurse has an untoward effect and it was through a medication error or a lack of action on their part, they can actually slip into a very severe depression. We want them to watch out for each other, and we want them to get help, because we don't want that nurse to leave the nursing fields or, heaven forbid, actually cause them self-harm. And that is something that can happen with any nurse, especially one that has caused patient demise. So we want to be very careful, and we do speak to the students about this because we don't want that to happen with them. Okay, I have a simulation here, a very short simulation video that I'm hoping I'll be able to bring up here. Just give me a second. New share. Let's see if I can get. I just wanted to show this one video. For the nursing department. Simulation lab coordinator for the nursing department. Welcome to the simulation lab. Communication lab is essential to nursing education. Students can have patient interaction with nurse area is essential to nursing education. Oh, I'm so sorry. Okay. Oh, I'm so sorry.
Yes, madam. If you want to share the video, you can must stop sharing the screen, then share with audio.
I'm sorry. Can you help me? I want to be able to show this. Oi. 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 Okay. I'm so sorry. Here we are.
Yes. Will you share your link to our email ID, madam, so that we can play behalf of you? Yes, ma'am. Are you going to play from your side?
Okay. So if you, I don't know how live this is, but if you have any questions, you can send me an email, which I have on the screen. I really do appreciate your attention with all of this. And I hope that you got something out of it. And hopefully you'll be able to use simulation and debriefing in your own institutions. And the students are filled with wonder and ideas. And they really do enjoy this experience throughout the nursing program. Thank you very much. I really appreciate your time and attention.
Yes. Yes. Any questions to Dr. Pamela Tristel? Any questions? Just if you have any questions, you can ask in chat box. We'll be asking behalf of you. Any questions? Yes. Thank you very much, madam, for joining as one of the keynote speaker for this event.
Thank you very much.
Yes.
I really
Yes.
appreciate it.
Thanks for sharing your tips with us. Looking forward to meet again next time in physical event if everything goes well.
Thank you very much.
Yes. Now I would like to welcome Dr. Gloria Doroff from the Office of CNS from USA and join the meeting and start presentation.
I hope that I can get my technology up and running today. But I am a nurse assistant, Gloria Doro. And I would like to talk about that CNAs on how they are future nurses. Okay. I do have a PowerPoint. I'm going to try to pull it up. Oh my God. But until I can get it connected the way I'm supposed to, I guess I'm just going to just go into that changing diapers saves lives. Okay. So, you know, CNAs the foundation to nursing is CNAs. We are the hands-on to the patient. We do the dirty work. We have the bedside etiquette. We, during the COVID, we are the ones that are actually feeding the patients. We still bathe them. So we cannot, even, say that 6 feet distance. We can't even practice that, because I really think, I don't think it's a joke, but, I think that, it's impossible to practice 6 feet when my job is to take care of COVID patients. So our job is extremely important. And a lot of people, they shame our scope of practice. But a good nurse, and this is just my opinion, a good nurse always has a CNA foundation, if you ask me. But actually, my foundation is home health care and then CNA, and then next level will be nursing. Now, this is just my personal opinion, because there's no way that you can really have that empathy for the patient or the resident unless you have practiced the hands-on with them. We are not afraid of the COVID. When people come, when they come and visit their family, they would like to see a well-groomed family member. They don't understand what all had to go through. We had to go through to get them on that level. And a lot of times it's not done to a spirit of excellency because of the shortages. We're not getting along with, our coworkers or our nurses. It's very stressful, our job. But it's extremely important that when a nurse is coming into the field of nursing, that she understands on a level of the nurse assistant. Because as I say, that when you go to school and you take the CNA test and you know about the heart, the blood pressure, you got all that down pat, but your hospitality or your ethic is not on point. We're not getting along with each other. And then we are told to go in the room and treat the patient like royalty. And I think that it's absolutely not. I think that CNAs and nurses need to, we need to get along. CNAs need more training because we need more training as far as not the academic part, not the academic part of the situation, but the bedside etiquette is what we need. Okay, more training and not all the time. When my CNA career has been based on CNAs being the trainer, not so much of the nurses, because we know how to work the Hoyers, the Stanlips, if the CNAs, I mean, God bless a nurse that have an assistant, because when it was Florence Nightingale, okay, she did everything. She did the cleanup. She got famous because she was finding out that all of the all of the soldiers were dying because of the sanitation problems, not so much of their wounds. So when she was given the go, she got approximately 30 other women, and they were nurses. It wasn't all, like it is now, hard to get in nursing school. You're gonna die or die trying to get through nursing school. It wasn't all of that. It was just a woman that had a calling from God that said, I'm going to go and answer the call. I'm going to answer the call. Yes, I'm going to answer the call to nursing and taking care of patients or wounded soldiers or individuals that were vulnerable to not being taken care of. So she answered that call. The CNA was in the nurse already. Okay, so there was no assistant. When she got to the hospital, there was all type of feces all around the hospital. She got in there, she got to work. So that taught me that nobody is above changing dirty diapers. Okay, so she was the CNA, and she was a nurse. So that nurse was already the CNA. So the CNA job, God has blessed the CNAs with the jobs. Thank you. Thank you very much. Okay. And also, God has blessed the nurse, because you don't have to do all of the other, work. We do it. We just ask for our scope of practice to be respected. That's all. We have had, some nurses say they didn't go to school to change diapers. I mean, if no CNA showed up, I mean, you would be doing that, and that would be kind of difficult for you to do that. We are your assistants, which makes us the next nurse. Okay, so I think that we need that extra training. I'm going to try to see if I can put this PowerPoint on. Okay, let me see. Okay. All right. Okay. CNAs are future nurses. Yes, we are. We make the best nurses because we can have empathy on both sides of the coin. Okay. And I'm so happy. Well, the COVID either worked for you or it worked against you. This right here is what caught everybody off guard. Okay. Most of the residents were affected by people coming in. That's why I'm not afraid to go into the hospitals and the nursing homes with the people that have COVID, long as I know how to protect myself, because we the ones that are transferring the poison to them or the disease to them. Most of us, because of this. Okay, the CNA is in the nurse. We already talked about that. And the Florence Nightingale, she had the backing of William Farr and John Sutherland. They was the Sanitary Commission. They assist Florence Nightingale into the Army data. Okay, because they was like, what's going on? And when she looked into the data, she discovered that it was 18,000 deaths, but 16,000 were not due to the battle wound, but it was due because of poor sanitation. Okay. Florence, she was appointed by the Secretary of State of War. Sidney Herbert. Okay, so he the one commissioned her to take the nurses to the military hospital. Okay, so that was a blessing. Okay, so for the first time, the troops were treated with decency and respect. I found that very interesting. So nurses are supposed, and CNAs, because the CNA is in the nurse, they're supposed to treat the residents or the patient with decency and respect, but also you got to treat your coworker with respect. You got to treat the CNA with respect. You cannot beat us down and then say go in there and do an excellent job. You have to respect me as your assistant. Okay, you have to appreciate me. And I do appreciate my nurses too. Don't get me wrong, I do, because they are leadership and they are the role model and they are the ones that's going to make CNAs want to be CNAs, or they're going to be the reason why CNAs don't want to go into nursing. And we do need our more nurses. God bless nurses with CNAs. We are their assistant. Okay. We are practicing social distance. So that's what that is for. Also, this is also practicing social distance as well. There is life in changing dirty diapers and sanitizing equipment. I sanitize my equipment for each patient. If I have to do vitals, I sanitize where they put their finger, where they put their arm. I do not transfer I don't transfer my equipment from patient to patient. Even when they use the toilet, you know that our staff, our cleaning staff only comes in from 6 to 3 or 4, and they're gone. So really, and they're not going to double back on the rooms. So in between patients, wipe down that toilet. These are things that I think that, that we're missing, in school or whatever. Even the handles to their sit-ups stands and things like that. Their sit-to stands and the Hoyers, the handles. And I even worked at some places where we were required to sanitize their hands before eating. Okay, there's approximately 1,942,258 certified nurse assistants in the U.S. 82% are females. That don't surprise me. God has blessed women to get out in the work field and make a way for our families to eat and take care of the families, especially in this day and time where, we have so many single moms in the home. And then the males, 13% are males. When you have a male CNA, it's like, yay, because the work is going to get done in half the time. They're going to come in, they know how to pick those patients up. And a lot of women surprisingly prefer males CNAs to take care of them. Then most of the time they're extra careful. They don't really get in. They probably don't be on point a lot sometimes like us women, but if you just let them know what to do or what they short of doing, they usually don't have a problem with doing it. I do have a problem with how the turnover for nurse assistants are going, because I didn't realize what the problem was until a nurse instructor came in with her crew, and she said, we was like, ooh, the CNAs, it's getting, kind of messy. It's getting, not so professional. She said, it's our fault. And I was like, what? What are you talking about? And she said, sending them to school for 5 weeks is like absolutely no. So people are turning in, the whole nursing business is turning into a business, and we are getting away from care, okay, and empathy, okay. We are politicking. We are politicking and things like that. But I just want to say my foundation was based on when I was a home health care aide. I started out being a home health care aide in a Jewish program. I had 8 weeks training. I had to take a test to get in the program, 8 weeks training, and it was like 9 to 5. Okay, 2 weeks. I had 2 weeks of clinicals. And I was so mad when I got finished with the class and went on to be a home health care aide. And then I found out CNAs was 8 weeks, and I could have just did that. But never did I understand at that time that I was building my career, okay, to be great, to be excellent. Because as a home health care aide, I was used to giving that patient my one-on-one care. And I started off in home health care. I didn't start off as a CNA. With the speed, you got to get up, you got to get them ready, they got to be here, there. I'm just used to the one-on-one training, and I'm still like that today. Okay, I do not rush. So you got 8 weeks of CNA, supposedly. So then they cutting it down to 3 weeks. I talked to a person, they said they only did 3 weeks. How are you a CNA in 3 weeks? How are you a CNA in 5 weeks? Okay, so that's the reason why we have so much of the unprofessionalism, the lack of training, because we're trying to get a body in there. We're trying to make a big turnover and get that body in there, and we are lacking the training. Just because you pass the CNA test, that don't make you a CNA. Just because you pass the nurse exam, that don't make you a nurse. I'm sorry. But as you work and get along and learn from your coworkers, that's what's going to develop you. That's what's going to change you. But you still have to spend some time in school. And when I was in class, I failed my first class. And my teacher said, I failed you for 1 point. And I said, oh my God, if you just let me make up a homework page. She said, no. She said, no. She said, I'm even sorry I told you about the 1 point. So I had to find another $1,000 and go through the class again. And I'm so glad she did that to me, because I take my CNA license very seriously. People will hire you. They'll tell you that you need a CNA license, but you're not giving me my credit for the state. So sometimes you forget about that because you're glad you got a job. Then your CNA lapse, and you're no longer certified when you went through all of that to be a certified nurse. So this is my information. And I'm just actually I'm building for the students how to be an excellent CNA. Okay. I'm take very good pride in my job, and eventually I'll probably become a nurse. Okay, so if anybody have any questions, you can, here's my information. You can contact me through this. through my website or through my email address, for sure.
Yes, yes, madam. Any questions? Any questions to Dr. Goliera? Just if you have any questions, you can raise your hand, you can ask. Yes, madam, you are getting compliments from chat box. Thank you, Natalia. Very interesting and informative. Impressive, working towards being an excellent CNA. Sharing your perspective and opportunity for CNA.
Thank you.
Yes. One more thing, madam. Thank you for your message for frontliners COVID-19, madam.
Okay, thank you.
Our committee is better because of you. You are a part of it.
Thank you very much.
Yes, yes. I really appreciate you, everything that you have done. On behalf of organizing committee members of Nursing Education 2021, we want to thank you for instant presentation. Thanks for your sharing tips with us. Looking forward to meet again next time. Yes. Next, we ask Dr. Evelyn Austin Bell from Atlanta Black Nurse Association faculty, as well as for Emetic College of Healthcare from USA.
Hello, everyone. My name is Dr. Evelyn Bell, and my presentation is going to be on my dissertation research findings while at the University of Phoenix, which is exploring perspectives of legal nurse consultants as entrepreneurs. My research was born out of my work as a legal nurse consultant, or an LLC, and realizing that there was a lack of research related to the processes to become a successful nurse entrepreneur. Now, the objectives of my presentation is to define the legal nurse consultant role, to define entrepreneurship, and to identify the path toward entrepreneurship. A legal nurse consultant is a licensed registered nurse who uses the training and nursing expertise to consult on medical legal issues. When working as an LNC, there is an opportunity to function outside of the traditional nursing role and hospital setting. LNCs can be employed in law firms, in government offices, insurance companies, and hospitals. I have even gone to the state capitol building in my home state and worked alongside with legislatures and discussed some of the issues related to the healthcare system, specifically how they impact our nursing profession. Even though LNCs may perform outside of the familiar hospital setting, there remains the opportunity to advocate for the patient. Whether the focus is medical malpractice, personal injury, the determination for injury causation, correlation to a pre-existing condition, and adherence to practice standards will always lead back to the patient. The patient will always be our function, whether you're inside the hospital or working in some other capacity. An entrepreneur can be considered as someone who generates or establishes something new, someone who's innovative, a motivator, and does something different. Entrepreneurship for the legal nurse consultant is an opportunity to work independently and have the flexibility with time commitments. However, finding effective ways to make the transition to entrepreneurship is often a barrier to having a successful career due to the lack of resources and business acumen that's needed to be successful. An awareness of what to expect on the nurse's journey toward entrepreneurship would be valuable in determining how to proceed in the process. With the increasing complexities of healthcare, along with some of the associated increases in medical litigation claims, there is an increasing demand for entrepreneurship. Castellana emphasized that there's a demand for qualified and seasoned legal nurse consultants to meet the needs of those entities and organizations that employ legal nurse consultants. However, and very unfortunately, there is a lack of useful resources for the emergent legal nurse consultant, as research tends to focus more on the successes of entrepreneurs. The general problem for this study was to seek to address what was some of the high entrepreneurial failure rates. The specific problem is the absence of sufficient and applicable research that identifies the process for LNC entrepreneurs developing a successful independent practice. The purpose of this case study was to explore the perceptions of legal nurse consulting regarding the journey to become entrepreneurs. This research study provided a platform for successful legal nurse consultants to describe their personal journey while providing a description of those experiences with an exploration and an explanation of the spirit and essence of being a nurse entrepreneur. The study provided legal nurse consultants with a stage or the platform to discuss some of their personal experiences, present a conclusive depiction of those experiences, and provide an interpretation of what an entrepreneurial encounter looks like. There was one guiding research question for this qualitative case study. How do legal nurse consultants describe their journey toward entrepreneurship? This qualitative case study was based on the theoretical framework of Albert Bandura's theory of self-efficacy. Self-efficacy is at the core of Bandura's social learning theory, which includes the discernment that individuals make about the ability to be successful about a particular task and the ability to control situations and ambitions. According to Bandura, unless individuals have confidence in following through with their intended actions, there will be little motivation to persevere when facing challenges. The social cognitive theory proposes that the most important predictors of self-efficacy are expert skill, experience, verbal influence, and physiological and emotional conditions. Bandura's self-efficacy theory provides a framework for the entrepreneur's commitment, intentions, and the ability to be a successful entrepreneur. Entrepreneurship is a significant component in the outlook for economic success. Working toward creating an environment that is more alluring and attractive for the entrepreneurs is essential. The current autonomy is not new to the profession of nurses. As nurses worked independently during the 1920s to meet the health care demands in rural areas. Wall found that less than 1% of registered nurses are included in the sector of entrepreneurial efforts that consists of the self-employed nurse shift from existing organizational positions. Opting to seek entrepreneurship was fueled by the restraints placed on nursing related to the ability to use innovative and creative ideas. Now, as we look at the literature gap we have to look at some of the studies that examine business challenges for the legal nurse consultant, which are devoid. There are very few literature research studies that address some of the challenges that legal nurse consultants or even entrepreneurs experience. Studies examining the experiences of legal nurse consultants as entrepreneurs and the transitioning stages of development are lacking. Even though a lack of recognition was identified as a barrier to entrepreneurship, Wall confirmed that limited research exists related to entrepreneurial nursing. Further exploration is needed as to the depth of knowledge and experience related and required for professional development as a nurse entrepreneur. The qualitative approach allows participants to have a voice, which was found to be appropriate in the quest to explore the different perspectives which reveal the experience of legal nurse consultants. With exploration of the perception of legal nurse consultants regarding their journey to become entrepreneurs, the qualitative paradigm was used, as it was an opportunity for subjectivity while discovering what had not been seen or revealed before. The case study approach provided the how and why of events and occurrences while obtaining great insight into a case while permitting data collection from different sources. This approach allowed for productive and contextual information to emerge from in-depth interpretations of the entrepreneurial experiences. This exploratory case study focused on legal nurse consultants, which is a specific group of individuals. In the context of the legal community, legal nurse consultants act as trailblazers, which defy the status quo while modifying the nursing culture. This study's population was entrepreneurial registered nurses working in the United States as legal nurse consultants. The use of the legal nurse consultant population holding membership in the American Association of Legal Nurse Consultants allowed access to data. A purposeful sampling method was used for recruiting the study participants. The initial potential participants were identified from a specific Southeastern chapter of the American Association of Legal Nurse Consultant membership directory because of the accessibility of the participants. Additional participants were recruited from some of the Northeastern and Midwestern states to reflect diversity within the sample. The sample size of this study consisted of 8 legal nurse consultants who had participated or had practiced as an entrepreneur for at least 5 years. The study participants included a sample of 8 legal nurse consultants who were interviewed using open-ended questions that took place via Skype. Different data sources were collected and analyzed, which included participant interviews, a theme matrix, the researcher field notes, and the archival documents from the American Association of Legal Nurse Consultants. There was an alignment of the participants' responses with the theoretical proposition and related to the theoretical framework through pattern matching. The theoretical framework consisted of Albert Bandura's theory of self-efficacy. The participant responses were formulated by computer-assisted qualitative data analysis software, MaxQDA, 12th edition, from the interviews, the archival document from the AALNC, and the researcher's field notes. The responses from the interviews that were recurring topics included determination, confidence, the ability to work independently, responsibility, challenging, work flexibility, the need for financial solvency, the need for peer support or mentorship, the need for education, marketing, the need to network, provide attorney support, the need for diverse background, risk, and lack of support. Following the discovery of themes and the representation of experiences of entrepreneurial legal nurse consultants, an alignment with the central research question was determined. Exploring the participants' journey to entrepreneurship led to emergent themes of confidence related to performance capabilities and determination to be successful, which emerged during data analysis. The desired entrepreneurial path does not always develop or progress as planned. Having the resolve and the willpower to continue pushing forward despite obstacles is essential for establishing a thriving business. The determination of confidence and the belief in one's abilities resonated as an element and strong indicator for success as an LLC entrepreneur. All the participants believed that confidence was necessary to be successful with work performance, especially with the interactions that are required with developing and maintaining attorney relationships. Confidence was felt to be an expectation of the necessary skill set as an entrepreneurial legal nurse consultant. The research question was answered by the study findings. The research question queries, how do legal nurse consultants describe their journey toward entrepreneurship? It was apparent that an interrelatedness of themes is seen during the entrepreneurial journey. Bandura's self-efficacy theory brought meaning to the participants' insistence that having confidence and being persistent is required for success as an entrepreneurial legal nurse consultant. Confidence feeds the ongoing determination. The basic attainment or success of entrepreneurs is the desire to develop a new business venture, along with accepting risk, along with the journey to entrepreneurship. The entrepreneurial progression for the LLC participants started with their wish to be an entrepreneur. Self-efficacy can be found along the continuum to entrepreneurship development. The theory of self-efficacy played a role in the qualitative research process in discerning the level and depth of entrepreneurial success. The theory of self-efficacy draws on the belief that individuals are contributors to personal situations and events rather than being a product of them. A positive result is likely for those entrepreneurs who possess a high level of self-efficacy with the ability to be successful. With the current and impending changes to the healthcare system, nurses are charged with diversifying their practice to integrate business astuteness. Continued awareness of known nurse practice standards is paramount to the LLC entrepreneurial practice. It is necessary to assess resources through the American Association of Legal Nurse Consultants as the organization that sets the LLC entrepreneurial standard. Entrepreneurship for the LLC is in a unique position to have a positive impact on the profession of nursing and the legal community. Developing a strong sense of confidence, especially when providing medical opinions, is very important to the leadership component and developing client relationships. Maintaining a strong sense of confidence of the entrepreneurial expectations, along with innovation and initiation, will help to develop leadership skills. Careful thought is needed related to the education of nurses that focus on innovative and entrepreneurial opportunities. Preparation for the entrepreneurial role is not evident in the nurse education programs. This study was significant to nursing in that research provided knowledge for nurses relative to the benefits of entrepreneurship while clarifying and providing specific information about entrepreneurship in nursing. Jahani and Wilson and their colleagues noted that the concept of the nurse as an entrepreneur is not usually related to the practice of healthcare and at first glance might not be apparent to the work of nurses. This study focused on the perceptions of the legal nurse consultants' experience as entrepreneurs and how those elements might expand into the profession and guide practice. With the availability and dissemination of the research findings from this study, nurse faculty in nursing education programs will be provided with resources to address entrepreneurship in legal nurse consulting as a specialty in nursing. The evolution of nursing roles and the diversity within the nursing profession, which includes entrepreneurship, will be apparent through this research and will be available to those who are in a position to distribute the findings. Even though nurses can enter this specialty without formal training, the American Association of Legal Nurse Consultants retain the position that nursing education programs should include legal nurse consulting as a specialty within the curricula. Registered nurses transition into many roles during their professional season, which undoubtedly includes the enhancement of leadership capabilities. The LNC entrepreneurial role emerges as a change agent, which is seen as a visionary, a decision maker, and the key to conflict resolution. Developing the leadership skill set that is enhanced with the entrepreneurial role prepares registered nurses with also having a voice at the table to impact change within the healthcare system. Entrepreneurship is an optimal role suitable for supporting the readiness of nurses for leadership in the changing healthcare climate. Having a determination and the initiative to lead for change is the goal and the motivation for entrepreneurship. Research related to failed LNC entrepreneurial attempts might provide additional perspectives as to some of the challenges that are experienced during the journey toward entrepreneurship. A study that generates knowledge as to the worth of the LNC entrepreneurial is needed to give additional credence to the specialized practice. Such a study might obtain data from those that benefit from the services of the LNC. A duplication of the study with the use of a larger sample, as well as soliciting participants from additional regions in the United States and other countries, would be an opportunity to validate the study findings. The ability to compare and contrast the male and female perspectives as to the success and challenges would disclose additional insight into entrepreneurship. Some of the potential study limitations were the researcher bias. However, it was minimal through the process of preserving honesty and candidness of the data. During data collection, the selected American Association of Legal Nurse Consultant chapter ceased operations, necessitating a snowball technique. In addition to widening the sample to include the northeastern and midwestern states, The small sample size lessened the capability to generalize findings and was not anticipated to characterize the whole population of LNC entrepreneurs. The absence of the male perspective limited the ability to compare and contrast gender differences related to the entrepreneurial experience. According to Powell, passion is critical to work successes. There is so much independence as an entrepreneur. Feeling a strong desire to be successful is often related to the thirst and the desire for professional growth, to continue while pushing forward. Passion and excitement stimulate success and growth within business venture. I was amazed at the lack of the discussion and excitement by the participants related to the successes and growth of their practices. Yet I was inspired by the commitment to the LNC entrepreneurial role. This study provided a means for transparency while validating the entrepreneurial's path with a stronger understanding of the value of entrepreneurship. And here are some of my reference sources. I wish to thank you for joining me in this presentation and participating with me, sharing some of my study results. If there are any questions related to my presentation, they can be forwarded to lhoustonbell@gmail.com. Again, that's LHOUSTONBELL@gmail.com. Thank you very much.
Yes, ma'am. This is was the presentation from Dr. Evelyn Austin Bell. Any questions to Dr. Evelyn Bell? Yes. Thank you very much, madam, for joining in this event and sharing your tips with us. Looking forward to meet again next time. Next, we ask Dr. Alnita Jackson from Fayetteville State University from USA to start the presentation. Hello, Dr. Alnita Jackson. This is your slot. You can start your presentation. Or shall we go with other speaker? Shall we go with other speaker? Hello, Dr. Josephine. Are you ready with your PPT so that we can invite you? Hello, Dr. Josephine. Are you ready with your PPT so that you can start your presentation, if possible, or we'll go with other alternate speaker? Yeah, we'll go with Dr. Mary Selman from Sejinajolki University of Applied Science, as well as Science of Healthcare Social Worker from Finland. Yes, madam, you can start your presentation.
Thank you so much. It was so that it was quite hard to hear your voice, but I hope that you are hearing my voice.
Yes.
Okay, thank you so much. There have been some kind of problems with connection, but greetings from Finland, and here is Mari Salminen Tuomaala. I'm working as responsible principal lecturer at Seinäjoki University of Applied Sciences, School of Healthcare and Social Work. And my presentation today is telling about what kind is it to have the situational awareness and also emotional intelligence, how we can develop those skills through simulation-based counseling and also using one special concept. And we have had this kind of a project-like development of multi-professional simulation-based education in South Ostrobothnia in Finland for years. And there were three aims for the project. And first it was to create a network-like simulated learning environment, and then to develop multi-professional simulation education for nursing students. And besides those, it was also meaning to create a multi-professional simulation-based coaching program for health and social care professionals in small and medium-sized enterprises. And then we developed a multi-professional simulation coaching concept for small and medium-sized enterprises in the health and social welfare sector in South Ostrobothnia in Finland, based on participants' learning needs involved as a result of Webropol study. This coaching staff in small and medium-sized enterprises using simulation-based education and action-based methods was something quite new nationally and internationally. And the aim of this coaching was to increase participants' competencies, emotional intelligence, and situational awareness based on a learning needs assessment. And this project aimed at improving the quality of training by tailoring it to the specific needs of the participants. And our coaching program provided 160 simulation coaching interventions to 230 participants in cooperation between Seinäjoki University of Applied Sciences and Seinäjoki Vocational Education Center. And this simulation coaching concept consisted of workshops and collaborative full-scale simulations involving mannequins, but also simulation video equipment, and very often teachers as coaches taking part and acting the part of demanding patient or client role. And this coaching took mainly place in the enterprises' own facilities according to their specific needs. The coaches were teachers working in pairs, and they might represent the same or different fields of expertise. And the simulation coaches studied carefully its context and set of learning needs before planning any contents for those simulation sessions. The participants form a multi-professional group which enabled benchmarking and also peer mentoring or sharing knowledge and experiences. And this simulation coaching was based on a coaching philosophy, teachers as facilitators taking those coaches' roles, and our task was to support professionals interested in improving their emotional intelligence, situational awareness, and also non-technical care competence. The simulation coaching concept was originally developed for the learning needs of child protection, mental health, and also elderly care professionals in small and medium-sized enterprises. Since these participants appreciated this coaching as one good way and excellent tool for developing interaction, collaboration, and decision-making skills, as well as for improving situational awareness and emotional intelligence. It was decided to test this concept also with nursing students. And first, something about this emotional intelligence, because it was very important topic. And we can think about that emotional intelligence is the ability to recognize and also manage one's emotion, also recognize other people's emotions and use this information to guide one's thinking and also action. And we can think about that there are like 3 levels in emotional intelligence, like person's knowledge about emotions and emotional skills, the ability to apply knowledge in emotional situations, and the tendency to use emotional skills and competencies in daily life. Then something about the situational awareness. It's also a very important part of these simulations, and we can think about that it is like perception of the elements in the environment in a volume of time and space. Also comprehension of their meaning and the projection of their status in the near future. All those elements are perceived and their meaning understood in relation to the situation at hand, and like estimate or forecast of what will happen next is concluded. And this situation awareness is essential for safe practice in high risk and stress situations in nursing. The aim of the research was to describe final stage nursing students' experiences of simulation coaching in learning situational awareness, emotional intelligence, and teamwork skills. And we use qualitative data. Data was collected from 21 final stage nursing students undertaking an acute nursing course. And these participants responded to 3 open questions using online survey tool. It is WebRapol developed here in Finland. And this data was collected in spring 2021, and these essays were written by the students, and then they were analyzed using inductive content analysis. And as results, we noticed that these students had very positive experiences of learning situational awareness, also emotional intelligence and team intelligence skills. And they reported that their ability to recognize acute situations and underlying contexts had improved. They had also learned anticipatory skills. They were useful for the planning and safe implementation, all of those nursing interventions. In addition, these students felt that their teamwork and situation management and empathy skills had improved. These learning situations were considered authentic, similar to real-life work situations. And these participants found that scenarios had contained elements that they had encountered during their practical training periods. But through this simulation coaching, they had opportunity and possibility to share and examine their experiences and also challenges more objectively in a safe environment. This simulation coaching had been meaningful to the participants from 4 perspectives. First, increasing their awareness of their own and also other students' emotions. It has also been making them better prepared to project themselves into another person's position, increasing also team intelligence and teamwork skills, and also it has been like form of work supervision. And then these results indicate that simulation coaching can also be considered useful tool for the development of emotional intelligence, situational awareness, and other related competencies in communication and interaction of nursing students. One of these essential outcomes in simulation coaching was learning to recognize and name one's emotions. And this simulation coaching increased those students' self-knowledge and help also them to become better aware of their mindset. But they had difficulties admitting that many of their emotions were not so positive. On the other hand, they pointed out that negative emotions involved important information about the situation, encouraging reflection on how to respond and why. The need to bring self-compassion and accepting presence into the demanding situation was also recognized. Naming one's emotions and telling about them to the other students was also considered demanding and made all those students to feel somewhat vulnerable. They also felt that they had discovered what they called like mirrors for their own thoughts in other students. In that addition, to become aware of one's own emotions, awareness of other group members' emotions was considered important for building up effective teamwork and for improving the collective atmosphere. The students also reported that they had been surprised at learning how many different emotions had been evoked by the scenarios, depending on their participant roles and also students' earlier experiences. Then there was this projecting oneself into another person's position. Simulation coaching was found to increase empathy skills, putting oneself into another person's position. And these simulated scenarios sparked reflection on how too shallow encounters could lead to feelings of insecurity in the clients. These students wrote about that situational sensitivity and emotional literacy or ability to understand other people's emotions and interaction were required. This simulation coaching helped those students improve their conversational listening and feedback skills. Then there was also team intelligence as a result. Simulation coaching increased also nursing students' team intelligence and greater sense of togetherness. Acting out these scenarios and the feedback discussions had made them aware how important it was to bring together all competence and to make better use of the tacit knowledge in order to research and reach the common goals. These nursing students felt that this simulation coaching had increased the feeling of security, but also open interaction between them. And this team intelligence and collective situational awareness can be seen as the result of collaborative action and also potential of individual team members, fostered by self-knowledge, shared team direction, good tolerant atmosphere, permission to act and responsibility for action, and also encouraging interaction. It's essential to become aware of the importance of reflection, acceptance, and encouraging feedback. It is the most important part of these simulation-based coaching sessions. Then there's also possibility of supervision of education, because these students felt that this simulation coaching, especially the briefing session, could be regarded as a form of reflective supervision. And this simulation coaching was very good method because it allowed them to take time to look at their daily routines from a new perspective and to share their own thoughts and also emotions in a safe atmosphere. Students also had an opportunity to reflect on their learning, professional competence, motives, and attitudes. And then we can say as a conclusion that this simulation coaching as supervision could be seen also very good tool to enhance both emotional intelligence and situational awareness. It was also very good experience because the simulation coaching was experience useful. It increased ethical competence, also theoretical competence, skills to assess the patient situation, practical competencies, technical competencies, technical skills, practical skills, but also behavioral competence and social and community competencies. And this simulation coaching concept enhanced the use of peer mentoring, also peer support and evaluation. And this coaching could increase students' confidence in their technical and non-technical skills. It was also possible to practice this prevention of near misses safely by developing problem-solving skills and also situational sensitivity. This simulation coaching can be recommended for the training of situational awareness, emotional intelligence, and teamwork skills. And we can think about that this situational awareness is like precursor of a primary basis for clinical judgment and decision making. Also, logical reasoning and detection of cause-effect relationships are essential cognitive skills contributing to the situational awareness. And besides of these cognitive skills, social and emotional skills, empathy and emotional intelligence are constituents of situational awareness. And we can present as a conclusion about those results, what those nursing students experienced about this situational awareness, that it is including external and also internal knowledge. It's based on these various competencies, cognitive, emotional, and social competencies. And the simulation-based education and simulation coaching is very effective way to develop these competencies. Then there are a couple of pages of these references, and we have made quite many studies concerning this simulation coaching, and if you are interested, it is possible to have also these articles. And now I will thank you for you from listening.
Yes, ma'am. Yes. Any questions? Any questions to Dr. Maria Salaminen? Any questions? Just if you have any questions, you can. We'll be having chat box. We'll be asking behalf of you. Yes. Thank you very much, madam, for joining as a speaker for this event. Thanks for sharing your tips.
Yeah, thank you.
Yes. Thanks.
Thank you.
Yes, thanks for sharing tips with us. Looking forward to meet again next time in physical event if everything goes well in 2022. Next, we ask Dr. Ottoman McGulf as well as Kentlin Haddock as well as Dr. Lindy from Emporia State University from USA.
Hi, this is Autumn McCullough.
I'm Caitlin Haddock.
And I'm Lynette Schreiner. We will be presenting Multi-Patient Simulation, an innovative approach to bridging the clinical education gap. Many of you are aware of the momentous report titled The Future of Nursing, which presented many directives addressing the demand to meet the increasing healthcare needs of the aging population, the multiple comorbidities exhibited by patients, the growth of technology in healthcare, and the challenges of replacing the aging nursing workforce. The report underscored the needs addressed in previous Institute of Medicine initiatives, including the need to reform education for health professionals. To attempt to meet the Institute of Medicine directives, nursing programs, including our own nursing program, face many challenges, one of those being how to overcome the lack of traditional inpatient sites to prepare students with the knowledge, skills, and attitude required of an entry-level BSN prepared nurse, especially in rural, non-urban areas. On any given clinical day, have you ever wondered, what will we do today? Like many nursing programs across the nation, our pre-licensure nursing baccalaureate program, located in the Midwest region of the United States, has been using simulation for many years. However, our faculty quickly realized the challenge of accommodating a simulated clinical experience for up to 10 students at a time. Thus, several faculty began to utilize multi-patient simulation to deliver clinical experiences to the students to fill the clinical education gap.
So next, I'd like to talk a little bit about the plan and design of our multi-patient simulation. The first thing would be to secure simulators. Planning for simulation experiences starts with the purchase of these simulators. We have actually had the privilege of some local grant funding through trust to secure simulators within our department. Simulation does not require high fidelity mannequin use. Using low to mid fidelity can be just as beneficial depending on what tasks students need to perform. In multi-patient simulation, there can also be a combination of the two. The choice to use low fidelity simulators versus a high fidelity simulator depends on the desired goal for the simulation and at times the level of the student. A fundamental student may benefit from a lower fidelity simulator for learning basic skills, whereas a more advanced student may benefit from having the ability to rapidly change what is happening with the simulator in a scenario. And that is just an example of a couple of the simulators that we use, a mid-fidelity simulator of the CAE Juno Clinical Skills Mannequin, and then the CAE Apollo as an example of the high-fidelity mannequin that we use. With our approach and our plan, we do utilize our 2 adult health practicum courses and multi-patient simulation to provide a tiered approach between our second semester junior and first semester senior students. So as a junior, they will be paired with another student as they go through the simulation, progressing to individual performance at the senior level with multi-patient sim. With our plan designed for scenarios, the multi-patient simulation in each of the semesters includes 3 to 4 patients per simulation. Each patient is chosen through assessment of what the needs of the student in healthcare are. We do look at low acuity situations versus high acuity situations. Some of the examples would include bowel obstruction, urinary retention, pneumonia with potential COVID positive, fluid volume overload, blood transfusion, new onset AFib, and neutropenia with potential COVID. We also incorporate our student learning objectives. Examples of these objectives for our first semester of students include documents nursing care in a computerized charting system, program hourly flow rates using an IV pump, administer IV fluids using an IV pump, administer IV medications versus our adult health 2 or second semester administering blood, demonstrating central line flush, administering IV medications through a central line, and demonstrating the use of an ECG monitoring equipment. Within both semesters, demonstrating the ability to prioritize interventions to meet patients' needs, readily admitting mistakes and oversights, and interacting effectively with others in providing care are goals within that multi-patient simulation. The plan design with the environment should include a controlled, safe environment. By providing this environment, the goal or expected outcome is that the student can improve their critical decision-making skills, professionalism, communication, teamwork, and nursing skills. There are different options for this setup, including multiple beds within one simulation area as pictured in the top, versus individual rooms for each patient within the multi-patient simulation as pictured in the bottom. The last part of the plan design process is the debriefing. At the completion of all simulations, we have a debriefing period, which is an important part of the learning process. During this process, we review each patient in the multi-patient simulation. We discuss the state of the patient, the healthcare provider orders, and time management. Debriefing has been defined as the intentional discussion following the simulation experience that allows participants to gain a clear understanding of their actions and thoughts process to promote learning outcomes and enhance future clinical performance. It also allows faculty and learners to re-examine the simulated case experience, share their mental model, and foster the reasoning behind their clinical judgment.
So what does the implementation of this look like in reality? One of the first things would be to look at the faculty education that is required. Multi-patient simulation does require education regarding simulation development and the use of simulators, especially if using mid to high fidelity simulators. The patient scenarios chosen and developed for our program's multi-patient simulations utilize assessments, skills, and clinical decision-making situations in which students are making the decisions like the registered nurse, something that students do not get to necessarily experience when in clinical and paired with a nurse. At our program, faculty are also provided education on our program-specific simulators by other faculty or by the simulator's company representative. Another part of implementation would be the health record and documentation. Providing a way to give the students some history about their simulated patient, as well as orders, a medication administration record, labs, and radiology findings, as well as a place for them to document their assessment findings, interventions, and communication with the healthcare team. We utilize a simulated electronic health record in which faculty develop charts and students then enter the chart to document and find information, like in a hospital setting. Each patient scenario in our multi-patient simulation has a chart developed. This can be time-consuming, but once the chart is developed, faculty are able to reuse the same chart for subsequent multi-patient simulations and subsequent semesters. Medications and simulation setup. The use of simulated medications and intravenous fluids are an important aspect of the student's learning by requiring the use of hands-on skills. Our simulated electronic health record system enables us to print off medication barcode labels as well. The scheduling. Scheduling of The scheduling. Scheduling of students is another task that faculty can be faced with, especially depending on the number of students that are to attend simulation on a given day. For our program, we pair students for the first multi-patient simulation in their first adult health course, and in the second adult health course the following semester, they are completing the multi-patient simulations on their own. Students are given 1 hour to complete the care for each simulated patient, for a total of 3 to 4 hours of patient care depending on the number of patients in that given semester. As Autumn discussed, debriefing is very important, especially following multi-patient simulation. Within debriefing, we are able to revisit common mistakes made by students, engage students with their own personal feelings about the simulation, discuss common pitfalls that students faced, and it also provides opportunity for faculty to remediate with students over those common mistakes. Some example debriefing questions that we ask are, were you satisfied with your ability to care for the patient? What was done well and what could have been handled differently? What did you learn? How could the simulation experience be improved? And is there anything else you would like to discuss?
Ongoing changes in the healthcare environment, including the current worldwide pandemic, require innovations to meet the challenges to fulfill clinical experiences. Utilizing multi-patient simulation has proven to provide highly beneficial clinical experiences for our nursing students and prepare them with the necessary skills and attitude for the reality of the nursing world. Thank you, and here are our references.
This was the presentation from Dr. Autumn McAuliffe Kathleen as well as Dr. Lynette from Emporia State University from USA. Next we ask Dr. Alnita Jackson from Fayetteville State University from USA to start the presentation.
Good afternoon, everyone. So to the commentator, do I have the screen so I can pull up my presentation? Have it. Good afternoon, everyone. My name is Dr. Alnita Jackson, and I am an assistant professor at Fayetteville State University in Fayetteville, North Carolina. And I currently teach in our pre-licensure, our RN to BSN, and our MSN programs. So today I am presenting this topic that I think is pertinent to the nursing profession. And the title of my presentation is Maintaining Academic Integrity in Nursing Programs During a Pandemic. So there are a few things that I hope to accomplish with this presentation. And for students and for faculty, we need to define academic integrity. And we also need to make sure that
we are unable to see your PPTs. Start sharing your PPT.
Excuse me?
Yes, yes.
Can you not see my presentation?
No, no.
Okay. So do I have the screen to share? Do I have the screen to share?
You can start sharing from your side, ma'am.
Can you say again?
You can start sharing your PPT. You can see in the bottom of the screen. You can see with the green color with share screen.
Okay. Can you see can everyone see my screen now?
No, not yet.
Let's see. I'm not sure why you're not able to see the screen. Because if you're sharing it with me, it should be open for me to just pull up my presentation for me to be able to present.
Yes, ma'am. Is it possible to share your PPT so that I can share behalf of you? You can share me here through chat box.
Okay, let's see.
Yes, you can share through chat box. I'll be playing from you.
Okay. So let me come here. I apologize. I thought I should be able to pull it up without any problem.
Yes, no problem.
So let me go here and share it with you. So I need to send it to.
Yes, madam. You can find through chat box. There is a box you can share through it. I'll be playing from here.
Okay. Well, I did just send it to your email. Let me see.
Yes. Shall we go? Yes, I'll be sharing my email ID immediately.
Did you get it, Mr. Thomas?
Yes, yes. Yes, you
Okay.
can.
Did you get my presentation, Mr. Thomas?
No, just be on.
Okay.
వచ్చిందా?
Did you receive it, Mr. Thomas?
Yes, madam, we have received. We are going to play. Just
Okay.
Yes, we have received your PPT.
I apologize for the inconvenience.
Yeah, no problem. Yes, madam, you can continue your talk.
Now, can I control it?
Yes, yes. Are you visible your PPT on the screen?
Yes, I can see it on the screen.
Yes, yes. You can continue your talk, madam. As soon as completion of your talk, just you mention me slide change. I'll be changing from here. From here.
So you can see it from here. So I'm not going to be able to do it like a typical PowerPoint presentation.
Yes, you can
slideshow.
Yes, you can start presenting.
Okay. Okay. Good afternoon. I'm Dr. Alnita Jackson, and I am an assistant professor at Fayetteville State University in North Carolina. Thanks for the opportunity to present here today at the conference. And today my topic is maintaining academic integrity in nursing programs during a pandemic. This is not a new topic. It is not a new problem. It's just gotten a little bit worse since the pandemic began. So there are a few things that I would like to cover in the presentation. If I can move the slides. Can I move the slides?
Move your slide, madam. You can start presenting.
I don't see where I have control where I can move the slide.
I'll be controlling from my side. Just you can mention slide change as soon as your talk is completed.
Okay. So next slide. So let's discuss the objectives. So some of the objectives that I want to cover in this presentation include just defining what academic integrity is and making sure that students understand and know the policies, university policies, as well as the code of ethics as it governs ethical behavior and standard practices for nurses. I wanted to make sure that we covered in the presentation the increase in the academic dishonesty among students since the pandemic began. And I wanted to also discuss the implications for nursing practice and some of the tools that we have at our disposal to deter these types of behaviors. And some of the tools that we typically use in academia are the lockdown browsers and non-respondence monitoring and proctoring. Next slide, please. So I think it's first important to define what academic integrity is. And when I looked at the literature, there are many definitions, but I felt that this was the most encompassing definition for nursing practice in regards to this topic. And this definition comes from the International Center for Academic Integrity. And it simply defines academic integrity as a commitment, even in the face of adversity, to 5 fundamental values. And these 5 fundamental values that are listed here are the core of what we do in nursing in our profession. And those are honesty, trust, fairness, respect, and responsibility. And we need to be reminded of this from time to time. And our students definitely need to be aware of what academic integrity is and the expectations for behaviors. Next slide, please. So, as I mentioned, I'm an instructor at Fayetteville State University, and this is just a snippet of our academic policy. in terms of dishonesty. And basically the policy just states what probably, and it's very similar to most university policies, that students who engage in behaviors that whether it's intentional or unintentional, that's designed to cheat or to help others to cheat, is a form of dishonesty. And with that comes consequences. So at our university, some examples that we consider as academic dishonesty is definitely cheating on exams, sharing exam information, falsifying documentation, particularly for students when we go into the clinical setting, and also plagiarism when it comes to the writing of our papers. And some of the sanctions that we impose at Fayetteville State University in response to this type of behavior, it can be a failing grade. They may be placed on academic integrity, we do suspend students, and also there's expulsion, and they may be put on academic integrity probation throughout their time at the university. And if they engage in any other unethical behaviors, then they may be excused from the program. Next slide, please. And this is the ANA's Code of Ethics for Nurses. And I think it's a cornerstone of what we should be teaching our students early on in their nursing careers. From the very beginning of their pre-licensure experience, we should make sure that students are aware of the professional code of conduct for nurses, the ethical responsibilities that we have as nurses, and the responsibilities that we have and the expectations that our public and the populations that we serve have. Next slide, please. And so the pandemic has changed pretty much everything. And like any other presentation, it's changed the way we even engage in taking our students to clinical practice. We've had to revert to simulation. COVID has also impacted our students in such a way that it has caused them to engage in more unethical behaviors in regards to cheating. And so these are some of just the challenges overall that students face, faculty face, and that we've all faced globally. And so we've had students who had contracted COVID-19, family members, they've lost family members. The student may have lost a job or their partner or their spouse. We have food insecurity amongst our college students and even in our communities now because of loss of employment. And for our students who signed up for didactic courses, the didactic courses disappeared and turned into online learning for those students who are, kinesthetic learners who need to be in a classroom. So going from a didactic course to an online environment has posed difficulties for these students. Also, lab and clinical experiences have been very different because we've had to revert to virtual simulations when students were not able to go into the clinical settings for their clinicals. And also, even with their interactions with their professors and with academic advisors, all these things have had to be conducted over Zoom. So all of these are challenges that have impacted our student population. And then the other thing too, where I live in North Carolina, it's a lot of rural areas surrounding Fayetteville. So a lot of our students didn't have access to internet connectivity, or they didn't have laptops with webcams. And so it posed a lot of difficulties for the students. Now also, because of the pandemic, many of our children, the schools were closed down, so there was virtual learning for students. And so this impacted our students as well. And because of all these factors, they contribute to a higher level of stress and anxiety amongst our students, which is a culprit in seeing an increase in academic dishonesty amongst our students. Next slide, please. So with our millennials, they have engaged in a higher level of academic dishonesty than we've seen in the past. And it's just because of technology. Our students are able to cheat a little bit better because they're a little bit smarter and more tech savvy, probably, than a lot of us professors. And so these are some new ways that we've seen at Fayetteville State and probably at other institutions of higher learning that you've seen students engage in these type of behaviors. Fingernails, acrylics, even though we don't allow them in the clinical setting, but students do wear acrylics prior to going to clinicals. So they've become creative. They're actually putting answers in their fingernails. It's something I thought I would never see in academia, but it's a very real thing that we're seeing with our students. With the Apple Watches, all these smart watches, they're able to cheat that way. We're seeing that. We're having to ask students to place these watches. Cell phones are another way that the students cheat. And so we're asking students to place those in baskets and things of that nature. Or when they're actually in the virtual environment, when we're monitoring them on the webcam, those are not visible in the students' area where they're testing. So because of the high level of stress, students are engaging in more behaviors that we don't want to see in nursing, because as students practice these behaviors, as students, we worry that these practices will continue on once they become professional nurses. Next slide, please. So these are some more factors that contribute to academic dishonesty. As I said, stress, anxiety, the desire to succeed and perform at a high level has increased these behaviors. Students are admitted into the programs. They have scholarships, financial awards that they don't want to lose. Risk-taking. Our millennial students are risk takers. They're engaging in behaviors that probably we would have never considered because we were feared getting expelled from the program. We have a different type of student now. And so these students aren't afraid to take these risks. And then students are very competitive. In our profession, a lot of us tend to be type A type personalities. And this is also true of our student population. So they're very competitive, wanting to be ranked number one in their class. And those kind of behaviors and desires drive academic dishonesty. And they also view these type of behaviors as acceptable or normal. Whereas for most of us who've been in the profession for a long time, we definitely did see these as undesirable behaviors or unethical behaviors. Our new students population, our millennials, see this as pretty much the norm. It's not a taboo, it's not forbidden. It's more acceptable among our current student population. Next slide, please. So how does this impact nursing? Well, it impacts our profession in a lot of ways. According to the Gallup studies that they've done over the last however many years, nursing has always ranked in the top, very top of the list for being professionals whom the public trusts. So our image is very important to how we impact our patients, impact our communities, impact global health. So we need to maintain our image as ethical, compassionate healthcare professionals. So when students engage in academic dishonesty, and when they're cheating on their exams, and it spills over into the clinical setting, it damages the image of our nursing profession. Also, students who typically engage in academic dishonesty will also do this once they become licensed. And so that may be falsifying documentation, stating that they gave a medication when they really didn't, or maybe they were supposed to perform wound care at a certain time and they document that they did it, but the dressing change never occurred. And also with the opioid epidemic, we are not exempt from that. Nurses, have access to drugs. So we have drug diversion. So students who engage in unethical behaviors are more likely to engage in these behaviors once they become professional nurses. Next slide, please. So how can we deter academic dishonesty? If you've been in academia for a while, some of these tools that we're discussing today, they aren't new tools, but for some of us, maybe we haven't really used them, but the pandemic has caused us to really buckle down and start learning how to use these tools. And one way that we prevent students from cheating, or we deter them from cheating, is using lockdown browsers. When we use the lockdown browsers during exams, students can't go to another website. They're locked into that environment. They can't copy. Our new millennials like to screenshot pictures and send them to other students. They're not able to do those sorts of things when we're using a lockdown browsers. And then students have to stay in that exam until it's completed and submitted. So the lockdown browser is very useful tool to implement in the course. And so another tool that we use is respondus monitoring. So this was a challenge because not all of our students had laptops with webcams. And so that's something that we had to provide for students who did not have that capability. So using the respondus monitoring with the webcams is also a very important tool, because it allows you to see the students sitting at their work area, at home, at their desk, or wherever their workplace may be within the home. We can see everything surrounding their work environment as they're taking their exam. So it provides access for us to see what the student's doing and hopefully to deter them from engaging in other behaviors. Next slide, please. And this is just a picture of what the webcam may or may not look. It's probably a little bit of an exaggeration of what webcams look like. But for most of the laptops, the newer laptops, they do come with the webcams. So the students are able to be monitored virtually, so that we can deter academic and tech dishonesty. Okay, so next slide, please. Turnitin has been around for a long time. I've been in healthcare for a long time. It was back in my BSN program many years ago, and we're still using this tool. And so it's been around for a long time. For most academics, we do know how to use Turnitin. We've made students become very familiar with using Turnitin, especially when they are doing their papers. And it's a plagiarism detection monitoring system that's widely used. It helps for our students, instead of copying and pasting information, taking information from other sources and not citing it, it makes them focus on creating original thought. It promotes them to enhance their academic abilities, to think outside the box, to come up with original information. So it does provide a lot of opportunity to detect any fraudulent or unacceptable practices. And for most professors, we have a standard that we set as far as similarity reports are concerned. The percentage can't be higher than 21% or 18%, whatever standard you have set or that's set at your institution. We set that so that when students submit papers and it's higher than that, we send it back, we give them feedback and tell them why we're not accepting a paper and what corrections they need to make. And so by using these different tools, it promotes a culture of integrity, because when students know that they're going to be caught cheating, they're more likely to do the right thing. Next slide, please. So we also proctor students during exams, and we can do that a number of ways. When we're in the actual classroom, we actually walk around, monitor students as they're taking the exams. They come into the classroom, they get rid of their backpack, watches, cell phones, go in a basket, they pick it up after their exam. We walk around the room, watch the students, make sure they don't have anything written on their arms, notes, anything that can be perceived as that they're actually cheating during the exam. And then we also can view and proctor the exams by the webcam. Next slide, please. So what we want to do is early on in the program, when students come on board, that's why those very first pre-licensure courses, intro to professional nursing courses are very important, because it kind of sets the stage of what we expect students to do while they're in the nursing program and also within the profession. So those early courses are fundamental to what we need to be teaching students. And also, when I've looked at the literature, one of the most important things to promote a culture of integrity is for faculty to model those behaviors. Students are more likely to engage in ethical behaviors when they see their faculty members doing so and being professional. And we need to incorporate it through every course, not in those basic nursing courses, but throughout their entire nursing program. We should be incorporating ethics in every course. And the other thing we should also be promoting is ethical decision making. Will you do the right thing when no one's looking? When you go to clinicals, if you're in the room and you're putting in a Foley and I'm not in there, but you have another nurse there and you contaminate your sterile field, are you still going to put that catheter in, or are you going to start over? So we need students to make these type of decisions because they impact patient outcomes, and they need to understand how important that really is. And we need to make sure that students are accountable for their actions and their behaviors, because when there is accountability, students are more likely to do the right thing. So sometimes we need consequences and accountability to promote that. And so this picture that you see here, these are the basic ethical principles that we teach students when they come into the program, but it shouldn't stop there. It should be pervasive throughout the program, so that they don't forget about autonomy, that they don't forget about veracity, that it's important to their learning, it's important to their decision making, and it's important ultimately to the profession and the impact that they're going to have on patients. Next slide, please. So the big questions: are we providing good examples? Are we modeling the behaviors that we expect students to conform to? So that's my question to you. And I know for myself, I try to be a good example for my students, and I'm sure that you all do too. And are we having conversations about ethical dilemmas that impact healthcare every day, that's impacting our students? The pandemic right now, the nursing shortage, the lack of PPE, all these are ethical dilemmas, because we're expecting nurses, doctors, the frontline workers to continue working sometimes without the proper equipment. These are ethical dilemmas that we can have conversations with our students about. And so, and also, do you use situations when you're in a clinical setting that shows and demonstrates good, sound, ethical decision making? Are we discussing these things? Are we providing opportunities for learning for our students? Next slide, please. So to kind of wrap and sum everything up, is that academic dishonesty, lack of integrity is not a new phenomena in nursing, especially amongst nursing students. This is a global problem. It has been for many, many years. So to try to solve it overnight is probably not going to happen, but we do have some more safeguards in place to deter this behavior. we should make sure that students understand and are familiar with our expectations, with the policies, with the code of conduct. They need to be aware of that. And we need to make sure that ethics is deeply rooted throughout our nursing education for as we prepare our students. And we should and nurses should also model appropriate behaviors for students is very important. That's why we mentors. We don't, not only do we teach students, but we mentor students as well. So modeling those behaviors are very important. And we also want to make sure, as I mentioned before, that when students deviate from the standard of what's acceptable, what's desirable, then there's a consequence. There's accountability in choosing to engage in dishonest behaviors. And then two, it's also important that we want to maintain our image to the world as one of the most trusted healthcare professions. So that's why it's important that students understand why we don't engage in these type of behaviors as students, so that it does not carry on into their professional careers. Next slide, please. So this is a quote that I think kind of sums up everything, and it's by Zig Ziglar. It says, integrity gives you real freedom because you have nothing to fear, since you have nothing to hide. So when we do the right thing, we don't have to fear hiding anything. We're transparent. So I think this is a great quote. It's one that I use for myself and I use for my students. Next slide. That's the end of my presentation. I am open to any questions that you may have, any comments. If you've experienced any increase in cheating, plagiarism at your university since the pandemic began, we have. Typically, we've had only a couple of instances each semester, maybe with this type of behavior. But since the pandemic, we've had 7 or 8 more students doing it each semester and having to be disciplined for that. So I don't know if any of you out there that's in academia have experienced similar situations with your students. And the next slide is simply the references for the presentation.
I have a question. Can I go ahead?
Yes, any questions?
Yes, thank you so much, Dr. Jackson. That was excellent, and just on time, very timely presentation, your topic. And I think just what you said about the increase in the student behavior, academic integrity being impaired, it's really arising. My question to you will be, will you suggest having to do like another exam? You know, like you do your first exam, everybody went in, lockdown and all that kind of stuff. And then if they have to do like a repeat of that exam, you know, dosage calculation being an example. So will you want to use the same exam for them? And will you suggest just creating another exam?
Okay, yes, ma'am. So what we typically do, because yes, we have students that cheat, and sometimes we give them a second chance because we do believe in second chances, right? And so what we typically do, and what I know that I do a lot, and my other colleagues as well, is that we have a version A, B, or C of the exam with the same content delivered in maybe a slightly different fashion, or just in a different sequence. And so that if students do cheat and we have to give them another exam, we'll give them a different version of the exam, because it wouldn't be fair to create a whole new test that doesn't cover the content that's on that test. So we typically have an A, B, and a C version is what we do.
Okay, so what you're saying is when you're loading your questions on Blackboard, just go ahead and load your A and your B, right? On Blackboard.
Yes.
Okay.
Yes. And for you use Blackboard, we use Canvas.
Canvas,
at where I am, but yes, we go ahead and create 2 or 3 versions of the same exam.
Okay.
Because sometimes too, even if we don't have any students who maybe cheat or something, but students like to share information what was on the previous exam with the students that's coming up. So we if we use version A in the first semester, we'll use version B or C the next time.
Next time. Okay. Thank you. Appreciate it.
Yes. Any questions? Any further questions to Dr. Anita Jackson? Just if you have any questions, even after the completion of the conference, just you can mail us officially. We'll be asking you. We'll be sending you.
Excuse me, I see someone has their hand raised. I'm not, or is that just a thumbs up? Okay.
Yes.
Okay.
You can find it's a thumbs up. Just it's a thumbs up.
Okay.
Thank you, Dr. Jackson. Virtually new to UK. Interesting to hear your challenges. These are the compliments you can read from the chat box, madam. You can read from the chat box. Yes, you can read from the chat box.
Thank you for the opportunity to present, everyone.
Yes.
And I apologize for the technical difficulties again.
It's a common to everyone. It's a no. Thank you. Thank you. Oh, sorry. So next will be Dr. Josephine Akintondi from Bowie State University from USA. The title of the talk will be Use of Critical Thinking Teaching Strategies by Nurse Educators.
Now. Hello, I see you load me and I'm trying to get my speaker on. You're doing something to me, sir. Hello, I was just on. Hello?
Yes, madam.
Can you hear me?
Yes, I can hear your voice.
Okay, and I hope everybody can hear my voice.
Yes.
Good morning, everyone. My name is Josephine Akintondi. I will be talking this morning about my findings during my research, my doctoral research while I was at Walden University. I'm currently an adjunct faculty at Bowie State. I've been in academia for over 30 years, so done a lot of things in nursing. So going straight to my presentation today, I kind of use another dimension, maybe not objectives, that I will be using. Next slide, please. Oh, I like this. Okay. My topic is use of critical thinking teaching strategies by nurse educator. And I know the topic critical thinking, it's very common. Can you hear me?
Yes, madam.
Okay. I know the word critical thinking is a common word used in nursing education. However, the term critical thinking teaching strategy emerged from a lot of other teaching strategies that nurses have used. Now, I'm going to just to introduce, I like to use the word overview and background, talking about how did this topic emerge.
Excuse me, madam, just starts changing your PPT. We don't see your PPT on the screen.
Okay, do you want me to do my screen and just share my screen, please?
Yes, you can start sharing your screen.
Okay, if I do that, I could do that. Okay, I could do that. And I could just go into
so that we come to know that you are presenting. Otherwise we'll be confused.
Oh, okay. Thanks everybody for your patience.
Thank you very much.
Because if not, I'm just gonna keep talking about next slide. Okay, can you see me now sharing?
No.
I think you're gonna have to come off. I'm here. I want to share. How about now? I use these all the time. Hello, I'm still here.
Yes, yes.
I think yours is, I think y'all, okay, how about now? Can you see me sharing? Sharing is not a bit, it's not difficult for me.
You can see in the bottom of the screen with the green color, share screen.
I see that, and I'm looking,
Yeah.
I'm looking for that right now, but it sounds like you have something else entirely. Josephine, what's going on here today? Okay. So, can you see me now?
Yeah, it's going to open.
Hi, everybody. Can you see my screen?
Yes, it's fine.
Okay. My apology for that technical difficulty. So again, my topic is use of critical thinking teaching strategies by nurse educators. I did mention earlier the topic emerged from the term critical thinking, which is a very, very common terminology nurses like to use all the time. Again, nurse educators for years have used so many strategies to kind of bring their student over to learning, just making sure that the student can connect theoretical concepts with clinical competency. And that has been a challenge for us in this career. And I'm just gonna do like instead of objectives, I'm just gonna kind of do like an overview and background. Critical thinking critical thinking skills are very essential for every nurse and for most healthcare workers. Lack of critical thinking skills for years result in so many poor patient outcomes. However, nurse educators are continuously challenged with developing the appropriate skills they can use while they are in training to prepare their student ready for clinical competency. Little knowledge is available out there as at the time I was doing this research that kind of talks about what are the things that nurse educators do that helps the student to develop critical thinking abilities while they are in training. And that continues to be like a challenge for nurse educators. However, again, nurse educators do their best while they are in training, while the students are in training, to train them ready for being a professional, for bringing clinical competency, but this is just not working well. Nurse educators and the healthcare are currently being challenged by healthcare recruiters, asking the question, what are you really teaching your students while they're in training? And this come back to us as educators in terms of how do we get them ready for competency after passing through the nursing program? And this was where my study kind of emerged from. Though the purpose of the study was to understand the lived experiences of nurse educators who utilize critical thinking teaching strategies in a baccalaureate nursing program to develop the critical thinking skills in their nursing students. This particular study was guided by the constructive learning theory. Constructive learning theory, however, make us to believe that people construct learning and meaning for their learning while they're involved in their particular learning, making it sound like if you are a learner, you really have to be involved in that activity and make some sense out of it for yourself for you to understand that concept. The research design, of course, for the study was the interpretative phenological design. This particular design became interesting to me because this design research method actually will examine the lived experiences of what is being investigated. Also, from collecting data from those that are involved with this phenomenon being studied, I was able to get rich information, like first-hand information from those people. Also, with this particular research design, the researchers have a tendency to interact more with their population. Moving along, the research question for the study, there was one big research question for the study, and I have other guiding research question, which was, what are the lived experiences of nurse educators who teach in a baccalaureate nursing program as they attempt to develop critical thinking abilities in their students? Meaning, nurse educators lived experiences. What do they have to say? What are their experiences? And what have they really been through in terms of helping their student to develop critical thinking abilities, which is a very important skill that is needed as the student graduate from their school. Other guiding questions during the data collection were educators were asked to describe critical thinking abilities. Educators were asked to describe teaching strategies that they use. Educators were asked to describe what are the rationale for selecting those strategies for their student. Also, they were also asked to kind of define which of the teaching strategies do they believe best facilitate the development of student critical thinking abilities, and which of the techniques have they used that they think have been effective. And again, we were talking about teaching strategies here. So it was a very interesting, pretty study. The population of interest, of course, we're all nursing educators, but with some modifications. These were nurse educators with 3 years teaching experience that are involved in mentoring or supervising nursing students in clinical settings. We were able to get 13 nurse educators for the interview, and the exclusion criteria for the study was nurses who teach in an associate nursing program were excluded because we are actually just looking at nurses in a baccalaureate nursing program. And the study was focusing on nurse educators from the Midwest. Of course, we receive a RIB and all that kind of stuff. We were able to collect information from 62% of educators that have master's degree, 32% that have doctoral degree. And of course, the interviewers were candidates with experience in teaching in nursing education. 62% of the people interviewed were 10 years of teaching experience, 31% were 5 years of teaching experience, and 13% were only the 3 years of teaching experience. To just kind of give you an idea that yes, we were collecting data from the people that we really wanted, or people with the right experience. So looking at the data analysis, very interesting. We kind of gather, collect information, put them in vivo, and then later line by line transcript was done just to collect to generate the data information. So we were able to come up with 3 teams and 11 subteams from the data analysis. 3 teams that emerged from their information was that 1, educators use a variety of teaching strategies. That was not new. Data research, other scholarly articles supported that. Educators selecting multiple teaching strategies when they are teaching, regardless of the concept that they are teaching, there's a tendency for them to use more than one teaching strategies. And the third thing was, we were able to also find out that outcome of using critical thinking teaching strategies was very beneficial to the program and to the educators as well. And what I will do, focus on now, will be just to kind of get more information about each of the team results. For team 1, which was educators use a variety of teaching strategies, we were also able to deduct that these strategies help to engage students in learning. These strategies facilitate thinking for the student, and these strategies also increase student knowledge. And most of the strategies they use have to transfer student knowledge from theory to clinical setting, which is like a main thing that nurse educators struggle with. After preparing their student, they're always concerned about, are my student going to be ready for clinical practice? So we do find out that most of the strategies that they use help those nursing students to transfer theoretical concepts to clinical setting. And what I just put in my slide just for presentation, very interesting. I'm going to share some of the student comments, some of the educators' comments themselves, where they say critical thinking teaching strategies are the strategies they use to elicit and engage students so that they can deeply think, which is important, about the concepts. It involves using probing questions to engage the student while trying to teach them. And some of the strategies that they actually mentioned were case studies, problem solving. Stimulation was one of the critical thinking teaching strategies they talk about as well. And One faculty actually talking about facilitated thinking said, open-ended education questions help the student to think a little bit more. Concept map help the student to connect the dots and enhance deep thinking for the student. It is believed that a student that has a deep thinking of the concept, definitely when it comes to putting that knowledge into clinical practice, that student would perform better, which is what we're actually always looking for most of our nursing graduates. Another interesting one was one participant stated, critical thinking teaching strategies are student-centered active teaching strategies that promote the application of theoretical concept to clinical situation. So just to kind of give you an idea what educators we are kind of talking about. Now, moving along with Team 2 results. From the educators, we were able to generate that educators agree that selecting multiple teaching strategies is important for them. And some of the reasons why they use those multiple teaching strategies are based on the situation. This was clearly explained during the data collection, that depending on the situation, depending on the topic they are talking about, they will go ahead and select multiple strategies. Student progression in the program. That was another interesting one. We were able to deduct from them that educators will use a different kind of teaching strategies for the first year nursing student and will agree to use another one for the third year nursing student, which was pretty interesting. I remember one educator mentioning something about a fundamental student will be better off with just a regular teaching with PowerPoint and stuff like that, where a third year nursing student, she will use case studies mostly in case scenarios in a presentation of concept to them. Again, we were able to also find out that nurse educators use multiple teaching strategies due to a lot of other multiple factors. And some of these multiple factors will include, according to them, the student level, the student learning style. Those are some of the things they talk about. And also they did say something about depending on the class that was, whether it was a community course, whether it was a critical thinking course, whether it was a med search course. So they do pick their teaching strategies, their selection of teaching strategies based on multiple factors. Okay, and what I did here was looking at Team 2, just to kind of get some of the things that were mentioned by them out, where one of the participants shared that the selection was determined by student level in the program and the concept being discussed. I did mention that earlier. Another one is that, for example, a lecture might be appropriate for some topic, case study might be better for complex study. With multiple factors, some of the educators did express that student learning style, cultural background was interesting to be cited as a reason for selecting a teaching strategy. And some educators agree that they like to use life application experiences while they're teaching. So just to kind of give us an idea of where most of the time why educators select different strategies that they use. And this is the last one. Another thing that emerged from the study was the outcome of using the critical thinking teaching strategies. Educators did agree that using those critical thinking teaching strategies help students to improve their clinical competency. And they did comment that students are better prepared for clinical practice. For example, with stimulation, the educators create an environment similar to clinical settings, and the student can practice, visualize, and start to develop their critical thinking ability. Stimulation was like a big one among them. Improve program outcomes. Most educators, part of their role is to prepare the student for professional practice. And program outcomes also depend on their board exam as well. Educators did agree that the use of critical thinking teaching strategies help to improve the program outcomes. The use of CCT is help the educator test if teaching strategies has been successful. Students perform better on their exam and their board score. So program outcomes was really looking positive for educators as they use those critical thinking teaching strategies. Another good comments on the outcome was that critical thinking teaching strategies help to improve student outcome. By the end of the program, for the student, there's a better understanding of the concept being taught. CT behaviors are much improved. Students analyze better and are able to connect the why, the if, and the what, which is something very important in trying to develop your student critical thinking abilities. The if and the what and the why. Student can think better of what they are doing, why they are doing it, and these at the end actually help improve patient safety as well. This particular study, I just want to kind of like, how does the findings correlate with the literature? The literature confirms the use of multiple teaching strategies to facilitate student critical thinking abilities. Think Like a Nurse, a very important initiative that's very common in nursing, is a teaching model that empowers educators to select teaching strategies situated within the nursing practice context. So from fundamentals, the nurses are busy teaching their students to understand, I want you to think like a nurse, think like a nurse, think like a nurse. And I think it was also evident from some of their comments that if educators can begin this in their student during the fundamental levels, students become better nurses in the world of their profession. Some of the limitations for these studies will include, there was a significant limitation to the study, was the use of nurse educators from baccalaureate nursing programs in a region where we have so many different nursing programs. Another limitation was that nurses and educators from the associate nursing program were not included in the study. Throughout the study, data collection, analysis, reflexity was continuously applied just to be sure that yes, the bias and the beliefs of the researcher was not in any way conflicting with the information being collected, because I'm a nurse educator myself. From this study, we were able to deduct some recommendations for future research. The study, of course, was a qualitative study. The study required the recommendation for further study to actually see if they can examine if there's a relationship between the specific critical thinking teaching strategies used and the CT skills developed and the learning outcomes in student and baccalaureate nursing program. Another recommendation from this study was to see if there are specific teaching strategies that could have been effective in developing CT skills for students at different levels of nursing program. Meaning, would there be any study that wants to kind of look at what kind of teaching strategies do we use for fundamental students? And what kind of teaching strategies do you recommend for students in the final year of their nursing program? We also, this study also deducts recommendation that to look at specific relationship between critical teaching strategies, clinical competency, and nursing program outcome. More of like, for example, if you want to pick, okay, we are using stimulation. For that particular course, stimulation was used throughout. What is the relationship that will exist in the use of stimulation, your student clinical competency appraiser or evaluation, and your overall nursing outcome program? So these are some of the recommendations that this study kind of put out there for any future researcher. This study, of course, has positive social change for 4 groups in particular. Nurse educators. The results of this study assist educators to refine their curriculum on the use of effective critical thinking teaching strategies. For the student, the result from this study help the student to enhance cognitive and affective ability, improve self-confidence, increase pass rate for the nursing licensure exam, which is very important for any student once they come to a nursing program. This study also have implications for healthcare consumer. Looking at competent graduate nurses, hopefully when they go to nursing program, they are being taught with critical thinking teaching strategies, they become competent. So any competent nursing graduate nurse will have the potential to provide safe quality care, increase patient safety, and improve positive health outcomes. Healthcare institutions, of course, are not left out of the positive effects of this study. Healthcare institutions, it does affect them. There will be improved patient safety, healthcare consumers are satisfied, and there will be less less medical errors. Kind of putting it all together for all of us, I put something together here, critical thinking teaching strategy used by nurse educators. Down here, looking at educators use a variety of multiple teaching strategies, and that will actually result in outcomes of the CCTS, which is improving students' program outcomes and increase patient safety. So kind of put it all together, coming down from educators to the students, and of course to the healthcare consumers. This study has actually helped to embrace why it's important for us as educators to use critical thinking teaching strategies while the students are in nursing program, so that they can develop effective critical thinking abilities that is an important skills for them once they become professionals. And what I did was, any questions at this time?
Yes, any questions? Any questions? If you have any questions, even after the completion of the conference, you can share to us. We'll be asking behalf of you. Any questions to Dr. Josephine Akentot? Just you can raise the hand if you have any questions.
Okay. In the absence of no question, I would like to say a big thank you to all the conference committee members for giving me an opportunity to present my findings, and also for my professional colleagues for taking the time to listen to my presentation. Thank you very much.
Yes, thank you very much, madam, for participating in this event. On behalf of organizing committee members of Virtual Nursing Education, that is 2021, we want to thank you for your excellent presentation. Thanks for sharing your tips with us. Looking forward to meet again next time.
Thank you.
Yes. Next, we ask Dr. Cassie Boyd from George William College of Aurora University from USA. The topic will be the increased importance of trauma-informed healthcare in a post-pandemic world.
Good afternoon, everyone. I hope you've enjoyed this morning's talks. I know that I certainly have. I am very thankful that you are all here joining me today about some topics that are extremely close to my heart and that I am very passionate about, and that is trauma. So my name is Cassie Boyd. I am here representing my own company and organization, which is named Imperfectly Perfect Coaching. I am currently functioning in the role of a nurse coach. I help people to overcome trauma using my own unique strategy that I have developed that no one else in the world has. That is completely different from traditional counseling and therapy in that we do not dig into your trauma repeatedly, thereby desensitizing it for you as a potential patient. So today, my emphasis is not only going to be upon improving our clinical practice when it comes to trauma-informed care, but also improving our relationships and our practice for those of us that may be in administrative roles to help employees with what is known as vicarious trauma. And so some of what I have already spoken about may not mean a whole lot to you because these subjects are not very well known. So my presentation today will hopefully enlighten everyone out there on these topics and give you some pause, some room to pause and consider your own healthcare systems and whether or not some of these strategies would need to be implemented into your healthcare systems to help, again, not only your patients and clients, but also your staff. So my plan for this presentation is to be very authentic and genuine. I am not editing this. I am doing this all in one fell swoop as if I was presenting live. The only reason I chose to record and then hop on live for the Q&A portion is because I tend to be a talker. And so I needed to make sure that I was honoring the time of everyone in attendance, as well as my colleagues, so that I'm not running into anyone else's time frames. So without further ado, I am going to begin to share my screen. I plan to pop back and forth between you being able to see me on the large screen, as well as my PowerPoint presentation. So let's get started. I'm going to share my screen and pull my presentation up. One more time, I'd like to say thank you all for attending my speech. This is something that is very close to my heart. All right, so here we go. I'm going to move myself up to the top corner here. And I don't believe I can make this bar disappear. So I will just try to move it. Oh, excuse me. I will try to move it out of the way of the presentation to the best of my ability. So again, I am here in representation of my own company, Imperfectly Perfect Coaching. We are located out of Wisconsin in the United States. All of my services are rendered through a virtual format. My presentation today is entitled The Increased Importance of Trauma-Informed Healthcare in a Post-Pandemic World. Again, I'm Cassie Boyd. I have a bachelor's in science of nursing. I am also a practicing RN. I received my bachelor's of science in nursing through George Williams College of Aurora University. And again, I am here in representation of my organization, Imperfectly Perfect Coaching. So let's start by first defining trauma. So when we look up the dictionary definition of trauma, this is what you'll find. The first definition is a deeply distressing or disturbing experience. The example given is a personal trauma, such as the death of a child. And we're all very familiar, those of us who work in the medical realm, of trauma in its second definition, which is referring to a physical injury, such as blunt force trauma, which can cause a variety of adverse health events. So when we're talking about trauma-informed healthcare, there are 6 trauma-informed core principles that need to be understood and put into effect. So we'll discuss these. I do want to point out at this point in the presentation, for anyone that is already getting on board with the concept of instituting trauma-informed healthcare in your own healthcare institutions, there are many ways to collaborate with programs that are pre-existing to help your staff become trauma-informed and receive trauma-informed certificates. So if you are interested in those resources, you would simply go to TIC.org and find an accredited program, collaborate with them in the way that makes the most amount of sense for your own healthcare institution. And on that note, for any individual practitioners who would like to pursue a certificate on their own without it being something that is system-wide within your healthcare organization, that same website does offer some trainings and certifications that you can obtain on your own. I myself am certified in crisis intervention, and I am also a trauma-informed healthcare professional. So getting back to the presentation at hand, we need to discuss the 6 trauma-informed core principles of trauma-informed healthcare. So first and foremost, we need to be understanding of trauma and stress and what that does in changing a person and the delivery of healthcare to them. We also need to look at compassion and dependability of our healthcare providers. There are cultural humility and responsiveness side effects that we need to have in consideration for trauma-informed healthcare. There is safety and stability that we need to look at, as well as collaboration and empowerment of the individuals so that they are more a part of making their healthcare decisions. And then, of course, resiliency and recovery. Just because someone has suffered from trauma does not mean that they are quote unquote damaged goods and will never be able to go on and live the life that they decide they want to live, the life that they so choose. I am living proof of that. I will share with all of you out in the audience that the reason that I have gone into this specific field is because I myself am a multiple trauma survivor in many different facets, those of which we will not discuss at this time due to lack of time constraints. But what I will share is that I have suffered multiple traumas starting in childhood and progressing into my early adult years. So that is why trauma is so near and dear to my heart. Moving along in the presentation, I understand that those of you in the audience are very unlikely to be able to read this graphic in its entirety, but this graphic was important for me to include because it's my understanding that anyone out there that wants to access the slides will be able to do so on an individual basis. And so you may be able to look at this infographic more in depth. There are a few key components that I really wanted to point out. So you won't be able to see those. I won't bother moving this bar out of the way. But beneath that is an additional definition of trauma-informed care. So adding on to our simple definition of what trauma is, trauma-informed care ensures that survivors are not re-traumatized by those of us who are simply trying to help them. And secondly, safety is the main goal of trauma-informed care. Clients are moved away from threats or perceived threats to prevent further exposure to trauma. So there's a famous saying that perception is our own reality. So our own life experiences have led to our own perceptions and thereby our own different varying levels of reality. My reality is not the same as the reality of those of you out there in the audience. A couple more key pieces that I really wanted to touch on is that 70% of adults in the United States have experienced some type of traumatic event at least once in their lifetime. In the work that I've done, I have actually met and worked with individuals who have not been able to identify that they themselves have experienced a traumatic event, and I have had to go back and help them reframe their experiences to understand why they get to this place where they are unable to move forward. They get stuck. It relates back to anyone who has studied psychology, is familiar with Maslow's hierarchy. It gets them stuck in that foundational section of Maslow's hierarchy, where yes, they're meeting their basic physiological needs. And in today's world, that would include having a steady job and steady income in order to be able to meet the rest of those needs of food, water, shelter, socialization, etc. Some other important statistics to refer to in this slide are that people who have experienced trauma are 15 times more likely to attempt suicide, 4 times more likely to become an alcoholic, 4 times more likely to develop a sexually transmitted disease, 4 times more likely to inject drugs, 3 times more likely to experience depression, 2.5 times more likely to smoke. And trauma-informed healthcare aims to eliminate and mitigate those risks to prevent further adverse healthcare outcomes. So let's talk more about re-traumatization. I'm not going to read this entire slide to you, but you can look at the current systemization of healthcare delivery practices, or quote unquote, the way things are done now, and the perception, which is on the right side of your screen, of how a person who has suffered trauma, you're trying to do things in a way that is holistic and in their best interests, but the perception is not received the same way because of their trauma history, which is why it is so critical for healthcare providers to really understand their patients have suffered traumatic events in order to be able to move forward in delivering the best healthcare possible. So the road to trauma-informed care involves a variety of steps. Again, you can go to tic.org if this is something that you are interested in pursuing further. Essentially, trauma-informed care addresses any potential re-traumatizing policies and procedures, and then can ensure a commitment in the entire healthcare system to prevent that re-traumatization, no matter what that may look like for each individual member, client, or patient, however you'd like to phrase that. And then we'll train all of the staff on how to prevent these reoccurrences. Now, the purpose of my presentation today is not only to speak about trauma and the importance of trauma-informed healthcare in a post-pandemic world, not only for our patients, members, clients, but also for us as individual healthcare practitioners, and for those of you in administrative roles, your staff. And so what most people are unaware of is there is a secondary form of trauma that can be incurred, which is called vicarious trauma. Vicarious traumatization is trauma that is incurred by frontline healthcare workers, first responders, firefighters, doctors, nurses. Those of us in the COVID pandemic who have been on the front lines are on a daily basis incurring vicarious trauma simply by the nature of the work that we do. It is a special form of countertransference that's stimulated by exposure to the client, member, or patient's initial traumatic experiences. So this is something that most people are not familiar with, but has very dire consequences in relation to healthcare as it currently exists and our practitioners' ability to continue practicing healthcare. So moving along, excuse me. A second definition of vicarious trauma is the process of change that happens when you care about other people who have been hurt and feel committed or responsible to help them. Over this time, this process can lead to changes in your psychological, physical, and spiritual well-being. So direct exposure to trauma is when we're talking about the primary traumas. I understand this infographic is not the most clear. I was not able to fix that in time to record this presentation. I apologize for that. Again, if you are looking at my slides on an individual basis, it will look more clear. So the direct exposure to trauma is the primary traumas that are incurred by our patients, our members, our clients, however you want to address them. The indirect exposure to trauma is, again, that vicarious trauma or secondary trauma that is incurred by people who are trying to help those who have suffered a primary trauma. Again, this is some more definitions of vicarious trauma or secondary trauma. There's also compassion fatigue, which for the purpose of time saving, we will not dive into. And then of course, there's burnout that's associated with work stress. Again, we're not going to dive into burnout. These are just definitions that are important for anyone out there in healthcare to be aware of. This infographic I included because it was drawn by someone who has specifically experienced a great deal of secondary trauma. And so this was a representation of how that vicarious trauma really affects you as an individual. So in COVID pandemic, the times that we are in now, this graph shows how depression, anxiety, and mental health have been increasing on the charts, as well as stress disorders, burnout and compassion fatigue, and of course, grief. So what does that mean overall? Why is this important? Why are these issues so important to address? Well, number one, individuals who are suffering trauma are less likely to continue to seek healthcare when they fear a lack of compassion and judgment from their healthcare team. So those people continue to seek healthcare after being re-traumatized by our healthcare system at a rate of 12.2%. That is a marginal, tiny amount of people that will continue to seek healthcare after that re-traumatization in the healthcare delivery model. 3 in 10 healthcare workers report having already left or planning to leave their positions in a study that was conducted in April of 2021. We are already in the midst of a staffing shortage. That shortage is going to continue to increase if healthcare models and delivery are not changed to support both our clients as well as our practitioners. So if we continue to dismiss the effects of both primary and secondary traumas, we're doing a disservice to the individuals who have survived the primary trauma, as well as the public servants who are trying to cope with the secondary trauma that is now being incurred. In pre-pandemic studies, 30% of first responders developed behavioral changes related to incurring vicarious traumas. That was in 2018, pre-pandemic. There are no studies that show how many or how much this number has increased in a post-pandemic world. Pre-pandemic studies, again, I had pointed this out earlier in the presentation, show that 70% of Americans had encountered some form of trauma within their lifetimes. Imagine what that number must be now that we're in a post-pandemic world. Suicide rates, alcohol, drug use, divorce, domestic violence, suicidal ideations and attempts have continued to increase, and they are currently increasing at a rate of 96.2% in the general overall population, and that was a study conducted in 2021. Pre-pandemic studies in the military show a rate of 43.3% of military personnel having had a primary trauma prior to becoming enrolled with the military. And then they have suicidal ideations as a result, not a rate, of incurring vicarious or secondary traumas through the nature of their work, leading to 64.7% of those same military personnel attempting suicide. And this was a study conducted back in 2012. Imagine how much those numbers must have increased by now. There's no conclusive studies conducted to date that show the number of public servants and healthcare professionals who currently have both primary and vicarious trauma, but numbers in the general population jumping to that 92.6%. One can only imagine what this means for our global population. So the next steps are as follows. Work with an accredited agency to start implementing trauma-informed practices into your healthcare institution. If you are a healthcare professional who is suffering in silence, please reach out. Utilize your healthcare system's employee assistance programs for free counseling services and additional resources available to you at no cost. Engage with your primary care provider in a conversation to discuss your mental health care options and needs. Seek out a counselor or therapist. Don't be afraid to speak to your employer about vicarious trauma you may be suffering in your line of duty. You can also seek out a coaching service such as my own that seeks to help you overcome both the primary and vicarious traumas. I happen to have a very unique strategy. There are other coaching services out there that are available to you. This is not a sales pitch. This is simply a fact that I am stating that is available to you. Remember that programs were put in place for first responders post 9/11 to assist with mental health care needs. And as of yet, there have been no efforts to put the same type of programs into place for those who have been working frontline within the pandemic. My main message that I want you all to absorb at the end of this presentation is that enough lives have been lost to COVID itself. Let's all come together to break the stigmas related to mental health and prevent the loss of life from the trauma it has inflicted on our frontline workers. And one last thing, if you or anyone you know have thoughts of self-harm, do not delay. Please immediately contact your local law enforcement and healthcare agencies to get help immediately. Do not wait. Please reach out for help if you are struggling or you know someone who is struggling. Again, I am from Imperfectly Perfect Coaching. Here is a list of my references, which you can easily access. And here is my contact information should you want to reach out and discuss any of this information further directly with myself. I do have the email address listed as well as a phone number. I thank you all for taking the time to watch my presentation. That is the conclusion of my presentation. And now I will be hopping on live to answer any questions that you may have related to any of the information that I have presented. Again, thank you so much for your participation, and I look forward to answering any questions.
Yes. Any questions? Any questions? Any questions to Dr. Cassie Boyd?
I'm here. I'm available. I'm going to start my video here so that people can see me. Hello, everyone. Thank you so much for engaging with and watching my presentation. It's an honor to be here. It's an honor for me to be able to speak about this topic. I do want to make one clarifying point. I'm not a doctor.
I am working towards my doctorate at some point as a nurse practitioner, but I don't have the honor of that title just quite yet. So just wanted to make sure that that was 100% clear to all of our viewers out there. So I noted a couple of questions within the chat sections. I have included my email. There are a lot of different organizations out there that can help healthcare systems to become what is known as trauma certified. However, I do want to point out that a lot of those organizations do not have an accredited program. And so if you would like further guidance on that as an individual or as an administrator of a healthcare system, there are better resources I can share with you. One of the best out there that I would recommend is tic.org, and they will be able to help guide you to the different programs that would be most beneficial for your particular needs. So any other questions?
Yes, any questions? Any questions to Cassie Boyd? Just if you have any questions, you can raise your hand, you can ask from the chat box. You can read from chat box when you have got a compliments, very timely content. Thank you for sharing. Thank you.
Thank you for having me.
Yes, this was a great from Dr. Catherine.
Thank you very much.
As well as
I look forward to watching everyone else's presentations. Again, you have access to my contact information if you have further questions or concerns for me. This was wonderful, and I will continue to watch the rest of the presentation scheduled for today. Thank you very much.
Yes, thank you. Thank you very much. Yes, thank you very much for joining as a speaker for this event. Looking forward to meet again next time. Next, we ask Dr. Cassie Pachakov-Moron from the Sparky Slough Community Nurse Consultant and Preventive Health Advocate from USA.
And I thank you so much for inviting me as a speaker at this year's nursing conference. I am so happy to be here. I am a bedside nurse, and currently I am on my way to starting a nonprofit organization. I will put out a disclaimer. I have a no scientific breakthrough, just really loving thoughts to share with you. I'm addressing everyone in this room who cares about saving and perpetuating human life. I call you preservers of life. Yes, you are a preserver of life. You're here because you care about people and you want to save life. Why am I talking about this subject, about healing humanity from the inside out? Well, we're at a pretty interesting place in history. We are on the brink of a global systemic collapse of the healthcare system. Sounds a little bit doomsday, right? But that's not why I'm here. Because when there is breakdown, you have a unique opportunity to start all over again. Yes, we are also on the brink of the dawn of a new era for healthcare. The wise man once said, if you build a house on a sand, when the rains pour and the flood come, right, and the winds blow, the collapse will be great. So we are seeing a collapse right now. But this highlights something very important. The foundations of our current system was built on sand. You see, sand is just loose dirt. It's barely held together. And we have allowed private thoughts and aspirations of a few to create a system where profit and value comes above healing. It's common knowledge that there is no money to be made from cures. So the value of human beings was turned into a commodity of human doing. Why am I addressing healthcare? Well, we built a system where we encourage consumption of healthcare that is not sustainable. We work a person to death and replace them when they're gone. And currently, as we bleed out nurses, all we could think about is more, we need more. Just like a fire, we will never be satisfied. You see, poor work-life balance has created this problem. We told our patients, expect excellence without requiring them to excellently care for themselves. We measure success in terms of metrics that never took the well-being of our staff into consideration. In meeting those metrics and planning out our important life-saving work, we never stopped to use the bathroom or plan and eat a nutritious meal. We did all of this in order to deliver excellence. Now, humanity cries. And when our own bodies whispered, we ignored. Just one more patient, one more life, one more task, with each action depleting from our very being. Now our nursing bodies are about to scream. And the world, will they listen? Humans, we need to realize an important fact. If we don't listen to the cries of those who don't matter, one day we won't matter. What is the problem? Why did this all happen? Where did this all come from? Well, the root of the problem is not the problem itself, but it is the mindset. It's a mindset that grew from chattel slavery. The mindset is human beings are a commodity, and a very valuable one at that. You see, placing a price and creating a system that places a monetary value on the life of a priceless human is the very base of the problem faced in modern day society. Even if every healthcare worker had the opportunity to work for free, we would still be trapped in this messy situation. Why? Because the ownership and consumption of human resource is trapping us. This is not the doing of the elite or the corporation. After many years, our work has become our identity. We pride ourselves on all our ambition and accomplishment, but our value and personal esteem as a human being is worth very little. Yes, my colleagues, I am so proud of our academic, economic, and scientific accomplishments. But that double shift that you pull, that soda that you drink every day, that greasy, fatty, sugary foods that we eat just to provide excellent care, is putting us front and center to death's door. The time spent away from home and family that we boast as dedication is ruining our families. It is ruining our mental health, and it is the actual cause of disease. I personally experienced within my past working relationships the loss of two colleagues. I watched them smoke the stress away and eat their sorrows away till death took its grip on them. Every day I watched them walk into work with habits that I know one day would catch up to them, all to care for another person. Currently, as nurses, we think our idea is innovation. and I am all for innovation. I actually have a story about innovation. About 5 years ago, I worked at a large healthcare institution in the southern United States, and they hosted a forum for all the nurses. And management and the CEO, they wanted to know what innovative ideas the bedside nurses had. They were concerned that big tech such as Apple, Google, and Amazon would tap their hands into the profits and make the current hospitalization system obsolete. So they were asking us nurses if we had any ideas. So I looked around and I was surprised that none of the nurses will volunteer an information. All they had to talk about was the staffing issues and the current needs that were being ignored. I thought to myself, why won't these nurses offer a solution? Well, I didn't have to wait too long to understand why. You see, later on, they took us to some of the nurses who were showcasing their innovative ideas. And I saw a nurse standing at a poster board, and she was boasting about how her innovation saved millions of lives and millions, maybe even billions of dollars. So I looked at her and I said, wow, you must really love your job, because why are you still working here? And she said, I didn't get any money from it. Because I was working for this company, the patent became theirs and I got a certificate. You see, this is what I'm talking about. The flames of injustice burns within me just relating this story to you. You see, innovation is good, but the time for innovation has passed. Innovation at this time is like building on a sandcastle. This sandcastle is about to be gone. And this is why I'm here today, because we are laying a brick for the new foundation of healthcare. We are no longer going to build on a broken system. We are here to encourage you to act. And I hope that you are a rock-like person that I am parking these thoughts on. A rock-like solid person, a person with integrity, with heart, and with courage to act. This is why I think you came here today, because you are this type of person. One thing I will say before I could build on any thought, and that is this brick I'm laying for this new foundation. Human beings are not for sale. Life is not a commodity. It is a precious gift to be lived and experienced. I'll say it once more. Human beings are not for sale. What's that? Human beings are not for sale. When I say human beings are not for sale, what I mean is not just one person selling out another person, but I mean that we as humans are selling ourselves, and we are selling ourselves short. We cannot continue to sacrifice ourselves on the altar of ambition and success. I like complex things. I like to sound complex. I think we all do. You know, you look at some of the names of our drugs and our medications and our processes. It is so complex because when we say things really complex, it makes us sound smart and we feel like we know something that somebody doesn't, you know? But I must admit that the solution to our problems, where it will take a lot of work, it actually is very simple. You know, the base of nursing, as instituted by Florence Nightingale, was very simple. She saved many lives. She did simple things as encouraging physicians and nurses to wash their hands in between patients, open the blinds and let fresh air and sunlight in. You see, it is simple, and the mindset change is simple. Stop selling ourselves. When is this change going to happen? Now. It is now. But let's be truthful. Are you ready for it? Are you prepared for it? Well, I came to share some steps of how we can be prepared for it. Step back and evaluate your view on humans in terms of value. Now, you may say, well, I love humans. They're valuable. That's why I got into this profession. Of course, they're valuable. Of course, you care about people. But what I'm talking about is how much do you care about people? How valuable, just how valuable are they to you? Are they valuable enough for you to state your opinion and risk losing your job, your license, your reputation, your accreditation? Yes, we say that they have value, but I am here to elevate your awareness and raise your consciousness. Just how valuable are they to you? Why so extreme? Because someone took extreme action or inaction that got us here. Think of it. If one day no person on the planet had any illness anymore, we would say that would be awesome. But really, would it? That will mean that everything you work for, your job, your license, your reputation, your accreditation, everything, your studies, everything that you are currently working on and have worked for in the past will be useless. Your heart may be good natured, and you may say, I won't care. But the truth is, the people who do care about losing it all has more power and influence than they should. And not too many people are willing to suffer loss for the right thing. You know, one day we will die, but I hope when you and I die, we will have done the right thing for humankind. How? Where do we go from here? Well, this is why I came to speak today. We must be models of healthcare and wellness. We live in a system that glorifies selling ourselves as healthcare providers. We sell our health, we sell our wellness to provide health and wellness to others. That does not make sense. We are so depleted, and only to find out that the people we serve aren't really satisfied. At least the airlines got it right. They say, put on your oxygen mask first before you put it on others. Think about this. Can a hairdresser walk around with messed up hair? Can a fashion designer walk around in rags? If not, why is it okay for a nurse and a doctor, a healthcare provider, to not be healthy? When I say not healthy, I don't mean free from disease. Healthy, meaning every aspect of our lives should exude that we are fit to be preservers of life. Holistic health. We must raise the bar for ourselves first, because then we would each see how to raise the bar for everyone else. If we personally strive and achieve good health ourselves, we would know how to help others. Now, you may say, I'm in good health, and I even encourage and set up a health plan for those who work under me. But when it comes to the mindset of healthy expectations, is it really healthy for one person to have healthy conditions at the expense of another person to produce their unhealthy expectations? This is not just healthcare. This is actually addressed to every business and corporation out there. However, I must address healthcare first, because we should be role models of what health looks like. You know, in retrospect, I wish that company, that healthcare organization I worked for, that met 5 years ago, who tried to stop innovative ideas from the nurses, I wish that they adopted this mindset. The mindset I am presenting to you today. The mindset of giving. Instead of focusing on getting ideas modeled after big tech, I wish they wanted to infuse ideas modeled after big tech. I wish they were prepared to make changes to create a healthy culture, just like big tech has for their employees. That would have cost a lot of money. But 5 years down the road today, it would have meant everything, especially being thrusted into the middle of a pandemic. If you want to save a person, we have two things. We have our brain and we have our emotion. Now, our brains or our instincts will say, go with all your might and pull him out as hard as you can. However, wisdom says, step back, find a tree, get a rope, toss it to him, because that will give you 3 points of strength where you can have a good foundation. You can use your strength to pull him up. He can use his strength to pull himself up, and you will have a tree as a grounding force or a foundation for the both of you. And you can do what you intended. I am here to share wisdom, thoughts of wisdom with you. Why? Because you are not the problem. We are not the problem. We are actually the solution for the future. We came here to solve the problems that we were handed from the past. Let us not be an addict trying to solve a problem in a way that creates even more of a problem later. Dr. Gabor Mate, an addiction specialist, says that we as providers are unable to help addicts because we don't get to the cause of the problem, the cause of the pain, the why. Can the same be said with healthcare? I wonder if we actually took a look holistically at caring and we asked this question, instead of saying, what's the matter with you? We said, what matters to you? Before we can ask others, we first must ask ourselves. And then we would really care when we ask others, we would really care to hear their answers. Maybe this simple question, what matters to you? When it is asked, not with the attempt to fix the problem, but to understand the person, may infuse some true love and kindness into this world. What matters to me is you and I being healthy. I want to see us walk away from this pandemic with blocks to build like the house that is on the rock, with strength and inner courage and morale, not just being exhausted and broken. You see, if we fail, we become part of a system that not just failed the population, but also failed ourselves. I am committed to nursing humanity back to health. And it starts where everything starts, the basic institution of society, the family. I am starting with mine. I will work my way up from there and be a good nurse to myself, to my family, eventually to my community, my country, and the globe. I hope that I put some good ideas in your mind today, that there is no value that can be put on the life of a human being. When you try, we will always end up here. In conclusion, I value your life. I respect your skills. And that is why I stood up and delivered this speech today. We are not merely medical workers. We are not givers or takers of life. Call us who we are. We are preservers of life. Let us nurture and preserve our own life and then encourage others to follow suit. My name is Casey Pacheco. I am a registered nurse, and I thank you for listening to this speech about healing ourselves inside out. Thank you.
Yes, this was the presentation from Kasey Moran.
Casey, hi, I'm here. Thank you for playing. Thank you for having me.
Yes, ma'am.
I do appreciate it. Thank you for listening and your attention.
Yes, any questions? Any questions? If you have any questions, you can raise. We'll be asking behalf of you. Yes, thank you very much, madam, for joining as a speaker for this event. You are given with a general topic. Yes, looking forward to meet again next time. This was the general topic we heard from you. We really appreciate everything that you have done too. It was a great video. We want to thank you for inside pressure. Looking forward to meet again next time. Even after the completion of the conference, within 3 to 4 days of the conference, you will be getting electronic certificate as well as electronic booklet officially through your email ID. Next, we ask Dr. Fabino Rosa Rezede Honda from University Paulista from Brazil.
From all over the world. I would like to thank you for the opportunity of participate in the Congress with nurses from all over the world to get to know a little of the nursing practice in various places. I will present this work done in conjunction with a nursing undergraduate student at Universidade Paulista. The elderly population, over 60 years old, tends to grow about 300% in an average of 50 years in emerging countries. According to research, people between the ages of 50 and 80 are hospitalized with depression or because they have recurrent depressive states. When depression is identified in the elderly, it can be treated, but its diagnosis in elderly by several research related to the patient, such as multimorbidities, dementia, in intermediate and advanced stages. And it's related to lack of social interaction with the social group they are used to. The objective of the work was to detect if there is underdiagnosis or undertreatment of people with present depressive conditions, verify how the diagnosis of depression imaging in the elderly. We conducted field research with a qualitative approach with people over 30 years with both sexes, who answered the mini mental state examination questionnaire, the geriatric depression scale, and the patient health questionnaire. We interviewed 100 people, most of all 62% were women. Most respondents were over the age of 40, 42% of women and 50% of men. 39% of respondents reported little interest or pleasure in doing things. 45% of women and 36% for men. Interestingly, both men and women had a high percentage of depressive symptoms for more than 4 weeks. We just conclude adult and elderly women responded affirmatively to the questions about anxiety, depression symptoms compared to the results obtained by adults and elderly men. The whole women are given to their lives to increase stress, anxiety, and the symptoms are not detected and treated early. They will blood to develop in depressive states that. Thank you.
This was the presentation from Dr. Fabino Rosa from Brazil. So if you have any questions regarding this topic, that is titled Depression in the Elderly, the importance of diagnosis and the treatment, you can send us the questions. We'll be asking behalf of you to concerned professor. So to end of these sessions, we do have last two more speakers, that is Dr. Kelly Miriam as well as Dr. Yosra. So we asked Dr. Kelly Miriam from Vallejo University from Peru to start the presentation.
Boa tarde.
Yes, you can go ahead, ma'am.
Boa tarde, tenho muito prazer de fazer esta apresentação no idioma português. Quero parabenizar e dar os meus saúdos a cada um dos profissionais especialistas da enfermagem e outros participantes. Aqui, desde Peru, tenho a bem apresentar uma experiência vivida pela equipe de pesquisa da Universidade César Vallejo, com a participação internacional da Universidade de Chile, de um dos participantes. O título é Funcionamento familiar, pessoalidade, estilos e as relações com empatia dos estudantes da enfermagem. Este trabalho tem uma coautoria com equipe de trabalho de pesquisa da Universidade César Vallejo, como eu falei, a Universidade Chilena. A relação enfermeira e cuidador é entendida como um intenso componente subjetivo e intersubjetivo, como uma relação e interação dialética, no qual o fator humano se torna muito importante e a enfermagem deve avaliar conscientemente para garantir capacidades cognitivas, comportamentais e técnicas para fornecer os cuidados de qualidade, desenvolvendo uma comunicação empática. Deste jeito, pode entender como as experiências e sentimentos do cuidador influenciam e são influenciados pela doença e constituem um dos elementos necessários para o desenvolvimento das habilidades básicas de comunicação por parte da enfermeira, quem é a que oferece alguns os cuidados. Aqui tem alguns estudos, dos muitos que este trabalho tem, mais de 95. E diz estes estudos de Rojar, a empatia está teoricamente e empiricamente relacionada aos vários componentes com o comportamento prosocial, é dizer, capacidade de perceber o nível de satisfação mútua nessa interação por os bons resultados terapêuticos. Este é um objeto de controvérsia entre as comunidades científicas, mas no tempo tem que seguir estudando para ser desenvolvido de uma maneira intencional. Uma vez que, considerando que é um atributo notável nos processos de interação com os usuários, seus familiares e seus colegas, o diálogo que tem o paciente com a enfermagem sobre os medos e as apreensões fortalece o relacionamento enfermeiro-paciente, pessoa, família, comunidade, e o planejamento do tratamento é melhor recebido. A empatia do estudante está sujeita à influência dos muitos fatores, tais como idade, sexo, interesse pela especialidade que ele quer seguir no futuro, a estrutura familiar, o clima, a pessoalidade dele, as experiências empáticas, o ambiente sociocultural onde ele se desenvolve, a escala dos valores éticos, morais, entre outros fatores que poderiam atuar como variáveis independentes. Aqui temos as variáveis independentes e vamos começar com empatia. No campo da saúde, ela é considerada como um conceito que engloba aspectos cognitivos, afetivos, definidos com a expressão de regular os sentimentos, ideias, a predisposição da pessoa para compreender aos outros e que os outros experimentam no contexto do desenvolvimento profissional. Os valores serão determinados, neste projeto foram determinados pela aplicação de uma escala de empatia de Jefferson, uma versão que foi adaptada no espanhol para os estudantes da Universidade César Vallejo. O ponto de forte que foi permitido fazer classificações, um assunto que é considerado mais empático na medida que se aproxima ao valor de 140 pontos do valor máximo na escada e o valor mínimo de 20 pontos. Um aspecto importante que foi considerado foi o gênero masculino e feminino. Também o nível da carreira foram considerados do primeiro até o quinto ano dos 10 semestres acadêmicos que ele faz. Por outro lado, temos o funcionamento familiar. Uma família é considerada funcional quando fomenta o desenvolvimento integral de seus membros, promovendo ou crescendo cada um deles, de modo que as suas interações entre eles e relacionamentos vão a permitir-lhes relacionar e resolver situações de conflito de uma maneira mais proativa, de uma maneira mais com intuição, tanto espiritual como cognitiva e intelectual algumas vezes. e assim melhorar o clima familiar. Por outro lado, temos o conceito da personalidade, que é um conjunto complexo das características comportamentais estáveis no tempo e profundamente enraizadas, manifestadas em todas as áreas fundamentais da pessoa, seja como tendências de perceber, sentir, pensar, agir e relacionar-se com outros, resultantes das interações, tanto dos componentes biológicos de aprendizagem que se expressam no curso do desenvolvimento individual. Neste trabalho foi utilizado a dimensão de coesão, de adaptabilidade e avaliada da seguinte maneira. Temos aqui as dimensões, o nível e a pontuação. Temos a coesão, desapegado, separado, conectado, ligado, rígido, para a dimensão de coesão. A pontuação foi de 0 até 40. Por outro lado, a adaptabilidade tem a ver com um nível rígido, estruturado, flexível, caótico, e a pontuação também é até 40. Os objetivos desta pesquisa foram determinar o funcionamento familiar, os estilos da personalidade e sua relação com os níveis de empatia dos estudantes de enfermagem. Os objetivos específicos foram descrever as características sociodemográficas, identificar o funcionamento familiar, se este tem relação com os níveis de empatia, identificar os estilos da personalidade deles, se tem a relação com a empatia, e comprovar a existência da variabilidade entre o funcionamento familiar, os estilos da personalidade e os níveis de empatia, considerando os fatores ano acadêmico e gênero. A justificação pela elevada incidência na comunicação da atitude empática por parte do pessoal da saúde, conforme reporta este trabalho de pesquisa, mais das 3/4 partes, respectivamente, têm nestes trabalhos resultado baixo ou malo. Neste sentido, os estudantes, ao melhorar a interação empática entre eles mesmos, vão a optimizar a comunicação com os sujeitos da sua atenção, nos centros assistenciais, comunitários e outros, em favor da saúde e bem-estar das populações que ele cuida. A relevância deste estudo, estes resultados serão úteis a outros pesquisadores para seguir poniendo na prática a empatia, tão importante no processo de humanizar a prática profissional de enfermagem em todos os âmbitos de onde ele cuida. Aqui temos a metodologia. O tipo de pesquisa foi aplicada, quantitativa, se baseia nas evidências científicas e envolve problemas práticos da sociedade. O desenho foi transversal, observacional, pois as variáveis não foram manipuladas, observando os fatos em seu contexto natural e depois foram analisados não, na coleta de dados num solo momento. A pesquisa é de nível correlacional, pois avalia as associações nas suas relações entre elas, o que significa um fator na influência, não, em os outros. A população foram os estudantes que conformaram e somaram, desculpe,
¡Que recorre! Ahora sí yo no me muero.
a população foram os estudantes que somaram 1.016 estudantes nesta leitura, desde primeiro até o 10º. O maior, quase 50% deles se encontram no primeiro e no segundo semestre. Foi uma pesquisa descritiva, né? Se fizeram uma análise estatística delas. Para elas, como já falei, se utilizaram os 3 instrumentos, né? Instrumento de Jefferson, de empatia, instrumento de estilo da personalidade e funcionamento familiar nas escalas. Se respeitaram os aspectos éticos correspondentes a este tipo de pesquisas. Aqui temos a avaliação e a confiabilidade dos instrumentos. Para isso, foi muito importante fazer uma prova piloto, que foram 56 estudantes a quienes se lhe aplicaram para logo fazer as provas da validez e confiabilidade. A confiabilidade dos instrumentos é a que dá resultados consistentes e coerentes e foi calculada com alfa de Convert. Para este fim, os dados obtidos se fizeram e foram analisados com o sistema SPS número 27. A validade do instrumento expressa o grau que o instrumento reflete um domínio de conteúdo, concordo com o que ele pretende medir. Aqui, a validade, aqui a confiabilidade foi ótima para os 3, não? Muito alta. Por outro lado, em termos de características sociodemográficas, aqui eu quero fazer uma análise muito rápida por el tempo, não? Os 2 primeiros ciclos de estudo representam a metade do total. A enfermagem é uma das carreiras com maior número de matrículas na graduação. Estes anos de pandemia, os 3 semestres últimos, temos até 14 aulas de 60 estudantes em cada uma delas. Elas procuram, na búsqueda de estudos, no licença para fazer, porque a universidade foi licenciada e passou por um processo de acreditação institucional muito bom. Então, a universidade é uma universidade César Vallejo, muito procurada por a população peruana e internacional também. Neste trabalho, se confirma que as mulheres são inclinadas a estudar esta profissão, 88,7%, cujos roles ou papéis estão ligados aos estereotipos de gênero, como o cuidado da família e das crianças. 10% da população são homens. Muitos deles têm algumas experiências estigmatizantes que se configuram como barreiras profissionais baseadas no gênero também pelos homens. As idades correspondem a grupos de adolescentes e jovens adultos entre os 15 até 34 anos, que o Instituto Nacional de Estadística de Peru calcula a idade e sexo dos estudantes universitários do Peru. Estão nessa faixa etária. A maioria dos irmãos deles são de ambos sexos, são primogênitos, estudantes, são solteiros e vivem muitos com os pais. Há um alto porcentagem que também alguns vivem solo com um pai. A população peruana, nos últimos tempos, está mostrando traços de diminuição da fertilidade, né? Aproximadamente um terço da população estudava bem desde as áreas rurais. As mães têm educação secundária, um quarto deles tem filhos e um quarto mais deles tem só educação primária. Os estudantes escolheriam como de uma maneira preferencial estudar no centro cirúrgico, né? E também escolheriam estudar cuidado infantil. Na maioria das famílias dos estudantes entrevistados, o menino ou estudante que estuda enfermagem é o único profissional da família, porque eles pertencem às áreas de desenvolvimento da região metropolitana de Lima, no Peru. Aqui nesta tabela, o funcionamento familiar apresenta uma coesão aglutinada em mais de 50%, mesmo que apresenta um alto nível de identificação familiar. Outras formas de interferência apresentadas são os limites intergeneracionais, que não são tão claros na população peruana, quanto aos tempos, aos amigos, atividades individuais que são compartilhadas com a família, o que limita seu desenvolvimento individual e, portanto, sua autonomia. Os estudantes da família, um quarto da população tem uma família conectada. Não tem na dimensão de adaptabilidade. A metade deles tem um tipo caótico e um terço deles são flexíveis. Quando estamos falando destes resultados, acerca de um quarto das famílias é considerada significativa, cujas características estão relacionadas com a dependência e a coesão familiar moderada. Existem limites, mais espaços para os amigos, tempo para si mesmos e para a família. Tem equilíbrios, somente decisões importantes são tomadas concordando com a família. Estes resultados têm concordância, não? Com os estudos de Stachini e Toma, nos anos 2020, eles concluem que a funcionalidade familiar e a eficácia da família em alcançar um equilíbrio é uma ordem importantíssimo e a unidade diante das exigências do ciclo da vida, sendo que um quinto da população estuda neste sentido, nestes termos. Por outro lado, aqui temos uma figura que é a figura que é o circunflexo, modelo circunflexo de Olson. Para Olson, a coesão é um vínculo afetivo entre os membros da família e que é semelhante neste trabalho nos resultados encontrados. Quase a metade dos estudantes da enfermagem tem uma família conectada, tem uma coesão. Ou seja, eles têm uma união afetiva, fidelidade e interdependência entre os membros e, às vezes, uma dependência familiar. Os membros da família destes estudantes valorizam o tempo que passam juntos e tomam decisões em conjunto. Entretanto, uma terceira parte apresenta uma coesão separada. Isso está relacionado, né, com a distância familiar, que é preferida algumas vezes pelos interesses e são também por alguns actos de recreação e eles preferem afastar-se. Na adaptabilidade, o 50% é caótica. E há uma liderança limitada e ineficaz neste grupo de estudantes. Não tem controle, a disciplina é moderadamente severa, há inconsistência com as decisões de seus pais que são, às vezes, impulsivas, os papéis não são muito claros, as regras familiares mudam frequentemente, e isso gera confusão entre o que eles olham de seus pais e o que, na prática, os pais exigem deles. Então, existe uma ausência de liderança disciplinária e regular. Por outro lado, a adaptabilidade flexível é demonstrada em quase um terço da população estudada, com a liderança igualitária dos pais, filhos. Isto permite mudanças suaves e concertadas, o controle da família, acordo da tomada da decisão. A disciplina pode ser dita de uma maneira democrática. Por outro lado, na variável funcionamento familiar, genera coesão aglutinada e adaptabilidade caótica. Ela leva a um extremo do funcionamento familiar. Significa que aspectos não tão favoráveis são gerados. Suas características são muito intensas, às vezes pode ser benéfica, mas não gera estabilidade. Há dificuldades com qualquer membro da família, seja por a unidade do matrimônio, ou pode desencadenar um funcionamento extremo, divórcio, problemas, e pode ser melhorada com estratégias de ajuda familiar. A adaptabilidade do funcionamento da família, conforme Olson define, é a capacidade da família de mudar sua estrutura familiar com o objetivo de superar as dificuldades pelas quais passa ao longo da vida. Com a relação à empatia variável, na presente pesquisa, se verificou que a metade de estudantes tem um alto nível de empatia e tem um maior nível de empatia. Então, nós podemos dizer que os estudantes da Universidade César Vallejo oferecem empatia em nível alto e muito alto. Isso tem discordância com um estudo no Chile, que estas descobertas não são consistentes com as desta pesquisa, porque aqui diminui em alguns estudantes conforme avançam suas carreiras em ciclos ou anos superiores. Então, deste resultado, podemos dizer que a enfermeira deve ter capacidades de perceber os sentimentos do ser humano que ele procura, de colocar-se no lugar deles, de compreender a fundo sua situação. Ela deve obter uma percepção particularmente fina e sensível dos sentimentos, experiências dos outros, da outra pessoa, com a finalidade, com a intenção de conectar-se com o mundo interior da outra pessoa e facilitar a resolução das crises que são permanentes na área da saúde. Aqui temos umas tabelas, que são tabelas mais metodológicas, não? Em las três variáveis tem uma distribuição normal, não? Que há muitos valores que são baixos e altos, portanto, as meias são enviesadas para a direita ou para a esquerda. Nesta tabela, os níveis de empatia dos estudantes de enfermagem da Universidade César Vallejo mostram que estão relacionados ao funcionamento da família. Quanta importância o funcionamento da família para a formação da enfermagem. Existe uma correlação direta, o que significa que quanto melhor é o funcionamento familiar, maior será o nível de empatia que os estudantes oferecem. As variáveis estão direta e significativamente correlacionadas, e quanto maior o funcionamento da família, maior o nível de empatia dos estudantes. É o mesmo. Na tabela 6, a pessoalidade dos alunos nos estudos se correlaciona de maneira inversa e é muito significativa com a empatia, indicando que se a população tem uma pontuação de personalidade maior, a correlação é inversa. É que a pontuação de empatia da outra diminui. Nesta tabela, mostra a pontuação do funcionamento da família com diferenças significativas conforme com os ciclos de estudo. Se verificou que a medida que é maior no 7º ciclo, mais que no 6º ciclo, seguido por el 10º ciclo. As pontuações meias variam significativamente nos diferentes ciclos de forma desproporcional e não seguem uma ordem específica com ordem do processo de ciclo. Então, estamos dizendo que não existem regras. O que deve existir é que a família deve apoiar para desenvolvimento da empatia. A personalidade também foram encontradas diferenças significativas, concordem com os diferentes ciclos. Bom, pelo último agora, as conclusões. Se confirma a tendência de que as mulheres estão inclinadas a estudar enfermagem, cujos papéis estão ligados aos estereotipos de gênero, como o cuidado da família e a criança dos filhos. Os estudantes de enfermagem têm uma coesão conectada, caracterizada pela união afetiva, pela fidelidade e interdependência entre os membros da sua família, às vezes com tendência à dependência. Existe alguma interdependência entre os membros da mesma família de 1/3 dos estudantes, com tendência à interdependência e envolvimento que é aceita, mas a distância familiar é preferida, pois os interesses são diferentes ante a recreação dos mesmos estudantes. Por outro lado, a empatia variável na presente pesquisa, se constatou que o 50% dos estudantes de enfermagem apresenta um excelente e alto nível de empatia, quase ao 91%, numa condição essencial para ser enfermeiros. O treinamento pré-profissional dos estudantes de enfermagem lhes permite desenvolver e fornecer as competências de empatia e da atitude humanística que eles demonstram no seu cuidado. O funcionamento familiar dos estudantes de enfermagem é mais elevado nos estudantes a partir da metade da carreira profissional, até o final da carreira. Algumas recomendações: estimular a tendência dos homens a estudar enfermagem, a fim de quebrar os estereotipos de gênero. Otimizar a coesão entre estudantes de enfermagem, com oficinas sobre fronteiras intergeneracionais em favor dos papéis familiares. Incentivar a interação familiar com respeito às individualidades, as singularidades compartilhadas com cada dos membros da família. E, para terminar, dar sustentabilidade às atitudes empáticas presentes na maioria dos estudantes do estudo, com oficinas de conceitos de empatia. Fortalecer os conteúdos curriculares para proporcionar sustentabilidade e melhorar o desenvolvimento das competências das atitudes empáticas e humanísticas, favorecendo a formação profissional na arte de cuidar da enfermagem. Por último, continuar este tipo de trabalho de pesquisa para avaliar e realizar ações que favoreçam o funcionamento familiar dos estudantes da enfermagem nos primeiros ciclos da carreira. Algumas referências bibliográficas e regalo para o presente para vocês, desde Peru, Machu Picchu, a Cordilheira de Cores dos Andes. Muito obrigada. Thank you very much.
Yes. Yes, thank you very much, madam. It was a long presentation. It's more than 40 minutes. We understand only through subtitle of your. Yes. Any questions? If you have any questions, you can mail us. We'll be sending you official through email ID. Thank you very much, mate, for joining this event. Hope you expect your presence for next time. We have enjoyed your speech. Pleased with your topic. Looking forward to meet again next time. Finally, I would like to inform that we have understood only through subtitle of the English. Thank you very much. Yes. The day 1, 24 September, the last session of the today's talk will be, speaker will be Dr. Yusra Raziani from Kumar University of Science and Technology from Iraq.
Hello everyone, hope you are having good. This is Yusra Raziani. For me it is bedtime, almost bedtime, so I would say good evening. This is Yusra Raziani. I am presenter of my university, Kumar University of Science and Technology in Iraq. My specialty is pediatric nursing, and thanks for having me today for presenting my topic. Here I would say that the topic of my presentation is about OSCE and students' voice toward improvement this clinical examination. As we all know, nursing involves hands-on psychomotor skills and clinical decisions, and so need to be evaluated in a method that covers both domains. The most important goal of students' assessment is promoting learning process and education quality. OSCE, which is standing for an objective structured clinical examination, is a modern type of evaluation used in health sciences. In this evaluation method, multiple stations are designed and different nursing skills are tested in each station. And all learners go through all stations and are judged by the same tools and nursing skills. Also, evidence showed that OSCE boosts students' confidence and help them feel more prepared for clinical work. There are several factors that can end in error and affect the reliability of tests, including students and examiners' personality, differences in educational background, and also the differences in evaluation methods and instruments. As the students are the primary customers of education system, it's important to investigate their opinion toward the evaluation method in order to design a more student-centered and standard test that can meet all expectations from both students and examiners. The primary aim of this study, as you can see, was the exploring nursing students' opinion, as they are accounting for a large percentage of population in health community. Regarding the study design, it was a quality exploratory study, and it was structured according to the correct or consolidated criteria for reporting quality of research. The study population, as I mentioned previously, were nursing students, and the criteria for students' entry were passing all theory and clinical units for the degree of Bachelor of Nursing, and being eligible for the OSCE, and also willingness to participate in the survey, and also we have asked them to share their experience in this field. Data were collected through semi-structured interview. In the interview, the students were encouraged to share their experiences with the OSCE in a 30 to 45 minutes period of time. We stayed the interviews with the questions of the tell me about the OSCE experience, the OSCE test that you have took. And then we continue with asking the question that what sorts of problems did you notice there? What suggestions do you have to solve this problem? And finally, we concluded with the question that how would you design the test if you were in the position of manager or designer of the test? Exploratory questions continued based on the individual experiences for sure. Sampling and interview were continued until the data saturation was achieved, and for our study, it was after 45 interviews. Then we transcribed the interviews and read them several times to reach a sense of the whole. Data were analyzed using a conventional content analysis method using the Granheim and Landsman's proposed steps, and initial coding was planned. To verify the coding method, 5 nursing professor specialists in nursing education checked the codes and verified them. The results showed that the mean age of the participants was 22 and 55% of the participants were male. We emerged 2 main themes through data analysis, including managerial and educational aspects, as you see in the poster. In managerial theme, we had three main subdivisions of supervisors' behavior, time management, and availability of facilities. And then educational background, questions type, and simulation were grouped for educational concerns. In our study, 65% of students confirmed that supervisors' way of looking and supervisors' behavior could either increase or decrease their boost in anxiety or confidence during the exam. As they mentioned, that some of the supervisors' reaction have such a so-called negative impulse on their performance. So in order to improve the OSCE's position in clinical evaluation, it's important to train and organize supervisors' behavior on the board. Our participants reported a mismanagement in time allocation for each station. They state that in some stations, the allocated time for some stations was much more than the required time. And at the other end of the spectrum, in the other stations, they were run out of time to complete their procedure. That means that the time should be specified according to the type of the procedure, and it should be taken into account that the pace of learning and pace of action varies from student to other students. So a minimum and maximum time should be considered for each procedure. At the time, a limitation, either more or less time, can increase the stress and anxiety for participants. Regarding the availability of facilities, the selected place should meet the fundamentals of the exam room. As our students complained about the temperature, lighting, space outside disturbing noise and ventilation. For sure, it is undeniable that providing the sufficient facilities play a key role for a standard evaluation. The results of our study indicate a lack of reality in the exam hall. As the students mentioned, they had difficulty in communicating with mannequins and models, and they perceived that the mannequins lack reality, and it is kind of difficult to demonstrate all skills that the students have. So the models need to be trained in terms of how to react, how to speak, and by and large, how to portray a real patient. Educational background also was one of the most reported problems in the present study. Our participants complained that they have never been in such an environment before, and it took them a while to find their feet. In a new position, actually, they also declared that through the whole 4 years of education, they were evaluated through the theoretical based method, and it was their first. So we need to educate, we need to train our supervisors, our lecturers, our teachers to take into account more clinical methods rather than theory-based methods. We need to prepare our students for OSCE by conducting several similar tests before the main one, and also training the teachers to use more clinical methods in the whole program, not only in the last year and in the last exam of graduation. And also, it is important to avoid more theory-based evaluation and moving forward real life conditions could be highly effective. The last mentioned problem was related to the type of questions and scenario that they involved in the examination. As our students state that the questions were designed only based on handy skills, and the level of knowledge, critical thinking, and the ability to communication with the patient were not of importance at all. And they saw that it's not a fair method of evaluation unless we should consider knowledge alongside with handy skills. You can conclude that also OSCE is accepted and valuable method of evaluation. It requires more and more attention to reach a standard and fair policy of evaluation. Using this kind of methods requires revision on education methods, student-centered teaching, and providing required facilities to bring students into a real world of career. Thank you so much. Thanks for having me in this fabulous scientific gathering. It was all, and if you have any question, I'm here.
Yes. Any questions? Any questions to Dr. Yusra? The last speaker of this today's session. Just you are getting compliments from the chat box, madam. That's it. No questions from. Just you are getting a compliments from chat box.
Thank you so much and good night.
Yes. Thank you so much, madam. Thank you very much for participating in this event. On behalf of organizing committee members of Nursing Education 2021, we want to thank you for instant presentation. Looking forward to meet again next time in physical event. So, almost we have left 2 to 3 speakers. That is Dr. Paul, Dr. Katwar will be joining for tomorrow's sessions. As due to some technical problems, they are unable to join today. So, if you go to the conclusion, if you go to the vote of thanks, thank you very much to all the participants, those who joined this webinar on third virtual conference on nursing education and healthcare, which is going to happen, that is 24th today as well as tomorrow, during period having with different time zones. Our most sincere thanks to all the keynote speakers, plenary speakers, students, delegates, journal collaborators, media partners who have joined from different destinations around the globe for their support and cooperation. Let us thank speakers who have responded so well to our invitations to participate in this conference. We have researched several papers which will form the basis of our dimension in these various lessons. Let us thank to all the associating with this conference by your presence. A special thanks to Program Manager Mr. Renaud as well as Ms. Shilpa for his as well as her continuous effort in putting us all together in this one platform in this online event that is September 24th today. If you go to the economic keynote speakers lecturer from Dr. Edil Mattox, Dr. Wilma Wilson, Dr. Pamela Trister, Dr. Catherine, Dr. Rosenberg, Dr. Josephine, as well as session speakers Dr. Alain Nazir, Hardeep Kaur, Awazin, Kia, Maria, Dr. Debro, Dr. Lisette, Dr. Shanti, Gabriel, Cassie Boyd, Fabina, Dr. Cassie, Alnit Jackson. So we have heard as well as few of the delegates from all over the world, delegates participants. If everything goes well in 2022, hope we will join in physical event on same topic, that will be virtual education, for nursing education, either in Europe or in upcoming Dubai. And a special thank to Dr. Catherine M. Grizil for managing whole day for the conference, as you are joining our events since last 2 years from 2019 to 2021, either in online event or in physical event. We are grateful to Madam for encouraging us in these scientific events. I would like to thank to all the participants. Hope we can collaborate in future events in physical as well as virtual event. Electronic certificate as well as electronic booklet will send through email ID within 3 to 4 working days after the completion of the conference. Yes. Finally, we extend our appreciation to each of you for participating in this online events. Tomorrow by the same time we'll be joining this event and completing the second day of the sessions. If you got any technical error for today, please apologize from our side. Thanks again. This is signing off. Bhupati. Just madam, if you have any questions, you can ask. You can mail us officially through email ID. We'll be sending you to all the participants.